Kasama ba? Yan o. Naka-registration yung kado.
Anniversary na kanila.
Yan o. live streaming ko. Sa loob. Teka. Start. Start.
Live stream. Nakaano kasi. Isang ganyan, isang ganito. Kasi papasok ako doon sa webinar na yun. Ito lang, cellphone ko lang. Huwag na yung live.
Nakapasa ka na, sabi ni Dr. Anilio.
Sabihan ko po kayo pag nakapagpasa na ako requirements.
Okay, ma'am, picture para ano.
Minsan nagsisila ng specialist dito. Tumawag ko na lang.
Pero Lasal pa rin.
Sa Lasal.
Okay, thank you.
Ayun na po, sa registration niyo. Papatunggal ko. Opo. Sa lahat ng araw. Meron naman ito.
Picture ako naman kayo, kasama si
Sa registration eh, nasa airfare. Hindi ko
meron pa pala. Wait, sorry.
Pili kayo na ano gusto mo. Yung hello sound.
Ang ganda na ng time for the walk time. Kaya for the walk.
Kala ko nakatingin ka sa akin. Papalit ang battery, lobot na. Meron ako. Hindi, ito camera.
as a person of integrity, responsibility, discipline, patriotism, bayanihan, and malasakit.
Welcome to the first World Day of Regional Anesthesia and Pain Medicine. Under the theme, Joining Hands for a Pain-Free Future Worldwide. This event is hosted by the Regional Anesthesia Society of the Philippines in partnership with Gentri Medical Center and Hospital. The event is also made possible through the initiative of the European Society of Regional Anesthesia. Get yourselves ready as we are about to kickstart this conference, featuring esteemed doctors from both local and international medical scene. Together, let us listen to a series of informative and insightful talks and make sure to participate in our interactive discussions during our hands-on workshops and sessions later. Our first plenary session will begin in a few minutes. We would like to invite everyone to occupy the front seats and a gentle reminder not to bring in any food and drinks to the session hall. Here are some reminders for everyone. Get a chance to win a free registration for the Prague Congress by participating in our funny quiz and competition later on. To all our attendees here on site, stick around until the end of the program and join the hands-on clinical workshops, which will focus on 3 stations: upper extremity, truncal, and lower extremity blocks. Today, we will also be giving away a raffle prize of a 1-night stay at the Acacia Hotel Alabang, courtesy of Wen's Pharma. The lucky winner of this raffle prize will get to enjoy this hotel stay with buffet breakfast for 2 and free use of hotel amenities. We invite all participants to share their experience on social media throughout the World Day using the hashtag WDRAPM. Again, that's hashtag WDRAPM. We also invite all of you to download the event app for a smoother experience, whether you're joining online or via Zoom, or you're joining us face-to-face here at Gentri Medical Center and Hospital. Just scan the QR code you're seeing now on the screen and install our official event app. So make yourselves comfortable as we'll be starting our program in just a short while.
Inside the theater.
Paano ka makikinig ng lecture?
Opo, hindi po allowed sa inside the theater yung food and drinks.
So you're not allowed to bring in the food.
Yes.
Dito lang, kaya
Dito
may mga
po.
ganito. Paano ka makikinig ng lecture? Yung lunch ganun din.
Ay, hindi po may break.
To be a light of hope to others. As a person of integrity, responsibility, discipline, patriotism, bayanihan, and malasakit.
Good morning, everyone, and welcome to the first World Day of Regional Anesthesia and Pain Medicine, under the theme, Joining Hands for a Pain-Free Future Worldwide. This event is hosted by the Regional Anesthesia Society of the Philippines in partnership with Gentri Medical Center and Hospital. The event is also made possible through the initiative of the European Society of Regional Anesthesia. Get yourselves ready as we are about to kickstart this conference featuring esteemed doctors from both local and international medical scene. Together, let us listen to a series of informative and insightful talks and make sure to participate in our interactive discussions during our hands-on workshops and sessions later. Our first plenary session will begin in a few minutes. May we invite everyone to occupy the front seats and a gentle reminder not to bring in any food and drinks to the session hall. Here are some reminders for everyone. Get a chance to win a free registration for the Prague Congress by participating in our funny quiz and competition later on. To all our attendees here on site, stick around until the end of the program and join the hands-on clinical workshops, which will focus on 3 stations: upper extremity, truncal, and lower extremity blocks. Today, we will also be giving away a raffle prize of a one-night stay at the Acacia Hotel Alabang, courtesy of Wentz Pharma. The lucky winner of this raffle prize will get to enjoy this hotel stay with buffet breakfast for 2 and free use of hotel amenities. We invite all participants to share their experience on social media throughout the World Day using the hashtag WDRAPM. Again, that's hashtag WDRAPM. We also invite all of you to download the event app for a smoother experience. Whether you're joining online via Zoom or you're joining us face-to-face here at Gentri Medical Center and Hospital today, just scan the QR code you're seeing now on the screen and install our official event app. So make yourselves comfortable as we'll be starting our program in just a short while.
Sabihin mo rin, that week, Gentlemen will be giving us also additional raffles, surprises for...
Yes, po.
Bibigyan din kami.
Okay po. Yes, po. Inside na po.
We'll start na po with the welcoming.
I mean, yeah. Okay. Good morning, everyone. On behalf of the Regional Anesthesia Society of the Philippines, we would like to extend our warm welcome to each and every one of you joining us today for the first World Day of Regional Anesthesia and Pain Medicine. It is an honor to stand before you on this significant occasion as we officially open the event. Today marks a celebration of advancements in regional anesthesia and pain management, and we are thrilled to have all of you here with us. To welcome us to today's event, let us call on Dr. Numeriano Samar Jr. to open the day. Dr. Samar.
Good morning. Today is the culmination of the week-long celebration of the first World Day of Regional Anesthesia and Pain Medicine, being celebrated across the globe through ESRA, headed by Dr. Eleni Moca, together with its sister societies, AFSRA, ASRA Pain Medicine, AOSRA, and LASRA. Here in the Philippines, in Luzon, we are very fortunate to be one of the 4 city participants, together with Makati, Davao, and Bacolod. We are participating with more than 120 cities from 60 countries across the continents, with a common scientific program aiming in learning, hands-on practice, interactivity, and reflection in between trainees and experts in regional anesthesia and pain medicine. We are very fortunate to be here in Gentri Med, a state-of-the-art and very accommodating hospital in the heart of Cavite, the land of the brave, in the city of General Trias. Today, we will be experiencing surgeries under ultrasound-guided regional anesthesia, lectures on updates and best practices. We will be learning the techniques of the trade from the faculty, who are a mixture of pillars of regional anesthesia in the Philippines and new breed of equally competent specialists that are locally situated in the area and understands the needs and cultural backgrounds of our patients in this community. Together with Philippine Society of Anesthesiologists, Southern Tagalog Chapter, headed by Dr. Rochelle Flor Sevillano, Hospital ng Maynila Medical Center, Anesthesia Department under the guidance of Dr. Anita Ocamposo, Gentri Medical Center and Hospital, headed by Dr. Jerimo Genuino. We in Rasfield, and with our President, Dr. Dalia Arancel, thank you and welcome you to this historic event. To the faculty and facilitators, and to the attendees, thank you for being here today. I hope to be with you until the end of this day-long activity. Mabuhay tayong lahat.
Tuloy lang tayo. Yan. Thank you, Dr. Samar. All of us, all joining each other, our colleagues all over the world, for this very fortuitous day for regional anesthesia. Following Dr. Samar's warm welcome, it is my pleasure to introduce the President of Gentri Medical Center and Hospital, Dr. Jerimo Genuino. Please join me in welcoming him to the stage with a round of applause. In-introduce ko na siya.
They're preparing it po. Siya. So, ano yung heartbeat? Sorry, gaano katagal? Sorry.
Ilang minutes?
Sorry. May mapaplay naman kayo. Where sabi ni Doc? We'll just say after that po yung national anthem. Okay. Apo. They're just waiting for the file po.
Okay.
Apo.
So may file na ba?
Apo. Inaayos na lang
Okay. Do I go?
po. Mag-ready na and then
We can.
Konica Minolta point-of-care ultrasound systems provide the power, IQ, functionality, and ease of use to optimally support bedside ultrasound exams and ultrasound-guided procedures. The laptop design of the SonImage HS2 consists of a 15-inch touchscreen monitor that swivels and pivots. The touchscreen interface and streamlined console can both be customized to specific user preferences. Konica Minolta designs and manufactures a full suite of broadband frequency transducers, which are specifically designed to meet the clinical demands of today's healthcare providers. There are 8 transducer options for the HS2 system. User-defined presets can be customized for specific diagnostic and ultrasound-guided procedures. Ultra Adjust is a one-button optimization of multiple imaging parameters and is controlled by adjusting the depth. This feature is designed to enhance workflow efficiency. Available imaging modes on the HS2 system include 2D, color flow mode, power Doppler imaging, pulse wave Doppler, continuous wave, and M mode. Panoramic imaging can be used to create a stitched anatomic presentation. Post-processing options include trimming, zooming, and measurement functions. Konica Minolta's Simple Needle Visualization, or SNV, is a unique, proprietary software algorithm that visually enhances both the tip and shaft of the needle in bright blue. This feature can be utilized with any of the linear or curvilinear transducers and works for both in-plane and out-of-plane approaches. Wireless network connectivity allows for seamless image transfer and patient information retrieval. Remote Assist is a powerful tool that can be used to remotely assist our customers with technical and clinical applications support. Konica Minolta Point-of-Care Ultrasound provides clinicians with the leading-edge technology and advanced applications designed to empower better patient outcomes. The superior image quality, ease of use, and portability of the HS2 provides the tools needed to make clinical decisions sooner. See beyond your expectations with Konica Minolta Ultrasound.
The miracle of birth is a beautiful moment. Actronex is an anti-fibrinolytic solution for intravenous injection. It is indicated for obstetric and gynecologic conditions such as menorrhagia, metrorrhagia. Don't let uncontrolled bleeding ruin precious moments. Take control with Actronex.
On and on. It just keeps going. On and on. Look at the discomfort it's causing. On and on. Is there no way of controlling this? Put a stop on emesis with Onzet.
When acid levels get out of hand, it's time to call the authority in acid control. Manage gastric acid secretion with Zepson injection. Zefzon injection is a proton pump inhibitor which reduces gastric acid secretion in the parietal cell. Keep gastric acid levels in check with Zefzon injection. For every battle we take on, a strong defense is needed. Trust the armor designed to protect against acid-related disorders. Choose Mepraz. Mepraz is available in 20 milligram and 40 milligram gelatin capsules. For a strong and reliable armor against acid-related disorders, choose Mepraz.
You're not you when you're in pain. Don't let it take you over. Coax the pain out with Coccidia. Coccidia is a non-steroidal anti-inflammatory drug used in the treatment of rheumatoid arthritis, osteoarthritis, ankylosing spondylitis. Coccidia is available in 200 milligram and 400 milligram capsule. When in pain, take Coccidia. It's programmed to take over pain.
When pain and muscle spasm are constricting you, don't wait for it to take over. Counteract it with Norpreksha. Never let pain and muscle spasm take away your spark. Always counteract it with Norpreksha.
In the treatment of acute pain, go to the root of it all. Lock in the target, lock in the relief. Target the root of moderate to severe pain with Dalix. Targets directly the root cause of pain. Achieve rapid relief with Dalix.
For a safe and secure sedation, choose the one with decades of clinical experience. Give your patients Xylem. Xylem 5 mg per milliliter is a sedative and short-acting sleep-inducing drug of pronounced intensity. Always stay confident in giving your patients a safe and secure sedation. Give your patients their much-needed Z's with Xylem.
Biopharma Medical Solutions is an all-Filipino-owned company specializing in the sales, marketing, and distribution of pharmaceuticals and medical devices. Biopharma is proudly composed of experienced sales and marketing professionals with expertise in building brands and fostering client partnerships. We bring value to our clients by offering them high-quality and affordable healthcare products and services. We have provided over 200 hospitals, cardiac catheterization centers, and PET scan centers with the highest quality products and state-of-the-art medical equipment. We are committed to improving the lives of patients and empowering healthcare workers and hospitals through our products and services. From imaging and diagnostics products, we have now expanded into hospital care solutions, orthopedics, oncologicals, and medical devices. We are proud to present the Biopharma product portfolio. OmniHexol is a tried and tested contrast medium for diagnostic imaging and interventional procedures with superior diagnostic efficacy. Omnihexal is manufactured in Korea by Korea United Pharm Incorporated, a multinational and multi-awarded pharmaceutical company reaching over 40 countries worldwide. Due to Omnihexal's excellent safety profile, it has been approved for both pediatric and adult use. Omnihexal is triiodinated, has excellent water solubility, and is less viscous, resulting in better efficacy and minimal adverse reactions. Omnihexal, or iohexol, is the only contrast media approved by FDA for oral and rectal use. It is well accepted by patients due to its neutral and palatable taste. It is less likely to cause GI distress, and it can be used in cases of barium intolerance. Gasless is a complementary product of Korea United Pharm Incorporated for relief of symptoms associated with abdominal gas. Gasless is given to patients in preparation for abdominal ultrasonography, and it is used to prevent colonic bubbles during CT colonography to significantly improve sound transmission. Zon Care is a leading high-tech medical enterprise and medical equipment manufacturer and service provider located in Optical Valley of China. The main products are color Doppler ultrasound system, ECG machine, and patient monitor. Our partnership with
Start the day right through our doxology.
May we request everyone to please rise for the doxology and to remain standing for the Philippine national anthem.
bayan, ang pambansang awit ng Pilipinas.
Kayang makiling, pero sa sinangalan, alam ng puso, sa titik mo'y buhay. Upang hinirang, tuyag ka ng mahiting, sa mandulupin, di ka pasisigil, sa nagatang tutok sa simoy at sa langit ang pagkaw, ay hinatang tudla, tawid sa pagkayang minamahal, ang isang ng matawan mo'y tagumpay na nag-iiging, ang inuwin at araw niya kailan pang ay di matitiging, luman ang araw ng walhabing pagsinta, buhay langit sa piling mo, aming bigaya ng pagkay mag-aaming, ang mamatay ng dahil sa'yo.
We may now please take our seats. It is now my pleasure to introduce the President of Gentri Medical Center and Hospital, Dr. Jerimo Genuino. Please join me in welcoming him to the stage with a round of applause.
Distinguished guests, speakers, RASPIL officers, doctors, colleagues, good morning to everyone. On behalf of the entire GentriMed family, I would like to express my deepest gratitude to the Regional Anesthesia Society of the Philippines for choosing our hospital, GentriMed, as the host venue for the upcoming RASPIL convention, aligned with the celebration of the first World Day of Regional Anesthesia and Pain Medicine. It is with great honor and gratitude that we accept this amazing opportunity. The selection of GentriMed for such an important event is a true testament to our commitment to healthcare excellence. Celebrating a decade of service, we take immense pride in being Cavite's leading medical hospital, dedicated to providing exceptional healthcare services to our country. Our hospital is home to a team of highly skilled and compassionate doctors whose unwavering commitment to patient care is unparalleled. Over the years, we have always tried to offer a wide range of services, always aiming to meet the diverse healthcare needs of every Filipino. GentriMed is equipped with the state-of-the-art equipment, including specialized services such as the 3D mammogram, crucial tool for the early detection of breast cancer among women. Our imaging center features and offers advanced digital X-ray, CT scan, MRI, 3D digital mammogram system with tomosynthesis and stereotactic biopsy, and many more to provide our patient with accurate and efficient diagnostic procedures. In response to the challenges presented to the pandemic, we have further expanded our capacity by establishing a molecular laboratory. These facilities plays a key role in supporting our kababayan in the fight against various viruses, most notably the COVID-19. The addition of this laboratory underscores our commitment to the health and safety of our Filipino people. We are especially proud that GentriMed is now an ISO certified. This recognition reflects our unwavering commitment to maintaining the highest quality standard in the healthcare. This certification serves as a testament to the diligence and commitment of our hospital. GentriMed shares the same passion as RASPIL's commitment to excellence. As enjoined in this awesome learning experience today, we did start as early in the morning. We hope for more collaboration with RASPIL on behalf of the entire Gentri Medical Center and Hospital family. Welcome all of you, RASPIL, on the celebration of the first World Day of Regional Anesthesia and Pain Management here in Gentri. Good morning.
Thank you, Dr. Genuino. Truly, we are very grateful. We are very grateful for your support and guidance throughout this event. Now, I think our esteemed colleagues from around the globe have graciously prepared some messages to share with us. First, let us hear from Dr. Eleni Moka, the President of the European Society of Regional Anesthesia and Pain Therapy. Afterwards, we'll hear brief messages from the presidents of our sister societies who have joined us for this momentous occasion.
Dear colleagues, dear friends, it is with great pleasure, privilege and honor that I inaugurate the first World Day of Regional Anesthesia and Pain Medicine. This is a newly launched initiative of the European Society of Regional Anesthesia and Pain Therapy, co-organized in close collaboration with all our sister societies, ASRA Pain Medicine, AFSRA, LASRA and AOSRA. And on behalf of ESRA, I would like to extend a heartfelt and a very warm welcome to all of you joining us today, to the enthusiasts and the participants on this momentous occasion that is marking the grand finale of the first World Week devoted to regional anesthesia and pain medicine that we all celebrated during the previous days. And I have to admit, I feel extremely proud but also very, very happy to announce that today, on this special day, in 130 cities across all continents, we unite all together, combining our individual strengths and raising our collective voice under the theme Joining Hands for a Pain-Free Future Worldwide. A very warm welcome to all the participating cities in the European territory, to the United States of America, to Canada, but also to all the participating cities in the countries of Latin America, Africa, Middle East and Asia. All of them are hosting on this special day either small face-to-face or country-wide online meetings with local faculty and national experts and under a similar scientific program. And I have to admit, I am fully optimistic that from this year, from 2024 and onwards, the World Day of Regional Anesthesia and Pain Medicine, celebrated the last Saturday of every January, will be the event to start our year for an updated perspective in our fields, showcasing the principal new techniques and highlighting any new developments in the fields of regional anesthesia or pain medicine. At this point, I would like to express my sincere gratitude to the event chair, Dr. Sébastien Bloch from France, and the organizing team from ESRA side. Without you, this activity could have not become a reality. Also, many thanks from my heart to the leaders of all regional anesthesia and pain medicine continental societies, the country coordinators and the city representatives worldwide, as well as the national scientific associations that have embraced our efforts during the preparation of this event. Your enthusiasm and devotion have been truly remarkable. You have been amazing. Without you, we could have not arrived at this point. Also, a special thank you to the local faculty, that today are contributing their expertise, transforming this event into a platform for insightful discussions and shared knowledge. I'm sure you will agree, as we convene, we focus on the vital field of regional anesthesia, recognizing its pivotal role in effective pain management, but also acknowledging it as an important bridge towards global pain relief. What I would like to highlight at this point is that this day is more than an educational and training event in our specialties. It is rather a celebration of collaboration and of a collective commitment to advancing the fields of regional anesthesia and pain medicine. Why? Because together we aspire to build a future where pain is understood, managed, and ultimately minimized, fostering a world of wellness and comfort for all our patients. Thank you from my heart for being a part of this global event. Let's join our hands to create a pain-free future for everyone, everywhere. Welcome to this day of enlightenment, connection, and progress. I'm wishing from my heart to all of you worldwide in every participating city wonderful activities and a great attendance, with the promise to meeting you all in person very, very soon. Welcome again, and thanks a lot for your efforts and your continuous commitment. Enjoy the first World Day of Regional Anesthesia and Pain Medicine in all corners of our world.
Hi, I'm Dr. David Provenzano, and I'm currently the president of Azra Pain Medicine. I would like to thank you for joining the first World Day of Regional Anesthesia and Pain. We are truly excited to work with our sister societies on this event, and we're very appreciative of the leadership of Ezra for setting up this great event. At Azra Pain Medicine, our vision is to relieve the global burden of pain. That obviously cannot happen unless we all work together. I think this event symbolizes the desire of all the sister societies to work together to advance the science and appropriate deployment of regional anesthesia and pain medicine techniques to improve pain control worldwide. We will continue to participate and to push initiatives that enhance education in pain medicine. We truly hope you enjoy this great event, and thank you for joining.
Hi, everyone. From the Latin American Society of Regional Anesthesia, we welcome you to this first World Regional Anesthesia Day. This is a great day for regional anesthesia, but I feel it's a greater day for the world, a demonstration that people from all continents, people from different beliefs and cultures can join, not just to a common list of topics to discuss and to learn, but more important, we join in a common mission and vision. We all care about others. We care about their pain. We all share the will to do something to alleviate someone else's pain. This is the message I see all of you are sending to the world today. We stand together. Thank you for caring, and thank you for being here today. Y a mis hermanos latinoamericanos, gracias por su compromiso y por estar hoy día también. May you all have a great day. Que tengan una gran jornada.
Good evening. On the behalf of the African Society of Regional Anesthesia, I would like to welcome you all for the first week online for World Congress of Regional Anesthesia and Pain Medicine. I'm Dr. Izzat Aziz, the president of the African Society of Regional Anesthesia. In fact, Ezra, the European Society, has taken the lead to organize this with the sister societies. We are so excited in Africa because, as you know, it's so difficult for us to attend conferences abroad for some financial strains on our doctors in Africa. So this is really a great initiative. We are hosting all over Africa, and we are doing live from Morocco, from Algeria, and from Egypt. Actually, in Africa, we're so excited to the point that, for example, in South Africa, we have more than one city, about 6 cities. We have people attending and doing these workshops from all over Africa, from north to south to east and west. I hope you will enjoy the meeting, and I would like to see you soon. Hopefully you will enjoy the day. Thank you.
The member societies of the Asian Oceanic Society of Regional Anesthesia and Pain Medicine are extremely delighted and excited to take part in the initiative of the European Society of Regional Anesthesia on celebrating 27th of January as the World Day of Regional Anesthesia and Pain Medicine, thanks to President Dr. Eleni Moka and Dr. Sebastian Bloch, the chair of the event, for organizing this. And I'm sure this will go a long way in propagating the usefulness of regional anesthesia practice in several parts of the globe. And we in the Asian Oceanic Region and Pain Medicine will share information about regional anesthesia to as many members as possible and make sure they inculcate the habit of using regional techniques in every single surgical patients whom they anesthetize, so that the patient gets the benefit of regional anesthesia in the perioperative period. Thank you so much.
There you have it. We have the messages. We heard the messages from the presidents and past presidents of ESTRA, ASTRA, LASTRA, AFSTRA, and IOSTRA PM. Let's now begin without further ado with our first session today, to be facilitated by Dr. Alda Tangkilid.
Dr. Alda, we give the floor to you. Let us welcome her with a round of applause.
Pleasant good morning to everyone, and I hope that each of us had taken our coffee to give us a little jolt for this morning sessions. So this is the first session of a series of interesting lectures, and let us hear from the podcast a few words from the editor-in-chief of Regional Anesthesia and Pain Management Journal, Dr. Brian Seitz. So our APM journal is usually our go-to journal when we need to learn more about regional anesthesia and pain management. So let us start the podcast, please.
First, I want to say I think the future is really exciting. We have massive growth opportunities because there's so much yet to be figured out in this area. I think it's important that anesthesiologists help define the value of medical interventions that we offer for pain management. And value is a pretty simple equation, but it's also very complicated. So value is equal to outcomes over costs. But the devil's in the details. And so outcomes defined by who? The insurance companies, the government, the hospital, the surgeon, the anesthesiologist, the patient, or some combination thereof, because it's pretty easy to devalue pain medicine interventions or any medical intervention if you change the numerator definition a little bit. And it's also very easy to value something. And there's a subjective component to all this. But what my point is I think for the future to continue to be very, very positive for our community, we have to be at the table and we have to help define the outcomes that matter. And to put outcomes in context, you have to know something about costs. And this is an area that I'm really excited about because we're starting to get some submissions to the journal that are dealing with costs. So the costs are the denominator of that value equation, and costs are also very, very complicated because they could be hospital level costs, government costs, insurance costs, patient costs like premiums and deductibles. So it can be very, very messy. But at some point, we really have to try to understand what costs are factored into the interventions that we offer, because some things may be cost prohibitive, and we need to define that before it's a problem that an administrator, let's say, points it out. Now, historically in regional anesthesia and pain medicine, we focus on outcomes such as pain scores and opioid reduction in the short term, the PACU 12, 24 hours. And I want to say that is still incredibly valuable because when we're comparing new techniques, we need to know what's happening in the immediate perspective, because if we're not making a difference there, it's hard for us to imagine how that's going to do anything downstream. But what I'm hoping for the future of regional anesthesia and pain medicine is that we start to connect the dots to some of these larger outcomes that are very, very important to both patients and the population. Things like the chronification of pain, and we're going to talk about that in a second. Things like mortality, major morbidity, extended lengths of stay, readmission data. And I think that there's a lot of reason to think that the procedures we offer and the interventions that we offer can impact in a positive way on some of these important outcome metrics. And actually at my institution right now, we're looking at the thoracic epidural approach that we use under fluoroscopy in terms of length of stay in abdominal surgery patients. And we're seeing a huge signal in the reduction in length of stay in patients who have epidurals compared to those who don't for the same open procedures. So I think the future's really, really exciting because we are going to be able to, and I think we need to focus on, to some extent, these long-term outcome metrics or more health system-centric metrics. But I do want to stress that there's nothing wrong with studying the immediate experience that a patient has with respect to pain in the perioperative period. That's really, really important because we want to fast track patients that are, let's say, at an ambulatory surgery center. We want patients to have a good experience. That should be celebrated too. All I'm saying is that we need to try to include some more things downstream. And I also want to make a plug for longer term pain management through catheter-based techniques or new pharmaceuticals. The reason why this is important is that if we're going to have a protective effect that's going to be linked up to meaningful health outcomes, the analgesia probably has to last longer than 12 to 24 hours. And I think with ERAS programs and novel nerve blocks, we're going to be able to achieve some of that. But it's important, I think, for the community to think about longer acting analgesia. Now, I think this is a really, really big story because some surgeries like lower extremity amputations are actually associated with a striking high incidence of persistent pain. I've seen ranges between 30 and 85%. And obviously the human suffering and costs associated with the development of chronic pain are absolutely massive. And any ability that we have as a community to decrease the incidence would have large population health benefits. And having said that, of course, the lack of good outcome studies and the lack of agreement on how to measure the outcome has left us kind of in a gray zone. But in the first question about the future regional anesthesia, this is exactly what I'm talking about. We really need to try to focus on some of these type of outcome metrics, because if we can make a dent on population health problems, that's going to really be a legacy gift to the world and to our community. Now, what do we know? We know that a poor patient analgesic experience correlates with the development of new chronic pain. And we know that patient pre-existing factors such as mental illness also predict the chronification of pain. The question ultimately then becomes, and this is for the research community and the clinical community, if we optimize the perioperative pain experience, can we actually mitigate some of these risks? And it kind of has a nice biological basis because unmitigated pain may very well lead to an inflammatory process that essentially primes the peripheral and central nervous system that results in maladaptive neuromodulation. That's what we know as central sensitization. And I love my job as editor-in-chief because I get to work with some of the smartest people in the world around these topics of centralized pain. And this is just an absolutely fascinating area of thought and investigation. There was a somewhat dated systematic review, I think from 2013, in thoracic surgery that compared epidural versus no epidural and did demonstrate a reduction in the incidence of persistent pain with an odds ratio of about 0.33. And that's a pretty large effect size. However, I think most people are familiar with the Dan Sessler study that was published in The Lancet in 2019 that found no difference in chronic pain at 6 and 12 months, comparing paravertebral block and propofol to that of volatile and opioid therapy for women undergoing breast cancer surgery. So there's some mixed information that's already out there. I think the one area with the best evidence is in chronic pain and phantom limb pain after amputation. Brian Ilfeld has published in this area. It has some pretty high quality data showing that amputees have clinically significant reductions in pain in 4 weeks and possibly beyond with regional anesthesia. And what's exciting about that is regional anesthesia is actually underutilized for amputation surgery on a international level, especially in the United States. So that's an area for potential growth and research. In fact, at my hospital, we're working on a quality improvement initiative where we're really intervening early on patients who show up with life-threatening ischemia that may end up in an amputation, and we're trying to advocate for more epidural and peripheral regional anesthesia. So I think that the data is very complex here, and there's a lot of opportunity for further investigations. And I would like for us to be in this area to really try to establish whether or not the things that we do can actually prevent some of this chronification. And I have heard people argue that the patients who develop chronic pain after surgery are kind of biologically earmarked to it. So the correlation that you see with unmitigated pain or poorly controlled pain and chronification of pain is just that. It's a correlation. It's not a cause and effect. And it wasn't like there was something specifically that the anesthesiologist did poorly that resulted in that. Now, that's one view. That's kind of the contrarian view. But I think that we do have to tease out this cause and effect. And my gut instinct is looking at the data that's out there and talking with leaders in this field is that inflammatory priming of the central nervous system during that acute phase is really something that we could potentially intervene on. And I have actually personally witnessed the transition from acute to chronic pain in the clinical world, and it's really scary. And it really made me think that there's something that we should be able to do to help minimize that risk of transition, including ketamine therapies and other interventional approaches. So I'm really curious to get people's thoughts on that in this World Day of Regional Anesthesia and Pain, because this is a very, very robust area of discussion. I look back on my career and I realize that there's so many things, and I've already alluded to this in this podcast, that we don't know. And there's so many opportunities to make people's lives better as a pain physician. And when I say pain physician, I'm referring to both acute and chronic pain management. And so it's very, very clear to me that unmitigated acute and chronic pain has massive health and economic implications, massive. And we can play a role in minimizing those negative implications. You have an opportunity as a young physician to minimize human suffering through a combination of pharmaceutical, procedural, and behavioral interventions. And I think pain medicine allows the opportunity to fully engage in medical decision-making in both the perioperative and outpatient basis. It's almost the complete career. You have interventional aspects, you've got medical aspects, and you have a phase of care that extends out quite a long period of time. And if we want to push things out into the chronification and the chronic pain world, it goes on for a very, very long time. I was speaking to Steve Cohen, who's one of our executive editors, who I think most people know very well, just a brilliant chronic pain physician from Johns Hopkins. And he said that as it stands now, essentially nobody who presents to a chronic pain clinic returns back to work if they're unemployed because of chronic pain. And what an awesome opportunity for us as a community to try to target that and fix that, because work gives people value in their lives and decreases incidence of depression. And I think that if we can figure out a way to improve people's pain to a point where they can actually return to the work and contribute to society from an economic standpoint, that would be a giant coup for medicine. And the young generation has the ability to do that because we haven't been able to accomplish that yet. And I also think that a career in regional anesthesia and pain medicine allows one to be incredibly creative. And I reflect back on my career with the use of ultrasound. That's where I got involved. Image guidance. There was no term POCUS when I started. We had ultrasound machines where you could see the frame rate was so low that the image was shaking. And we started exploring really basic vascular relationships to nerves to help us back in 1999. And everything just kind of took off with some technological advances in the ultrasound machines. But being part of that innovation was so much fun. And there are so many opportunities like this, because I hear sometimes from the young people that, oh, everything's already been figured out. No, absolutely not. There is so much growth opportunity, and you'll have a new image guided system at some point. You will have artificial intelligence to help you. You'll have probably some version of X-ray guidance for a lot of things that you don't have now. So it's a creative, fun time, and there's a huge unmet need in pain medicine, which makes it even more interesting. So everything's on the table, and I think I would encourage anyone to consider a career in this area. So I'll start with the two-part series that was spearheaded by Dr. Michael Barrington on systematic reviews and meta-analyses. He was joined by several amazing co-authors, including Ryan D'Souza, Ananda Zen, Ed Masha, and George Kelly. And this all started when Michael Barrington was actually an executive editor with us at RAPM before he went to Anesthesia and Analgesia. We struggled with some of the quality of the submissions to the journal when a systematic review meta-analysis was being performed. And the reason why quality is so important in this area is because systematic reviews and meta-analyses actually drive clinical policy in best practice advisories. And if you get it wrong at the systematic review level, things are going to go wrong downstream, and that's going to actually impact on direct patient care. And so since both Michael and I were kind of type A people, we really wanted to get this right. And so we put that team together to try to set the standards for pain medicine about how we want these systematic reviews and meta-analyses to look. And then Michael got offered the spot to work with Anesthesia and Analgesia, and we just built a great relationship and said, why don't we make this as a joint venture between the two journals and get kind of both editorial boards to sign off on it, and it'll have an extra, kind of like legitimacy, and when it's endorsed by two important journals. And so so it all came together. It was a long project, and it's now available. And it's a wonderful guide for all people at all levels looking to produce one of these type of papers. And we have a part one, which is kind of an introduction to some of the key concepts, and then a part two, which really goes into detail into some of the advanced techniques of doing these types of investigations, such as meta-regression and network meta-analyses that are very, very complicated. And a huge shout out to George Kelly. He's one of our editors specifically for systematic reviews and meta-analyses, and he's added a high level of quality to our reviews. So I really, really encourage people to check this out, share it with your students, print it out, put it on the wall, because it has a wealth of information. Okay, so now the next one that I picked was a study that was published by Dr. Wan and colleagues from the Thomas Jefferson University in Philadelphia, and it's the real-world study of intranasal ketamine for use in patients with refractory chronic migraine. It was a retrospective analysis, and what I wanted to mention to the listeners of this podcast is that RAPM supports all different types of study designs. We want randomized controlled trials because that's the gold standard when you're looking at interventions. But the reality is there's a lot of really good real world pragmatic data where we can learn about the therapies we're actually delivering currently. And what's really cool about this study is that it was an off-label use of ketamine, and I believe oral ketamine is available in Europe, and I could be wrong about that, but it's really not readily available in the United States. And so some changes have occurred where it's becoming more available. And this population of patients that's chronic refractory migraines, they're in really, really tough shape. It's actually a desperate situation where all therapies have failed. And so if there really is an outpatient approach that will help mitigate some of their suffering, that's a big story. And it brings up a lot of issues of addiction medicine. Is it safe to do this? So getting some entry-level data about a practice was really exciting to us. And they looked at 242 subjects. There were 160 women in the study, and they had an average age of 44. They reported a median intercontinental range of 30 monthly headaches. And I just thought that was just a absolute massive number. And so I think I would like everyone to kind of check out this study and kind of see how they kind of put this together, because it's a wonderful opportunity to kind of mimic that methodology for someone who has real world pragmatic data. So you really want to kind of check out that study and let me know what you think. Now, the third study, which I think is just incredibly important, isn't really a study. It's more of a guideline statement. And one of the things that we see in terms of our citations in the journal is that guideline statements tend to just do really, really well for the journal. Impact factor of a journal is important. It's not the only thing that matters. We're mission driven, so we'll support publications that will not necessarily contribute to the impact factor, like education articles and some editorials. But there are times where everything aligns perfectly, where we get an article that is super clinically relevant. It has the teeth of a society to really back the recommendations, and then we get all the citations. And this is the case with the ASRA Pain Medicine Consensus Guidelines on the management of perioperative patients on cannabis and cannabinoids. And this is a huge topic, particularly in the United States, because we have this weird world where the use of these drugs tends to be illegal on a federal level, but state by state differences exist, and research is somewhat limited because of that fact. And the other reality is that that patients are coming in on these drugs for elective surgery, for emergency surgery, and there are a lot of health implications of using cannabinoids in this setting. And it's kind of the Wild West right now, what things were happening from a policy standpoint, let's say at an ambulatory surgery center. And this guideline provides a really nice educational overview of some of the physiology and pharmacology of the drugs, and also some of the specific clinical concerns that stem from the use of this drug, especially in the acute setting. And so people are using this to kind of formulate their own hospital guidelines and procedures. And I feel really good that the journal could help support that. And I really want to thank the ASRA Pain Medicine Guideline Committee for really seeing this thing through. So we have a really good product here. So check that out if you haven't seen that. And then of course all the other studies, we have a bunch of RCTs, and we have quality improvement studies, and we've got some really cool case reports. So it's been a good year.
Hello. The floor is now open for any reactions or questions. Anyone? Okay, since there are none, so as Dr. Seitz have mentioned, there is so much more to learn and explore in regional anesthesia, and so I hope we can all develop our passion in this specialty, regional anesthesia and pain management. And we thank Dr. Seitz for his words of encouragement. Actually, he is encouraging us, especially the younger generation of anesthesiologists, to have passion in this field. And he wants us to be responsible for alleviating and making the lives of our patient better. And we thank you, Dr. Seitz, for the encouragement. And I hope that your words and works will inspire and motivate each of us to explore and learn more in the field of regional anesthesia and pain management. So again, thank you, and we look forward to more interesting series of lectures. Thank you.
And that ends our first session for today. Thank you so much, Dr. Alda Tangkilit, for facilitating that portion of our program. And thank you as well to our speaker for the first session, Dr. Brian Seitz. For our next session, we'll be delving into the journals that made a significant impact in the field of regional anesthesia and pain medicine in 2023.
Our moderators for today's discussion are esteemed experts in the field, Drs. Lyris Gonda and Dr. Richard Genuino. They will guide us through the noteworthy publications, providing insights and perspectives that you won't want to miss.
So, whether you're a seasoned professional or just starting your journey in anesthesia and pain medicine, this is the perfect opportunity to stay updated with the latest research and discoveries. Sit back, relax, and let's dive into the journals that made waves in 2023. Without further ado, let's hand it over to our moderators, Dr. Lyris Gonda and Dr. Richard Genuino.
Good morning, colleagues. Today we have the privilege of being in the presence of a very skilled anesthesiologist in the field of regional anesthesia. Dr. Michael Ronald B. Madarang, a charter member of RASFIL, is a graduate of UST Faculty of Medicine and Surgery. Likewise, he chose the same institution for his residency training in anesthesiology. From 2003 to 2006, he was recognized multiple times for his outstanding performance in the in-service exams for senior residents. His senior year research paper, The Effect of Levobupivacaine on the Extrinsic and Intrinsic Pathways of Coagulation, was accepted for presentation at the First Asian Australasian Congress of Anesthesiology in Singapore, 2006. During this time as well, serving as the team captain, UST won second place for the 2006 Tagisan ng Talino. In 2009, under the guidance of Dr. Noel Aipa and Dr. Samantha Claire Braganza, he became a preceptor associate for ultrasound and nerve stimulator-guided peripheral nerve blocks. Dr. Madarang continued sharing his expertise in regional anesthesia in the following years, and in 2019, he obtained a higher course in regional anesthesia from Montpellier University in France. Despite his engagement and busy schedule to PSA as a member of the Board of Directors from 2016 to 2018, and as head of the Tagisan ng Talino Committee from 2016 to 2017, Dr. Maderang was able to join the local clinical faculty of ultrasound-guided peripheral nerve block workshops in the ISURA and AOSRA Convention and the Dinosaura Asia RA workshop. His expertise also rendered him to be the founding chair of the section of orthopedic anesthesia in UST. From 2009 to 2015, he became an anesthesia provider in multinational shoulder arthroscopy workshops by Dr. Albert Molano. Dr. Maderang also served as the department training officer, vice training officer, and interim OIC from 2018 to 2020, and as the department secretary and member of the Credentials and Privileging Committee at present. Today, he will be sharing his insights on gastric ultrasound and erector spinae blocks and how it can help us deliver safe and quality anesthesia. Please join me in giving a warm welcome to the exceptional Dr. Michael Ronald B. Maderang.
Thank you very much, Dr. Gonda. That was quite an introduction. I hope that I will be able to live up to the expectations. So for this afternoon, I was tasked to deliver a short lecture on the journals that made an impact last year. Please take note that these are only my personal opinion. Maybe you have read your own journals and maybe those journals made an impact on you. But for me, these are the two journals that made a huge impact in 2023. Now, just a caveat though, when the topic was given to me, I read journals from 2023, but as a habit, I continually browse, and I found some journals, more recent journals. So these are journals, 2024 journals already, January 2024, fresh off the press. Hindi pa na pa-publish, but for this morning, I will be presenting it to you, as these are auxiliaries to what I was supposed to be presenting. Okay, the first journal I'll be presenting is on gastric volume and antral area in the fasting state, a meta-analysis of individual patient data. This has been submitted for publication last year at March, and was accepted for publication about 2 weeks ago. Now, what makes this journal so relevant? First, because for the longest time, at least in our local setting, ultrasound use has been confined to peripheral nerve blocks. I think it is about time. The push for the past almost a decade now has been that anesthesiologists must be perioperative physicians. We're not confined to the operating room, and as experts supposed to be in ultrasound-guided peripheral nerve blocks, it's about time that we expand our horizons and do ultrasound guidance perioperatively, and this includes using ultrasound preoperatively. Okay? And this would pave the way to modernizing some concepts, such as the fasting states, because I think up to now we are still using the 8-hour fasting guideline for solids, or some institutions use the 6-hour fasting guidelines, and then for liquids 2 hours. I think it's about time that we use the ultrasound so that we can objectively measure whether a patient is indeed fasted enough to be operated on or not. Now, it is also clinically significant because in recent years, there's been a spate of users of Ozempic, mga nagpapapayat, and Ozempic has been found to decrease gastric motility, such that even if the patient has been fasting for 12 hours, 10 hours, once you check on their gastric contents, mayroon pa rin laman pagkain. Those who take Ozempic, mga nagpapapayat. Okay? And there has been a special subgroup of patients. When you do pre-op rounds on the patients, minsan you have to ask, especially if he or she fits the profile, nagtitake po ba kayo ng Ozempic? And if she or he says that uminom siya ng Ozempic in recent years, recently, then you have to be especially suspicious that his or her fasting might not be adequate. And this is where the use of the focused ultrasound for gastric contents comes in. Next is also, of course, we all know that diabetics don't exactly fit the normal, the way gastric motility works. Okay. Pwede pa yung slide masyado yata malaki para sa... Anyway, it is a meta-analysis. The researcher did a meta-analysis of cases done from 2009 to 2020, and a total of 120 research papers were included. And they found, they wanted to find out if there is a particular cutoff value, like when you do ultrasound on the abdomen and look for the antrum, what exactly, how distended must an antrum be before you say that, oops, the patient is not well fasted, is not fasted enough. Okay? And that is what they tried to find out using this meta-analysis. So they have something objective. So once you see that the antrum of the stomach is so-and-so dilated or distended, and we have to wait a little bit more, and then check again. If it has reached that level already, that volume, then pwede na siyang operahan. It's looking for the superior limit already. Okay, here, using gastric ultrasound. Okay, placing the ultrasound probe subxiphoid. And you're looking for, this is what we're looking for, the gastric antrum. Here, this is what a fasted gastric antrum should look like. It's like a small walnut. Now, the authors recommend placing the patient on side lying, because if the patient is supine, then if there's any liquid or solids, then you might not be, you might miss it kasi naka-flat on bed. So the authors recommend a right-sided, right-lying ultrasound, doing the ultrasound with the patient on the lateral decubitus. This way, if there are any fluids, makikita mo yung air fluid level. Okay. So here is here's the image, and this is the antrum. You'll be able to notice a fluid level if there is something inside. Okay, so again, this is what a fasted antrum looks like. Okay, this is a gastric antrum of a patient who has just drank soft drinks, so fizzy. So makikita mo yung mga bula-bula. Also this one. And this is a gastric antrum of a patient who just ate solid foods. Okay, so you can see the impact of ultrasound guidance in determining the fasted state of a patient. We will know immediately kung talaga bang nag-fast yung pasyente. Kasi some patients, they, just for want of gusto nila matuloy yung operation, they sometimes lie about their fasting. Say, kumain pala sila a few hours before. Then we'll be able to see objectively, meron tayong proof na may laman pala yung tiyan niya. Okay? Now, their conclusion was, based on their meta-analysis of their 120 journals, is that a 10 square centimeter, here, an area of 10 square centimeters can be the upper limit already. So if you see that the patient's antrum is already 10 square centimeters, then maybe pasado na siya, pwede na siya maoperahan. Okay. There are some limitations. But for me, this journal that is about to be published made an impact for me because it paved the avenue for the use of ultrasound beyond the operating room. Next. Okay. Next is a journal that's recently released by Dr. Manoj Karmakar. It is about the erector spinae block. Since 2016, the erector spinae block has been used and has been widely used for many surgical indications. And some attest by it, and some say it doesn't work as well. And Dr. Manoj Karmakar has sort of laid out the cards. He says that I thank you very much. He says that the ESPB is not useful for thoracic analgesia. So he calls a spade a spade. Okay? And then as a corollary to what he initially mentioned, that an explanation given by ESPB advocates might just be wishful thinking. Okay, so this was published a few months back, about 6 months ago, and this is a follow-up on his previous publication. Now, why does it make an impact? First, because it put things in a different perspective. So, like, as I mentioned earlier, since the erector spinae block was introduced in 2016, many people stand by it. And there has been some controversy. So there has been gray area. Sometimes it takes, sometimes it doesn't. Most of the time, the image quality is good. And then some would explain away that kasi hindi kasi maganda yung spread, ganun. Now, as I mentioned earlier, Dr. Karmakar calls a spade, and he says, no, erector spinae block is not perfect. It's not a perfect anesthesia for thoracic surgeries. What else? It opens up channels for discourse. Now, not just an ordinary discourse, but intellectual discourse. Because he cites, Dr. Karmakar cites several reasons, physiologic and even up to the cellular level, why he thinks that ESPB block is not ideal for thoracic surgeries. And eventually, through this discourse, a clear understanding of the present concepts, anatomical concepts, might be arrived at in the future. Okay, this is what Dr. Karmakar mentions. The effect of the erector spinae block on the dorsal ramus is not disputed. Okay, Dr. Karmakar agrees that the erector spinae block has an effect on the dorsal root. However, its effect on the ventral ramus is what remains questionable. Okay, that's what his contention. Now, he cites as an example, it is erector spinae block on breast surgery. It reduces pain and 24-hour consumption compared to placebo. However, according to Dr. Karmakar, it is only marginal and probably not clinically relevant. So, strong words from Dr. Karmakar. In contrast, if you do a thoracic paravertebral block for breast surgery, then this does indeed provide, unquestionably, it does provide anesthesia and analgesia. Okay. Now, the purveyors of the erector spinae block offered a possible explanation. They say that kaya daw nagkakaroon ng preferential blockade is because using 0.2%, a low concentration of local anesthetic, it preferentially blocks the C fibers, smaller fibers first, the small unmyelinated fibers first. So that's why there is preferential blockade. Sometimes the patient still feels pain, and sometimes the patient, the block is good. And that is their explanation, because of the preferential blockade. And this is what prompted Dr. Karmakar to write his follow-up journal. Differential blockade to explain the anterior thoracic analgesia without sensory blockade might be wishful thinking. So may pangontra siya kaagad. So someone proffered an explanation, and Dr. Karmakar provided a counter explanation. Okay, he mentions that the mechanism which produces anterior thoracic remains subject of controversy. Okay, he says that this evidence cannot be attributed as the presumed effect of ESPB. There is not enough evidence to prove. For now, it remains a theory. And as a theory, it doesn't hold much water, according to Dr. Karmakar. Just simply saying that it preferentially blocks smaller fibers without any scientific explanation or scientific evidence, this cannot be used as an argument for erector spinae block. So yun yung counter-argument ni Dr. Karmakar. Little technical difficulty. Next slide, please. Okay, so according to him, thoracic paravertebral block still remains a good standard for thoracic analgesia, and it is, we have to admit, it is in fact superior to erector spinae block and provides more consistent results. Next slide, please. Now, whereas thoracic epidural block protagonists say that it is simpler to do, has a wider margin of safety because you don't have to pierce near the pleura, and it is effective. Clinically, personally, in my practice, I have noted that erector spinae block is indeed effective, but I also do concur that it is not as consistent as doing a paravertebral block. And there are varying degrees of consistency. Some would say, yes, patok yan, the best yan. Whereas the other population would say, medyo, okay lang. Okay? And the explanations for this inconsistency does not hold much water. Next slide, please. Now, it is exciting at this point, since kaka-publish pa lang it is exciting at this point to wait and see what proponents of erector spinae block would say about it. What other explanations would they give? How would they defend the erector spinae block? That is what I'm looking for. This is why I said that this journal started it all. It's the pebble that caused the ripple. And I'm waiting to see how the ripple turns out. And next slide, please. Okay, thank you very much. It's a short lecture only. If you have any questions, you may email me at these email addresses. Thank you.
Thank you very much, Dr. Madarang. Those journals are very interesting, especially for the residents. I know we have residents here today, no? So personally, I experienced that, having patients, outpatients, who come in the OR, they say they fasted, but then in the end, they really did not. So I think that journal is very nice. And also the ESP block po. Can we now open the floor for questions? Baba na lang ako dyan para... So Dr. Madarang can answer our questions. Sige, pipili tayo. Yes po, Dr. Anita So. Good morning po, Dr. Thank you for initiating the first question po.
Good morning, Dr. Madarang.
Good morning, Dr.
My question is on the first journal about the gastric volume, no? Now that we have the ultrasound to guide us on the gastric volume, will our practice of anesthesia technique and patient care change? Like, for example, for patients who are emergency cases, like if you have a ruptured ectopic pregnancy, where you have already too much of your hemiperitoneum. So what will be the impact now on our anesthesia technique?
Thank you for the question, Dr. So, that's what I'm excited about with these new developments in ultrasound guidance outside the operating room, beyond peripheral nerve blocks, because its applications have just now been recently realized. As we all know, there's a POCUS group which travels around the country and encourages anesthesiologists to do POCUS, including this gastric ultrasound to find out if the patient has indeed fasted or the fasting state of the patient. I wouldn't say it is at its infancy stage anymore because it has been around for more than 5 years, if I'm not mistaken. But unfortunately, its popularity has not really kicked in yet. I don't think many institutions have taken it into their practice yet, which is why, again, I'm excited that this such journals have been already published, and I hope that other anesthesiologists would be encouraged, especially those who practice ultrasound-guided regional anesthesia. They'll be encouraged to go outside their comfort zone and start doing ultrasound guidance on other parts of the body for development of anesthesia practice.
Thank you po, sir. Thank you po, Dr.
Thank you.
Thank you po. Sino pa po may questions? Any questions po from the back? Sa center po and sa front. Any questions po? Sige, ako po. Meron, sir, pwede po kaming humingi ng tips for our residents. How can they improve their learning curve for the gastric ultrasound? Is it better for them to start on elective surgeries just to familiarize themselves first with scanning and all that? Or is it more beneficial if they go on to emergency cases po?
As far as learning curve is concerned, the best way to increase, to steepen the learning curve is to do ultrasound, whether it's elective, whether it's emergency, or I might even recommend that they do ultrasound on themselves. If ultrasound is available, then use the ultrasound. Mag-scan kayo sa sarili ninyo. That's why it's there. Habang wala pang pasyente. It's while it's still easier to use and easier to learn, rather than pag nandiyan na yung pasyente, saka pa lang kayo matututo, saka pa lang kayo mag-aaral. So while there is no patients yet, I would recommend that you do your scanning. Maghanap kayo ng volunteers, bayaran nyo na or pakainin nyo ng breakfast, or bayaran nyo ng konti, then you do the scanning. That way, the learning curve steepens and you learn faster.
Thank you, sir. Thank you po. At this point, are there any more questions? I guess wala na po. Thank you so much. Thank you, sir, for the very wonderful lecture and very educational journals. Thank you po.
Thank you so much, Dr. Lyris and Dr. Lyris, for facilitating our second session for today. And of course, thank you to Dr. Michael Ronald Madarang for the insightful talk. We were discussing at the back that I do it on patients on semaglutide, just to make sure that nothing's in nothing in their stomachs. And then you can do it on your own and try to see how your breakfast affects your gastric volume.
Yes, the before and after photos.
Yeah. Now, but we hope all of you have been enjoying our enlightening session so far. As we take a break to recharge and refuel, we've got a little treat for you.
That's right. It's time to kick back, relax, and indulge in a well-deserved coffee break. Whether you're joining us from your home office or bustling conference venue, take a moment to savor the flavor of your favorite brew.
To our on-site guests, you may also enjoy some snacks and pastries outside at our buffet setup. We'd like to remind everyone to please do not bring the food inside the theater. We are not allowed to eat inside. We'll see you again in around 10 minutes. Thank you very much, everyone. Also have a photo booth set up near the elevator area for those who want to document their attendance in today's event.
Biopharma Medical Solutions is an all-Filipino-owned company specializing in the sales, marketing, and distribution of pharmaceuticals and medical devices. Biopharma is proudly composed of experienced sales and marketing professionals with expertise in building brands and fostering client partnerships. We bring value to our clients by offering them high-quality and affordable healthcare products and services. We have provided over 200 hospitals, cardiac catheterization centers, and PET scan centers with the highest quality products and state-of-the-art medical equipment. We are committed to improving the lives of patients and empowering healthcare workers and hospitals through our products and services. From imaging and diagnostics products, we have now expanded into hospital care solutions, orthopedics, oncologicals, and medical devices. We are proud to present the Biopharma product portfolio. OmniHexol is a tried and tested contrast medium for diagnostic imaging and interventional procedures with superior diagnostic efficacy. OmniHexol is manufactured in Korea by Korea United Pharm Incorporated, a multinational and multi-awarded pharmaceutical company reaching over 40 countries worldwide. Due to OmniHexol's excellent safety profile, it has been approved for both pediatric and adult use. OmniHexol is triiodinated, has excellent water solubility, and is less viscous, resulting in better efficacy and minimal adverse reactions. OmniHexol, or Iohexol, is the only contrast media approved by FDA for oral and rectal use. It is well accepted by patients due to its neutral and palatable taste. It is less likely to cause GI distress, and it can be used in cases of barium intolerance. Gasless is a complementary product of Korea United Pharm Incorporated for relief of symptoms associated with abdominal gas. Gasless is given to patients in preparation for abdominal ultrasonography, and it is used to prevent colonic bubbles during CT colonography to significantly improve sound transmission. ZonCare is a leading high-tech medical enterprise and medical equipment manufacturer and service provider located in Optical Valley of China. The main products are color Doppler ultrasound system, ECG machine, and patient monitor. Our partnership with ZonCare allows us to provide state-of-the-art ultrasound systems such as ZonCare N7, a full digital color Doppler ultrasound system. We also offer ZonCare's high-end portable 3, 12, and 18-channel ECG machines, iMac 12, a tablet ECG machine that was a 2016 Red Dot awardee, and a multi-parameter patient monitor. Perlove Medical is a large-scale and influential manufacturer with high-tech imaging equipment, R&D, production, sales, and after-sales service. Their comprehensive product range includes imaging systems and related instruments, ventilators, anesthesia systems, and veterinary products. Our partnership with Perlove Medical allows us to provide our clients with intelligent, humanized comprehensive medical imaging solutions that are multifunctional, highly efficient, and with low dosage. The product line covers a series of flat-panel digital radiography system, surgical C-arm series, and mobile digital X-ray systems with advanced digital imaging technology, producing sharp and high-quality images. Chison Medical Technologies Company is one of the world's leading manufacturers for ultrasound systems certified by CMD, CE of Europe, FDA of US, CSA of Canada, KFDA of South Korea, and other international bodies. Biopharma is proud to offer Chison Sonowai, the lightest handheld ultrasound with the fastest response speed that delivers high-quality imaging and provides a flexible connection with a smartphone or tablet. ANDI, or the Automatic Needle Destroyer by Mune, is an award-winning syringe disposal system that is compact and easy to set up and use. Partnership is always at the core of the biopharma business model. We have consistently supported various medical societies through booth exhibits, continuing medical education, and scientific sessions. For 2 consecutive years, Biopharma was given the Best Exhibitor Award by the Philippine College of Radiology. In a highly competitive industry, establishing trust and integrity is a must. Biopharma believes in its greatest asset, its people. Apart from its innovative products, the strength of Biopharma lies on the talent, dedication, innovation, and expertise of its competent workforce. Biopharma has evolved into a strong healthcare partner and a gateway of products from both international and local companies. With ultimate service in mind, Biopharma shall continue to uphold its credo, a shared commitment to quality healthcare by providing high-quality and affordable healthcare products and services everywhere in the Philippines.
The miracle of birth is a beautiful moment. Actronex is an anti-fibrinolytic solution for intravenous injection. It is indicated for obstetric and gynecologic conditions such as menorrhagia, metrorrhagia. Don't let uncontrolled bleeding ruin precious moments. Take control with Actronex.
On and on. It just keeps going. On and on. Look at the discomfort it's causing. On and on. Is there no way of controlling this? Put a stop on emesis with Onzet.
When acid levels get out of hand, it's time to call the authority in acid control. Manage gastric acid secretion with Zepson Injection. Zepson Injection is a proton pump inhibitor which reduces gastric acid secretion in the parietal cell. Keep gastric acid levels in check with Zepson Injection. For every battle we take on, a strong defense is needed. Trust the armor designed to protect against acid-related disorders. Choose Mepraz.
Mepraz is available in 20 milligram and 40 milligram gelatin capsules.
For a strong and reliable armor against acid-related disorders, choose Mepraz.
You're not you when you're in pain. Don't let it take you over. Coax the pain out with Coccidia. Coccidia is a non-steroidal anti-inflammatory drug used in the treatment of rheumatoid arthritis, osteoarthritis, ankylosing spondylitis. Coccidia is available in 200 milligram and 400 milligram capsule. When in pain, take Coccidia. It's programmed to take over pain.
When pain and muscle spasm are constricting you, don't wait for it to take over. Counteract it with Norpreksha. Never let pain and muscle spasm take away your spark. Always counteract it with Norpreksha.
In the treatment of acute pain, go to the root of it all. Lock in the target, lock in the relief. Target the root of moderate to severe pain with Daleks. Targets directly the root cause of pain. Achieve rapid relief with Daleks.
For a safe and secure sedation, choose the one with decades of clinical experience. Give your patience Xylem. Xylem 5 mg per milliliter is a sedative and short-acting sleep-inducing drug of pronounced intensity. Always stay confident in giving your patients a safe and secure sedation. Give your patients their much-needed Z's with Xylem.
A light of hope to others. As a person of integrity, responsibility, discipline, patriotism, bayanihan, and malasakit.
Good morning, everyone, and welcome to the first World Day of Regional Anesthesia and Pain Medicine under the theme Joining Hands for a Pain-Free Future Worldwide. This event is hosted by the Regional Anesthesia Society of the Philippines in partnership with Gentri Medical Center and Hospital. The event is also made possible through the initiative of the European Society of Regional Anesthesia. Get yourselves ready as we are about to kickstart this conference featuring esteemed doctors from both the local and international medical scene. Together, let us listen to a series of informative and insightful talks and make sure to participate in our interactive discussions during our hands-on workshops and sessions later. Before that, here are some reminders for everyone. Get a chance to win free registration for the Prague Congress by participating in our funny quiz and competition later on. To all of our attendees here on site, stick around until the end of the program and join the hands-on clinical workshops, which will focus on 3 stations: upper extremity, truncal, and lower extremity blocks. Today, we will also be giving away a raffle prize of a one-night stay at the Acacia Hotel Alabang, courtesy of Wen's Pharma. The lucky winner of this raffle prize will get to enjoy this hotel stay with buffet breakfast for two and free use of hotel amenities. We invite all participants to share their experience on social media throughout the world using the hashtag WDRAPM. We also invite all of you to download the event app for a smoother experience, whether you're joining online via Zoom or you're joining us face-to-face here at Gentri Medical Center and Hospital today. Just scan the QR code you're seeing now on the screen and install our official event app. Make yourselves comfortable as we'll be starting our program in a short while. May we request everyone to please settle down as we will be restarting the program in 3 minutes. Again, may we request everyone to please settle down to the theater as we will continue with the program in 3 minutes. Thank you very much. Good morning. May we invite all our delegates to please re-enter the theater so we can continue with our program. Again, we'd like to invite all our delegates to please go back to the theater and settle down so we can continue with our morning program. Thank you very much. Welcome back, everyone. We hope you've had a chance to recharge with your coffee. Now get ready for an exciting session ahead. We have a distinguished expert in the field who will unravel the intricacies of shoulder procedures. It's time for everything you need to know for shoulder procedures with none other than the incredible Dr. Samantha Claire Braganza.
We're honored to have distinguished experts in the field who will unravel the intricacies of shoulder surgeries. Our next speakers will share their wealth of knowledge and experience with us. From anatomy to the latest techniques, this session promises to be a comprehensive guide for both novices and seasoned professionals in regional anesthesia and pain medicine.
Throughout the presentation, feel free to submit your questions in the chat. We want this to be an interactive experience and your participation is key. We'll have a dedicated Q&A session at the end where our experts will address your queries.
And speaking of interaction, don't forget to connect with us on social media using the event hashtag #WDRAPM. Share your insights, key takeaways with us.
Now, without further ado, let's dive into everything you need to know for shoulder procedures with our session chair, Dr. Dean Arvin Agbon. Dr. Dean, take it away.
Good morning, everybody. Welcome back to our session. This morning, let me introduce our next resource speaker. She has been both resource speaker and moderator and sharing her knowledge in regional anesthesia for multiple local conferences held by the Philippine Society of Anesthesiologists and the Manila Academy of Regional Anesthesia. Actually, she was, as a resident, she inspired me to take up regional anesthesia when she performed the workshop at the institute where I did my residency training at the East Avenue Medical Center. Dr. Braganza is a regular attendee of international conferences and workshops held by the International Symposium of Ultrasound, Regional Anesthesia UK, American Society of Regional Anesthesia, and the European Society of Regional Anesthesia. She is affiliated with the following hospitals: the University of Santo Tomas Hospital, St. Luke's Medical Center, Global City, and the Cardinal Santos Medical Center, to name a few. Please join me in welcoming our resource speaker to lecture on regional anesthesia for shoulder surgery, evidence-based practice, Dr. Samantha Claire Martin Braganza.
Thank you. Ikaw pala yung doc. Tagal na nun. Yeah. So, good morning, everybody. I hope that you were able to wake up a little. I don't really plan to take much of your time today. Hold on. Let me know when game na. There. So, good morning. This is where I work. I work at St. Luke's Medical Center, Bonifacio Global City. Here at SLGC, we do about 9,000 surgeries a day, a year, and then I am part of the regional anesthesia team who runs about 12 to 15 block lists in a day. We just graduated 2 regional anesthesia fellows, namely Iris and Carlo, and they're doing pretty well in their regional anesthesia profession. So I have a few spoilers. This is where it all started. No, not the love affair, but it all started in 2008. Where we do a lot of shoulder surgeries at the University of Santo Tomas. Quarterly, we do invite people to come over to our hospital to view the perioperative management of these patients. No? So I guess I know that for the past 5 years, I've been known to love fascial plane blocks, but to tell you the truth, it's ISB that I am first in love with, because it makes me happy when I see patients at the PACU after having shoulder surgery. Then they are so comfortable. Many of them would like to go home the same day. We are able to discharge them the same day. So it gives you that different, unique experience or satisfaction. So for today, we are going to talk about why we would block the shoulder, the spectrum of surgery and the anesthetic considerations, a short anatomy, because I do not like to study anatomy also. And I wouldn't want to put you to sleep. And the optimal techniques that we can employ for these types of surgeries. So this is the third disclaimer, actually. Not all shoulder surgeries are the same. So it can be, you cannot find this anywhere, but I tried to, from experience, just put them into each of the categories. No? So you will have the symptomatic. Most of the time, these patients are non-surgical, but they are in so much pain. These are the women. Well, studies show that women are more prone to adhesive capsulitis, primarily because of the hormones. No? So hormonal, you'd get a lot of female patients undergoing arthroscopic shoulder surgeries as well. Now we go to the pathologic. The pathologic part, it encompasses many patients, many patient profiles. These can be the athletes, the gym, the gym buddies, nag-kettlebell siya na mali yung those who want. We had a lot when Heidelin was champion. We had a lot of patients. And then you also have the elderly ones who would fall, who would tear their rotator cuffs, etc. No? So it's important for you to be able preoperatively to tailor it accordingly. No? Your anesthesia should be tailored according to the profile of the patients that you are going to have the surgery with. So, why block shoulder surgeries? I'm sure all of us, not only shoulder surgeries, but for any regional anesthesia, multimodal technique that we employ, we all very know of the positive results from our point of view. No? So we very well know that it decreases acute pain, and the chronification would be blocked as well. In the long run, you'd have lower post-operative nausea and vomiting because you give less opioids. In the long run, higher quality of recovery. Patients feel satisfied more because they're able to continue their life more. Athletes can get to their usual activities as before. We now discharge them for home as outpatients. They do facilitated lesser hospital stays, and of course, the overall value-based care. So we contribute to that as well. That is from our perspective, the anesthesiologist perspective. But it's not uncommon, di ba, that you'd see this eyes from these surgeons. Arthroscopic. Maliit lang, di masakit. Huwag mo block. Ano, what block? What block are you talking about? Do not block. Kasi sandali lang ako dito. 4 to 5 incisions, small incisions, patients would go home with Band-Aids. Why do you have to block? No na. So, I'm sure it's every day, deal or no deal. In Global City, we call it block or no block. Because we get the patient's consents. It's always a shared decision, remember. So when you explain the anesthesia, you give all the options. And one of the multimodal part of that is giving out regional anesthesia options. Now, yes, papayag yung patient, papayag ka, available ka, but the surgeon, no block. It's 5 incisions, 30 minutes. No na. Okay, so it's always this way. I'm sure it's not too uncommon for you to see these types of patients, no? So, why is it important for us to do that intervention intraoperatively? And this video tells us why, no? So, yes, small incisions, but then your surgeon needs to infuse fluid inside the joint so that the joint will become distended. He'd be able to see the tear. He'd be able to have a little space for the repair. Almost always your surgeons would have this type of machine. It's called an arthroscopic pump, which pushes in a certain pressure with epinephrine to keep the bloodless field. And mind you, now with the pressure that the machine is generating, it absorbs, the joint absorbs about 25 cc every 5 minutes. So 25 cc times 30 minutes lang ako, promise. With this type of machine, with this type of pump, some surgeons pala, by the way, would use just gravity. But then your joint will still get imbibe some more fluid pa rin in there, no? So, you see, from the beginning till about 80 minutes, total operating room time, we've infused about 32 liters of fluid. The distension per se is what's mostly causing the pain immediately post-operatively, okay? Now, we have several other intraoperative factors that your surgeons would be needing as well. There's the radiofrequency ablation. Remember that the joint capsule has superficial nerve endings there, and your surgeons would burn it, no, using radiofrequency, and that's yung mga nociceptive fibers would, of course, be interrupted, so masakit. There's also the arthroscopic burr and shaver. Parang sinishave yung edges nung joint. So it's also causing pain. Next is the drilling of the anchor sutures. So from our point of view, Doc, it cannot be without a block. Or else, you will bombard your patient with so much opioid that your patient cannot go home. That's one. Your patient will be sobrang mad at you because she's so vomiting, nauseated, cannot sit up. No? Lastly, this is one of their requirements for them to be able to have a good field. So for us to be able to contribute to a bloodless field, we should have, yan. Pag nakakita na ng ganyan yung surgeon, kakanta na siya, Stevie Wonder, I cannot see anything, I cannot see anything. And then we'll ask you, what is your blood pressure? Because I want you to maintain your mean arterial pressure at such for me to be able to have a bloodless field. Pag ginantahan ka na ng Stevie Wonder, that means that the surgeon cannot see, and the surgeon is telling you that you need to do something about it. Now, it's practically very difficult for you to be able to maintain this mean arterial pressure if it wasn't combined with any other anesthesia. So we put regional anesthesia as to balance the technique for them to be able to do their work properly. Okay, sensitive video. Hindi naman lahat ng surgeons against the block. No? There are others who would actually ask for a block. So this one is Professor O. He came from Korea. He do like quarterly workshops with us in UST. No? So the host asked him, how can you prevent that much bleeding? So he said, good blocks and really good blood pressure control is important during surgery. No? So he says that it's like a tourniquet in the neck. Let me guide you towards the procedure-specific guidelines. No? Procedure-specific guidelines, Prospect is a committee of multidisciplinary people. They have surgeons, anesthesiologists, pain management. No? So just to give you an overview of that, they say that for rotator cuff repair, arthroscopic, pero number one, we cannot naman actually can dictate to our surgeons, arthroscopy mo na lang. Or open mo na lang, wag na arthroscopy. This part, medyo, it's very difficult for anesthesiologists to be able to adhere with kasi we are not in control. No? We very well know number two, it's multimodal analgesia, almost always, not only for shoulder surgery, but in all of the cases, even craniotomy, hemorrhoidectomy, it's all multimodal anesthesia with some form of a regional block in place. Number three is the interscalene brachial plexus block is recommended as the first choice. The suprascapular nerve block with or without an axillary block may be used as an alternative. A single dose of dexamethasone. Dexamethasone now is not only for PONV, but we give it now as an adjunct to prolong our anesthesia and give pain relief. No? The recommended dose is about 1.2 to 2.1 milligram per kilogram. So about 10 milligrams of dexamethasone, double dose. And then one thing's for sure, in all of the Prospect guidelines that you will be seeing, almost always opioids are reserved for rescue analgesia in the post-operative period. They are not now given routinely. So they're only reserved as rescues. Very busy slide, but the most important here, they just gave out you can scan on the QR code and you can read the full text. It's all in there. Okay, and then multimodal analgesia, opioids as rescue. And then recently, we very well know that interscalene brachial plexus block is the king of shoulder surgeries, no? The king regional block for shoulder surgeries. And we are also aware of the standardized nomenclature, di ba? They had nauna yung fascial plane blocks. And I'm not sure if you have attended one of the workshops that I've given, or I've taught you. We no longer call them by the number. We call them as to the destination, no, your target. You call them according to your target. So for example, ano ba yung may count? PEX, for example. PEX 1, not anymore. It's interpectoral because your target or your destination is in between. Same with, it's a newer consensus. It's a Delphi again. Delphi meaning they passed around all the guidelines, no? If you agree or not, they would say so. Tatlong rounds yon. And they have more authors now compared to the fascial plane blocks. But the description is practically the same. It's where you're going to put your target in. All right, so just to, you can also scan the QR code. It's there. The full text is there. So I'm going to concentrate lang on the 3 blocks above the clavicle. No? So above the clavicle meaning you have the interscalene, the superior trunk, and the supraclavicular block. You will see here but for the interest of time, will not wait na. But very peculiar is the itsura of the suprascapular nerve. No, it's almost always naka-pair siya with the C5 and the C6 roots. No? So it's one phrenic sparing. You very well know that anything above the clavicle, almost always, kahit small volume, once it violates that deep cervical fascia where the phrenic nerve is, it would almost always cause a phrenic nerve paralysis. In healthy patients, like in basketball players, unilateral blocks, that's okay. But it will matter if you have a COPD patient, if you have an elderly patient, if you have an obese patient. No? So that's where we are able to tailor our anesthesia accordingly. Okay, so we know that PISB is king. If you want your awake surgeries, it's you know that the roots of the ventral rami of these, we always ask you these, di ba? Kaya parang deja vu na paulit-ulit. Parang babalik ako sa 19, yung kay Doc, nasa East Ave, nag-lecture rin. Yon, so interscalene block above the clavicle, you give anesthesia to the roots of the brachial plexus. Next, sir. Next slide, sir. Ayun yan mag-move doon. King daw siya. There. Okay. So, if we take a closer look, it's almost always in close proximity to the phrenic nerve. No? Dumadaan lang siya sa fascia, but then, once you violate that fascia, can you find the phrenic nerve here? There, that small part. Which one is this? There. The small part, it goes into that fascia, going to the thoracic inlet. Diba? So, almost always, when you pierce that fascia, you can almost always have a phrenic nerve paralysis. No? So, this study studied 87 patients whom they gave 20 ml each of 0.375% of ropivacaine, and the incidence of hemidiaphragmatic paralysis was measured by the diaphragmatic exertion via POCUS, via lung ultrasound, and then the reduction in 25% during sniff test, and then dyspnea and hypoxemia were recorded as well. And they found out that hemidiaphragmatic paralysis, if you're far away, no, even at the even at the supraclavicular area, is almost half of that as it would happen if you're doing an interscalene brachial plexus block. Also, they studied if it matters pag madami yung volume or konting volume. Hypothetically, pag madaming volume, it will, di ba? But then, this study did double the actual volume, and they found out, and the conclusion was, it's about actually the dose, the total dose of the solution, not the volume, no? In fact, meron pa dito 0.9 ml. It did give some anesthesia, but they weren't able to, because of the brevity of the duration of the block. Kasi 0.9 ml, mas marami pa yung local natin na nilalagay sa skin, di ba? Of course, the lower the dose, the shorter rin the duration of your anesthesia. Another modification, phrenic nerve palsy and regional anesthesia for shoulder surgery. So they said that they're reducing the concentration independent of the volume, reducing the total dose of the drug delivered, and they produce significant decrease in the palsy and improvement in respiratory function after landmark or ultrasound-guided interscalene block. You know, they doubled the bupivacaine, and they realized that from 71, naging 42% na lang, given 20 ml of ropivacaine. However, it was at the expense of reducing the likelihood of giving analgesia. No? So it wasn't as effective as before. So, pag nanonood yung surgeon mo doon, gumising, sabihin niya, sinabi ko sa'yo, huwag mo na lang gawin yan eh, kasi hindi naman nag-work. But then, yun nga. So we also be very careful about how we dose our solutions. All right, so anatomy again, mabilis lang. Okay, so there are 5 nerves that would practically, your shoulder would practically need for innervation. You have the suprascapular nerve, the axillary nerve, the subscapular nerve. You have a few of the contributions from the musculocutaneous nerve, and one tributary from the lateral pectoral nerve. Okay? Oh, alis na tayo doon. Alternatively, yun nga, if you get patients who are high risk for developing paralysis, phrenic nerve paralysis, such as COPD, too obese, or diabetic, severe, uncontrolled diabetic, and so forth and so on, with pre-existing pulmonary issues. You have alternatives, just like Miss Universe. If Miss Universe is not able to fulfill her duties, the first runner-up shall take over. So you have 3 particular alternates. No? So you can do a suprascapular plus an infraclavicular, a suprascapular plus an axillary, and a superior trunk block. This is the big thing now. It's uso. Superior trunk block. It's trending. So alternatively, suprascapular plus infraclavicular, you very well know that you cannot cover for these nerves if you go higher up, kasi they take off distally, no? So you would have to do a separate infraclavicular block for this, if you want to do this. Next, you can also, you can also do a suprascapular. Suprascapular nerve block can be approached anteriorly and posteriorly. But of course, kung anteriorly, the phrenic nerve is also there. So if you want to do a suprascapular nerve block from the anterior, you would have to do it more distally. Okay? And this one, posterior approach. So you will see there's the supraglenoid notch, etc., etc. Complementary to this is the axillary nerve block. Not axillary brachial plexus block, but tributary, the axillary nerve per se, no? So you would find it at the middle below the humeral head. You will see the posterior circumflex. Remember, almost always your nerves are in close proximity to, that's not your target, but it gives you an idea that somehow the nerve is in the vicinity. Okay, so there are several studies that compared the Miss Universe and the first runner-up. And they found it's not non-inferior, meaning no clinically meaningful analgesic difference were found between suprascapular block and an interscalene block, except for the recovery room stay. Patients at the recovery room were better off with the analgesia compared to the suprascapular nerve block group. Likewise, this paper found out that this was actually a con paper. Parang nag-argue, yung findings nila did argue that the suprascapular block provided inferior analgesia in the immediate post-op period compared to ISB. And the analgesic differences gradually decreased, of course, kasi maliit lang siya na nerve eh, as the block worn off and the pain scores became comparable. Okay, but they found out that, ISB versus suprascapular nerve block, there's practically no dyspnea in the suprascapular nerve block group. There. So, with the superiority profile, safety profile, superior trunk block can be considered as a preferred alternative to interscalene when interscalene cannot perform its duties as Miss Universe, as validated in this superior trunk block systematic review and meta-analysis. Now, so, ang palagi nilang argument for pushing a superior trunk block is the safety profile of the block. Okay, so very fast. To complement an existing block, you also need, remember, di ba we saw kanina that the shoulder becomes so distended. So we'd like to anesthetize the cutaneous area dun sa cape of the shoulder, and we do a supraclavicular supplement for that. And it's just deposited on top of at the most distal part, where it gives off its inferior branch, on top lang of the middle scalene muscle. Corollary or contrary to the superficial cervical block, which you do higher up, di ba? That way, kasi we found out that patients na are sitting in a beach chair, so may mga straps sila sa muka. With the superficial cervical block, most of the time, that same side, they get numb. So they're not very comfortable, especially the athletes, they're not very comfortable with that. No? So we do a supraclavicular nerve block, not a supraclavicular brachial plexus block, a supraclavicular nerve block instead, just local infiltration on top of the middle scalene muscle. So just technical notes, we already know that. We'd like to scan from distal, from the supraclavicular area, up until we go up, and you will see the suprascapular nerve, nakabuntot siya dun sa C5 and the C6. In a while, in a while, in a while. There. Going up, going up. There. Not yet. Okay. This is circa 2012 when we used to use a nerve finder and stimulate all the nerves there. No, we no longer do them now. And this is how we test the quality, especially for the awake blocks. No, we'd like to make sure that it's. Pero 2012 pa to eh. Now we're more into motor sparing blocks na. Kasi especially the athletes, they don't want to feel that, that they cannot move their arms. There. So nowadays, no, we don't naman throw away our nerve stimulators, but we do keep them aside just in case, not as a nerve finder, but as an extra layer of protection for intramural deposition of local anesthetic. And we also use a nerve guard, so it's triple guidance. Just a sample of an interscalene block. Kita yung phrenic nerve, guys, so here. The phrenic nerve is right here. And it dips off into the thoracic inlet. This is the long thoracic, this is the dorsal scapular nerve. And then you'd notice that the C6 has two bubbles side by side. Again, supraclavicular nerve block just on top of the middle scalene muscle. It's just a local infiltration, and you use the hydrodissection to further propulse your needle in. All right? I'm almost done, Doc. Just to give you a short review on the position, no? So it's the Bezel-Jaris reflex that we are we should be wary about, especially when we are under a nerve block and under general anesthesia. No, so it's a busy slide, but it almost always gives you the overview of the pathophysiology of it. The outcome, you will notice there's bradycardia and hypotension, which it's easily naman can be counteracted, but then we should be more careful when we are dealing with, of course, the elderly patients and the cardiac patients. So finally, this is my last slide, no? So I'd like to push a new mindset that it should be not procedure specific, but I'd like to propose na it should be patient specific, So it's not one size fits all. It's tailored according to your patient's profile. And then, of course, coordinated results, good high quality outcomes would stem from coordinated care, it's nice to talk to your surgeon. How many anchors are you going to do? How bad is the shoulder? How many fluids do you think that we're going to give? So to give you an overview of the intraoperative course, And then, of course, value-based healthcare. And last but not the least, always consider the following. It's a shared decision. A shared decision between you, the anesthesiologist, the patient's consent, the surgeon's consent, and also consider expertise, comorbidity, if the patient wants to go home the same day or wants to get admitted. And of course, the catastrophizing patients. Patulugin mo na lang yun. So thank you all for your time. We're open to questions.
Thank you very much, Doctora. Would anybody want to ask a question for Dr. Claire with regards to? Yes, Doctora.
I see.
Yes, Doctora. That was the first our first ultrasound guide.
Huwag mo sabihin yung date.
Hindi po. It was an upper, it was a hand surgery, yes po, Doctor.
Did it work?
Yes po. Any questions from the floor? Very interesting topic regarding shoulder surgery, regional anesthesia for shoulder surgery. Yes, Dr. Escalon?
What are your recommendations for bilateral
Bilateral?
Mahirap pa. Shoulder surgery. Yeah.
Is it really indicated?
Let's say
Because
for
in international institutions, it's no longer, you can't push for a bilateral surgery, but then if it's really needed, might as well go for the more distal blocks, like a suprascap and an axillary nerve block, bilateral, with sedation.
not really surgery, doc. Yung
surgery.
lang yung for, let's say,
Frozen shoulder?
Frozen
Suprascap,
shoulder
kaya na yun. Suprascapular.
Suprascapular,
Remember, it's
bilateral.
70% of the joint is via the suprascapular nerve. So frozen shoulder, you mean?
Yes.
Para makarehab?
Yeah. Yung bilateral.
Yeah. 5 ml, 5 to 10 ml would do. It's a very small nerve. Kung surgery with axillary, but then you take into consideration that you cannot block all the, di ba, 5 nerves, axillary and suprascapular only. So, chances are you would have to sedate some more kasi yung tatlo hindi mo ma-block. So, you would have to do like a costoclav pa or an infraclav for that, for surgical anesthesia.
Doc, last question. Yung if ever the patient had phrenic nerve paralysis or palsy, how long would that yung duration of the if ever due to the block?
It's the duration of the
yung
gamot.
yung phrenic nerve palsy,
Yeah,
yung makakaroon ka ng
it's according to the
elevated
duration
hemidiaphragm.
on how much local anesthetic.
No, how long
you give.
would that until it goes back to normal if you just,
Yun nga, it depends on how concentrated your local anesthetic. Yung binigay mong local anesthetic. If it's 0.5, yung the more diluted one gets resolved easier than the more concentrated ones.
Yun ba, Doc, yung
But then,
duration ng...
the other side naman, patients would barely feel it. Kasi, especially for the healthy ones, the healthy ones, the other lung naman would compromise, would compensate for that. So, almost always they won't feel it. Unless na, COPD, super tanda, bronchitis or something, merong lung pathology.
Thank you, Doc.
Thank you.
Any other questions from the floor?
Hi, Doctor. Do you have any idea or any experience using dexmedetomidine as adjunct for the blocks? I mean,
Yes,
it's
we
off
do.
the label, but yeah.
No. Off-label siya, Doctor, if it's perineural. If it's perineural, that we don't have an FDA yet. But then, we like it very much because they prolong our blocks really well. Especially with dexamethasone. We use it, we take advantage of all the other properties. We call it the Swiss knife, di ba, of the sedatives. It has antiemetic, it can prolong your anesthesia, it has anti-sialogog, yung hindi masyadong naglalaway. So we like it very much when our patients are awake. Either that or TCI propofol, depending sa profile. And of course, yung baseline, if your patient is an athlete, ganyan, and baseline heart rate niya is 40, although hindi naman masyadong nakakadip, no? If you do it at 0.4 microgram per kilogram, but then we'd use propofol instead. Kasi yung these subset of patients, medyo agit, but we like it very much, no? Yung sedation that we get from dexmedetomidine.
Doctor, I have a question. With regards to the suprascapular block, if you want to do do you find it easier or the advantage of doing a subomohyoid approach or the posterior suprascapular approach for the...
Same. Kasi you'd be using a linear probe anyway. Papatong mo lang siya here. Depending sa pathology Kung for example, may lung issues, I wouldn't go na anterior, subomohyoid, kasi may propensity pa rin ano yun, di ba? So, I would suggest that you do it from posterior. Anyway, mas mababaw rin naman yun. It's the linear probe rin. Wag lang masyadong posterior, kasi if you hit it more posterior, nandun na yung pleura. So, you want it to come from here lang, not dun sa notch mismo. Di ba? It's in the box, it's in the notch, they say. But it's best to approach it from the top, dun sa may shoulder girdle.
Yes. Any other questions?
Sayang, sana pala may ortho.
Yes.
May ortho
Good
dito.
afternoon po. Doktora, have you experienced any shoulder surgery na nagsip in yung fluid mo to the chest?
Oh yes, that's the reason why patient selection. No, not all our patients are awake. Not all of our patients are under general anesthesia. You should consider the surgeon as well. You should consider the pump pressure as well. Yes, we've had experience like putting them in the ICU for diuresis, for diuretics. Kasi marshmallow man sila.
I had one or two of patients na nagkaganon. Would you recommend doing apex block or serratus anterior for the pain dun sa chest area niya?
Yeah, pero it's super diluted na, no? Pero yes, you can, anyway, it would help pa with the shoulder as well. Kasi di ba, the lateral pectoral nerve is one of those that gives off with the shoulder as well. Yes, you can do so. Technical difficulties lang yan, Doc, kasi yung fascia, syempre, hiwa-hiwalay na din siya. So, it's very difficult to to see an unzippering in those cases.
I mean, preoperatively.
Say it again?
Preoperatively po, ibibigay niyo yung block.
Pero would you know na ganun ba yung mangyayari? Preoperatively? Di ba yung swelling is, it's usual, pero yung swelling na hanggang sa kabilang, meron 12-hour surgeries, parang 1,180 liters of fluid, ganyan, sobrang taas ng pressure, subcutaneous emphysema, and yon, sobrang swollen.
Thank you.
Okay. Any other questions? Here, one.
Good morning po, ma'am. Ma'am, question lang po. How does the choice between single injection nerve blocks and continuous catheter techniques impact the duration and quality po ng surgery and post-op din po to?
Yeah, I would say that all depends on the type of surgery. Di ba? Not all shoulder surgeries are the same. If it's just subacromial decompression, it's a single shot, almost always. But we do put in the catheters for the massive cuffs, yung massive rotator cuff repairs. Yan. Kasi 7 to 8 anchors yon, 3 to 4 hours, sobrang swollen yung shoulder. Yon. Also, another thing to consider is your patient going home the same day. We can send them home with catheters, but of course, the resources are very limited who can follow them up at home. So, for now, we do send home with easy pumps and elastomeric pumps, infusing, but only to those who can take care of themselves. Yung mga lay, yung mga may medical know-how, or mga doctors, ganyan, or someone who has a caregiver at home, we can send home the catheters with them. Kung hindi naman, you'd like to keep them admitted, and then hanggang sa duration nung infusion mo. But of course, continuous interscalene blocks are superior to the single shot kasi it gives off sustained doses of your local anesthetics. Pero not all shoulder surgeries are the same. So we ask the surgeons, what type of surgery are you going to do? Subacromial decompression lang. Pag subacromial decompression nga, less than 30 minutes yon gising. With a little sedation lang. But then if it progresses to something more extensive, then we would have to secure the airway. So, saka makikilala mo naman yung surgeon. Yung surgeon mo na merong track record na a little longer. So, remember, patients cannot, sa EDSA nga, nagda-drive sila, nabobore na sila. And what more, yung most of the time kasi they do develop tachyphylaxis as well. Kakabigay mo ng boluses of the sedatives. Might as well, para mas cost efficient, secure na lang the air input completely to sleep, balance the anesthesia.
Thank you very much for your questions. Unfortunately, due to our time constraints.
Selfie tayo. Carl, sama ka. Doctor, like that, oh.
Okay. Thank you very much for a very interesting discussion and lecture.
What an enriching Q&A session. We'd like to thank all our audience members who gave their questions that were excellently answered by Dr. Braganza. And of course, we'd like to thank Dr. Agbon for the excellent moderation of this session's Q&A.
Yes, that was very interesting indeed. I learned a few new points there. But we're not done yet. As we conclude this session, we want to encourage everyone to please spark conversations in social media and use our hashtag WDRAPM to connect with other people who are also in the first World Day of Regional Anesthesia and Pain Medicine. Before we break for lunch, we have a special session brought to you by our sponsor, Taisho Pharmaceuticals. And we're honored to have a representative from Taisho join us today to share some insights. Please welcome Dr. Evelyn Salido, who will provide us with a brief message.
Osteoarthritis is a burdensome condition that leads to significant deterioration in quality of life. It is estimated to affect more than 500 million individuals worldwide. In the Philippines, it is the second most common musculoskeletal condition next to rheumatism, with an estimated overall prevalence of 4% per 4 million Filipinos. It affects mostly the middle-aged to elderly population, often overweight or obese, with comorbidities such as hypertension, dyslipidemia, and diabetes. Although there's a wide availability of pharmacologic treatment, more than 50% of OA patients remain to have unsatisfactory pain control. Existing oral NSAIDs such as coxibs pose a risk for CV, renal, and GI side effects, hence can only be taken in short or limited period. On the other hand, topical NSAIDs, which are strongly recommended by guidelines, are associated with lower risk of such side effects, but perceived to be less effective due to poor tissue penetration. To address the potential side effects from oral NSAIDs such as coxibs and the lack of potency from existing topical NSAIDs such as gel, it is ideal to have a topical NSAID that has high potency, proven to be beneficial in pain and function, and safe for long-term use. Introducing an innovative and first-of-its-kind NSAID patch in the Philippines. Esflurbiprofen Locoa. Esflurbiprofen Locoa has high transdermal absorption and tissue penetration sustained after 24 hours. Esflurbiprofen Locoa showed potent COX inhibition compared to other NSAID patches. Esflurbiprofen Locoa has favorable safety profile in long-term use. Esflurbiprofen Locoa was found to have significant and consistent symptom control up to 52 weeks. Esflurbiprofen Locoa, first-line pharmacological treatment for osteoarthritis with favorable safety profile. Patch the pain, embrace the game.
Our speaker for this session finished her medical school from the University of the Philippines Manila College of Medicine, her residency in internal medicine at the University of the Philippines Philippine General Hospital, as well as her clinical fellowship in rheumatology at the same institution. She also finished a Master of Science in Clinical Epidemiology from the University of the Philippines, Manila. She is a professor of the Department of Medicine, College of Medicine, University of the Philippines, Manila, and professor of the Department of Clinical Epidemiology of the De La Salle Health Sciences Institute. At present, she's also the chief of the Division of Rheumatology of the Department of Medicine of the Philippine General Hospital. Ladies and gentlemen, please join me in welcoming Dr. Evelyn O. Salido, Fellow of the Philippine College of Physicians and Fellow of the Philippine Rheumatology Association.
Paano ba?
Itong forward most likely.
Oo nga.
Lang natin. Na-upload pa nila. Ayan. Try nyo pa.
Good afternoon. So, thank you very much to the organizers of this convention for the invitation. And thank you to Taiso for allowing me to introduce their product as flurbiprofen to you this morning. So, maiba naman tayo, no? Let's talk about osteoarthritis. You've been talking about surgical pain and post-operative pain. And osteoarthritis is a very common disease. It's a huge problem. It causes pain and difficulty in ambulation. It makes older persons prone to falls. It causes limited range of motion as well as joint misalignment of deformity. And it's not only common among older persons. Although among those who are 70 years old and above, it is the 7th ranked cause of years lived with disability. So we'd really like to be able to control the disease as well as control the pain of osteoarthritis. But what is a little bit shocking is that even among those who are 30 years and above, 14.8% had osteoarthritis diagnosis, and 3.5% lived with osteoarthritis. So our usual picture when we talk about osteoarthritis is that we see it among very old people, but nowadays we're seeing it in younger persons. And the disability is not only physical, it can also be psychological as well as socioeconomic. So we'd like to really be able to control osteoarthritis among Filipinos. It is the second most common musculoskeletal condition, second to soft tissue rheumatism, and it is present in 4% of adults, which is approximately 4.2 million Filipinos. In this study which we did in the Philippine General Hospital, the average onset of symptoms was at 59 years of age, and the mean age at diagnosis was 63. And many of the patients were overweight or obese, and the most common complaint was pain in 92%. Many of the patients that we saw, these were around 150, a cohort of 850 patients with osteoarthritis. The knee was the most commonly involved, and in 70%, the problem was bilateral. 80% also had more than one site affected by osteoarthritis. And you can see that many of the patients had other morbidities like hypertension, dyslipidemia, and diabetes, which can potentially complicate the treatment that we give. In this study, the most prescribed drugs were glucosamine sulfate, paracetamol, and non-steroidal anti-inflammatory drugs. And less than 10% received other treatments like intra-articular treatments or were referred for surgery. But I'm not sure if this is still reflective of how it is now, because this study was done almost 10 years ago. So it would really be interesting to do an update of the study. So moving forward, how do we manage osteoarthritis? I think it is mostly a combination of non-pharmacologic as well as pharmacologic treatment. And in the Philippine General Hospital, we are doing a multidisciplinary clinic between, so this is a virtual multidisciplinary clinic for osteoarthritis, participated in by rehabilitation medicine, orthopedics, rheumatology, and family medicine. And so these are the different modalities that we can give for our patients with osteoarthritis. There are several guidelines that have been created to guide us in managing osteoarthritis, and many different institutions or organizations have put forth their guidelines, and we see that in most of these, medical management is still the first line treatment. What happened? Okay. And so given that our patient's complaint is pain, one of the common drugs that we give are NSAIDs. And however, given that our patients with osteoarthritis have a lot of morbidities or comorbidities that may make us hesitate to give oral non-steroidal anti-inflammatory drugs, then topical NSAIDs, which are highly recommended and are beneficial over placebo, seem to be a good option. And of course, our patients would want something that can effectively reduce their pain, which works fast, has a long duration of action, and less adverse effects. And also, to top it all, something that is less costly or quite affordable. So in osteoarthritis management, we would really want to give our patients something that can relieve them of the pain. However, given, as I mentioned, we might, think twice before giving our oral medications. Despite the advantage of coxibs being safer for the GI tract, we expect less GI adverse effects with their use. We still are faced with the cardiovascular and renal problems that may ensue with their use. So we'd really like to look into existing topical NSAIDs. And however, most of those existing topical NSAIDs have poor absorption, and we're looking at products which are absorbed well and also work very fast for long periods of time. Okay, so one such innovation recently launched in the Philippines is S-flurbiprofen, okay, or Locoa. So this is a 40 milligram transdermal patch, and it is applied on the area of pain. So it's given once a day, and it is used daily in adults for relief of pain and inflammation associated with osteoarthritis. So let me introduce this product to you. It was launched in Japan in 2016, and in other Asian countries, Thailand and Malaysia, in 2021, so at the peak of the pandemic. And it it came to our shores last year in November 2023. And I think it's now available in commercial quantities. Okay. So introducing the product, you might have heard of flurbiprofen. So it's flurbiprofen is available as a tablet, but it's also available as a patch. So it's an NSAID. And looking at the composition of flurbiprofen, there are S and R enantiomers. And the difference given S-flurbiprofen or Locoa is the R enantiomers have been removed. And the advantage of solely S enantiomers being available in the patch is higher COX inhibition as well as better tissue penetration. So what is the proof that S-flurbiprofen works? No? So that's, of course, something important to know. And we'd also like to know safety, and if that safety is something that is long-term. Because usually treatment for osteoarthritis is long-term. So in the next 20 minutes or so, I'd like to share with you data on pharmacokinetics as well as clinical performance, efficacy and safety of Locoa. Mahaba yung S-flurbiprofen, it's tongue twisting. So please allow me to just use the brand name for this lecture, Locoa. Okay. So this is showing you absorption or blood concentration. This is a study in 7 healthy volunteers, and the patch was applied on the lower back for 24 hours. And we can see that if you look at the graph, the peak absorption is at 12 hours, but it goes on until 24 hours and even extending beyond 24 hours. And that is with just 1 daily application. So the patch is kept in place for 24 hours. This table shows us single application versus 2 patches being applied. So looking at this table, the first row is 1 patch of Locoa, and the second row is about 2 patches of Locoa compared to oral flurbiprofen, the lowermost row. If we look at the area under the curve, we see that when 2 patches of Locoa are applied at the same time in different parts of the body, you approximate the concentration of an oral flurbiprofen. Okay, so it's able to achieve high blood plasma concentration even with just 1 patch, but with 2 patches, then you're able to achieve even higher blood concentration, which is equivalent to what you get when you take something orally. Okay, so let's look at more data on transdermal absorption and tissue penetration. This is a randomized, open-labeled study investigating the tissue penetration as well as the pharmacokinetics of Locoa in 20 patients with knee osteoarthritis. And so the patients were given either Locoa patch, and this was compared with the flurbiprofen patch. These patients were due for surgery. So they were given the patch 12 hours before surgery, and there was the surgery done, and they looked at, they measured the transdermal absorption ratio, and this was shown to be 7 times more for the Locoa group. They also looked at the amount of Locoa present in the synovium as well as the synovial fluid, which were collected during surgery. And we can see that there is higher concentration of Locoa compared to the flurbiprofen patch, both in the synovium and in the synovial fluid. So that assures us of a very good tissue penetration, even inside the joint with the use of Locoa. So how is the drug metabolized? It's mostly through oxidative metabolism by CYP2C9. And so it's good to have information that if there are polymorphisms of the enzyme, then that will affect the metabolism of the drug. In healthy adults receiving a single 24-hour application of 80 milligrams Locoa, so that's 2 patches, very little of the dose is excreted as unchanged. So they are mostly metabolized. Okay. So let's now look at clinical data, looking into the analgesic and anti-inflammatory properties of the drug. So this is in animal models, and the objective is to look at pain relief, which is measured using vocalization counts. So this is comparing 3 different patches, Locoa, ketoprofen patch, and loxoprofen patch, and placebo. And looking at the graph, you will see that the orange line, which represents Locoa, shows a significant decrease in pain among these Lewis rats with arthritis, which is significantly more than what we see with ketoprofen patch and loxoprofen patch. What about the anti-inflammatory effect? This is again in animal models, in an animal model of Lewis rats, and the anti-inflammatory effect is measured in terms of prostaglandin E2 values. And again, the graph shows us very good inhibition of prostaglandins, signifying a reduction in inflammation. Okay, so the next is showing us the COX inhibitory effect. So again, looking at the anti-inflammatory effect of Locoa, comparing its action in the inhibition of COX-1 and COX-2. And both graphs show us that, again, comparing Locoa with the other patches, as well as diclofenac, then we see good COX-1 inhibition as well as COX-2 inhibition. You might be wondering why the 40 milligram dose is the one that is available, because it is the dose which has been shown to exert very good anti-inflammatory effect, good analgesic effect compared to placebo. So this is a phase 2 study among more than 500 patients with knee osteoarthritis, and they looked at the outcome of knee pain on rising from a chair. So that's a very significant problem among patients with osteoarthritis, knee pain on arising from the chair. And in my practice, that's usually also one of the most common complaints that patients have. And so in this study, the patch, Locoa, was compared with placebo. There was a washout period of 1 week, and the patients were observed for 2 weeks. And the comparisons were various doses of the patch, 10 milligrams, 20 milligrams, and 40 milligrams, compared with placebo. And what's the result? So in terms of pain on rising, measured through the visual analog scale, then the graph is telling us that the 40 milligrams patch is the one which is able to exert significantly better reduction in pain in terms of visual analog scale compared with placebo. Not only, and there were also other outcomes like symptom improvement. So this is a combination of various manifestations of osteoarthritis. So pain, inflammatory symptoms, as well as impairment in activities of daily living. And again, looking at the graph, comparing all the different doses, we see that the 40 milligram patch is the one which is able to significantly cause an improvement in all of these manifestations of osteoarthritis. This is also another proof why the 40 milligram patch was chosen. So this is looking at knee pain on walking. And again, it was the 40 milligram patch which worked significantly well. And the improvement was noted on the next day, after using or starting the patch, as well as 3 days and beyond that compared to placebo. Looking at other endpoints, which were investigators' global assessment, as well as patients' global assessment, the 40 milligram patch also had the highest percentage of patients and investigators who said marked improvement with the medicine. Okay, what about adverse reactions? So remember, this is a two-week duration of drug use. And if we compare placebo and all the other patches, looking at adverse reaction on the application site as well as non-application site adverse reactions. So these are examples of non-application site adverse reactions where increase in blood urea nitrogen as well as AST. We see that there were no significant difference in the adverse reactions seen for the different doses and placebo. And most of these adverse drug reactions were mild. So in summary, the 40 milligram patch showed remarkable pain relief in many different endpoints in the study, namely pain on arising from a chair, a composite of clinical improvements given pain, inflammatory, and activities of daily living, investigator and patient assessment, as well as pain on walking. And the safety profile of the 40 milligram patch was not different from that of placebo. So it was the dose chosen, and it is the one that is available now. Okay. So let's further look at how it compares with another topical agent, which is diclofenac gel. So this is a study in more than 300 patients with knee osteoarthritis. It's multi-center, randomized, open-labeled, and it was designed to assess the efficacy and safety of Locoa in patients with knee OA compared with diclofenac gel. So here, the outcomes were similar to the dose-ranging study I mentioned previously, and the treatment period was 2 weeks. So what did they see? It's not moving. There. Okay, so this table is just showing us that the patients in the two groups were comparable in terms of sex, the age, their weight, and their BMI. The results in terms of the primary endpoint, which was pain on arising from a chair, we see that Locoa was non-inferior to diclofenac gel in terms of reducing pain on arising as measured using the visual analog scale. Also, the patch, Locoa, is also better in terms of clinical symptom improvement compared to the diclofenac gel group, as shown in these graphs. And looking at investigators' global and patients' global assessment, we see that there is more than 60% market saying that there is market improvement with the Locoa patch. So this seems to be reassuring, no? Other endpoints, this is pain on walking. We see similar trends in effect, as well as in safety outcomes. In this study, so this is over a 2-week study, the adverse events were around 5% in both groups. And we see a few systemic reactions like gastrointestinal disorders, some application site reactions like dermatitis and rash. Okay. But these adverse events were mild and were of low incidence. So to summarize, comparing the Locoa patch with diclofenac gel, we see non-inferiority in terms of efficacy for pain relief on rising from the chair, and there were statistically significant differences in terms of other safety outcomes, other efficacy outcomes, indicating robust efficacy of the product for knee osteoarthritis patients, and it was also well tolerated. So let's now look at safety. This is long-term safety. In a 52-week multi-center open-labeled study, comparing the use of either one patch or 2 patches of Locoa per day used over 52 weeks. So the patients were those who really had pain every day and needed to be given a pain medicine every day. So there was an initial observation period of 2 weeks and then the treatment period for 52 weeks. Most patients had osteoarthritis of the knee, and the second most common site was the lumbar spine. So they looked at the application site, safety on the application site, looking at the skin, and they also looked at non-application site safety in terms of systemic effects. So looking at the 1 patch versus the 2 patches, we see that almost 50% had some kind of adverse drug reactions. But looking at the application site adverse drug reactions, 46%. So there were different kinds of adverse reactions on the skin. Some were pruritus, erythema, eczema, or dermatitis. There were also a few systemic adverse drug reactions like gastritis, increase in blood urea nitrogen, and the presence of hematuria, but these were very, very small in frequency. Other outcomes were looked at, like, again, the composite of clinical symptoms. And this graph is showing us that Locoa showed early efficacy. So within 2 weeks of use, there was an improvement in the clinical symptoms. And this is continued over the 52-week period, regardless of the site of application. Okay. And again, this is comparing, this is showing investigators and patients' global assessment that more than 70% of patients said that there was marked or moderate improvement, and that the same was said by the investigators. So this long-term study showed that the majority of drug-related adverse effects were mild, usually mild dermatitis at the application sites, and occurred in 46.8% of the sites that were examined. So it's something that we must tell our patients. We should warn them that it may happen, and we should advise them on, how to handle that if it does occur. Systemic drug-related adverse events were minimal in 5.9% of patients. So this is data showing that esflurbiprofen patch is safe for long-term use up to 52 weeks at once daily dosing of 40 to 80 milligrams. And significant improvement in symptoms is seen in 2 weeks and continuously over 52-week period. So the last set of data I'll be showing you is about the post-marketing surveillance, which was done in Japan. And here, there were 3,000 patients who were included in the study. And most of them were female, and we see that the youngest patients here were in their 60s, no? So they included patients who were even more than 85 years of age. And the mean was 71.4. The most common site of involvement of osteoarthritis, just like in the clinical trials, was the knee joint. And if we look at the clinical symptom score, then we see that there was improvement in pain at rest, at exercise, and there was also a reduction in tenderness. Also a reduction in inflammation and improvement in activities of daily living with the use of the patch. Comparing patients who were given Locoa and an oral NSAID, and those who were not given an oral NSAID, then we see that in both groups, whether with or without an oral NSAID, there was improvement in pain, inflammation, and in their range of motion. So without oral NSAIDs, there was marked or moderate improvement in 68%. Without the oral NSAIDs, the improvement was found in 63.6%. So it seems that the addition of an oral NSAID did not really do much, in terms of improving the situation of the patient. Okay, so this is to summarize the safety data in that post-marketing study involving 3,000 patients. The patients who developed ADRs at the time of approval, so the incidence of ADRs present among the patients who used the drug at the time of approval was 19.3%, and during the post-marketing surveillance, ADRs were found in 13%. And most of the adverse drug reactions were on the skin, either in the form of erythema, irritation, pain, pruritus, rash, or increase in warmth. Okay. So this post-marketing surveillance, which was conducted in Japan, shows satisfactory pain control and improvement in clinical symptoms at 3 months, continued up to 12 months. There were a few systemic adverse drug reactions noted, but mostly the adverse reaction was on the skin and found in 11% of patients. So, how do we use this product in our practice? No? Given that many organizations have included in their guidelines in the treatment of osteoarthritis the use of topical nonsteroidals, then it may be used as first-line drug, no, for patients with osteoarthritis, especially among those who have hypertension, kidney disease. We can also use it as an add-on in a cyclic manner. The 52-week studies have shown that it can be used as long-term for pain management, and it can be used in patients with or without GI or cardiovascular comorbidities. So thank you for your kind attention. I hope I did not extend too much. Thank you very much.
Thank you very much, Dr. Salido. Do we have any questions for Dr. Salido before we say goodbye to her from the group? Again po, Dr. A big thank you to you and to Taisho Pharmaceuticals for your valuable contribution to our event today. Let's give Dr. Salido and Taisho Pharmaceuticals another round of applause. Thank you, Doctor. Doctor.
Okay. Now it's time to take a break and enjoy a delightful lunch. We're heading to the penthouse for our lunch symposium. It's an excellent opportunity to continue conversations, network with fellow participants, and enjoy the delicious meal while taking in the stunning views. Our ushers will guide you to the penthouse. See you all there.
But before that, since this is a Tri-City event, we'll just say hello to our friends and colleagues and fellow regional anesthesia and pain medicine specialists in Bacolod. Do we have our live feed from Bacolod?
Hello, everyone in
Hello.
Bacolod. Oh, they're also having their lunch break. Oh
Good
no, or they're
afternoon.
scanning ba?
Delegates in Bacolod. We're
Hello,
from
yes, sir.
General
Let's all
Trias.
wave to them. Let's wave to them too. Hello, good afternoon, everyone.
Hello.
We hope you're also enjoying all of our lectures and talks today. Yan.
Happy first World Day of Regional Anesthesia and Pain Medicine. Hi, Doc Lily. So,
Wave hi. Hi,
Hi,
Doc.
Doc
Wave
Lily.
hi.
Happy World Regional Anesthesia Day. Mabuhay!
Have a nice conference. Dr. Alili, Dr. Arancel, and we have Makati Med, Dr. Cano.
Thank you, everyone. We'd like to invite you for lunch. Our ushers outside will be leading you to the penthouse where we'll have our lunch, and hopefully we'll be back in 45 minutes, hopefully, so that we won't be taking so long.
Okay.
Enjoy lunch, everyone. Bon appetit.
is always self-involving. Health has become the top priority as the explorers light up the torches and looking for new ways to the future. Technologies bring us a bigger world and more creations. By focusing on medical imaging technologies and innovating, Focus and Fusion Healthcare makes high-class healthcare available to everyone, enabling every soul to write the best chapters in life. Technology lights up life.
Konica Minolta point-of-care ultrasound systems provide the power, IQ, functionality, and ease of use to optimally support bedside ultrasound exams and ultrasound-guided procedures. The laptop design of the SonImage HS2 consists of a 15-inch touchscreen monitor that swivels and pivots. The touchscreen interface and streamlined console can both be customized to specific user preferences. Konica Minolta designs and manufactures a full suite of broadband frequency transducers, which are specifically designed to meet the clinical demands of today's healthcare providers. There are 8 transducer options for the HS2 system. User-defined presets can be customized for specific diagnostic and ultrasound-guided procedures. Ultra Adjust is a one-button optimization of multiple imaging parameters and is controlled by adjusting the depth. This feature is designed to enhance workflow efficiency. Available imaging modes on the HS2 system include 2D, color flow mode, power Doppler imaging, pulse wave Doppler, continuous wave, and M mode. Panoramic imaging can be used to create a stitched anatomic presentation. Post-processing options include trimming, zooming, and measurement functions. Konica Minolta's Simple Needle Visualization, or SNV, is a unique, proprietary software algorithm that visually enhances both the tip and shaft of the needle in bright blue. This feature can be utilized with any of the linear or curvilinear transducers and works for both in-plane and out-of-plane approaches. Wireless network connectivity allows for seamless image transfer and patient information retrieval. Remote Assist is a powerful tool that can be used to remotely assist our customers with technical and clinical applications support. Konica Minolta point-of-care ultrasound provides clinicians with the leading-edge technology and advanced applications designed to empower better patient outcomes. The superior image quality, ease of use, and portability of the HS2 provides the tools needed to make clinical decisions sooner. See beyond your expectations with Konica Minolta Ultrasound.
a line of
others. As a person of integrity, responsibility, discipline, patriotism, bayanihan, and malasakit. a light of hope to others. As a person of integrity, responsibility, discipline, patriotism, bayanihan, and malasakit.
Biopharma Medical Solutions is an all-Filipino-owned company specializing in the sales, marketing, and distribution of pharmaceuticals and medical devices. Biopharma is proudly composed of experienced sales and marketing professionals with expertise in building brands and fostering client partnerships. We bring value to our clients by offering them high-quality and affordable healthcare products and services. We have provided over 200 hospitals, cardiac catheterization centers, and PET scan centers with the highest quality products and state-of-the-art medical equipment. We are committed to improving the lives of patients and empowering healthcare workers and hospitals through our products and services. From imaging and diagnostics products, we have now expanded into hospital care solutions, orthopedics, oncologicals, and medical devices. We are proud to present the Biopharma product portfolio. OmniHexol is a tried and tested contrast medium for diagnostic imaging and interventional procedures with superior diagnostic efficacy. OmniHexol is manufactured in Korea by Korea United Pharm Incorporated, a multinational and multi-awarded pharmaceutical company reaching over 40 countries worldwide. Due to OmniHexol's excellent safety profile, it has been approved for both pediatric and adult use. OmniHexol is triiodinated, has excellent water solubility, and is less viscous, resulting in better efficacy and minimal adverse reactions. OmniHexol, or Iohexol, is the only contrast media approved by FDA for oral and rectal use. It is well accepted by patients due to its neutral and palatable taste. It is less likely to cause GI distress, and it can be used in cases of barium intolerance. Gasless is a complementary product of Korea United Pharm Incorporated for relief of symptoms associated with abdominal gas. Gasless is given to patients in preparation for abdominal ultrasonography, and it is used to prevent colonic bubbles during CT colonography to significantly improve sound transmission. ZonCare is a leading high-tech medical enterprise and medical equipment manufacturer and service provider located in Optical Valley of China. The main products are color Doppler ultrasound system, ECG machine, and patient monitor. Our partnership with ZonCare allows us to provide state-of-the-art ultrasound systems, such as ZonCare N7, a full digital color Doppler ultrasound system. We also offer ZonCare's high-end portable 3, 12, and 18-channel ECG machines, iMac 12, a tablet ECG machine that was a 2016 Red Dot awardee, and a multi-parameter patient monitor. Perlove Medical is a large-scale and influential manufacturer with high-tech imaging equipment, R&D, production, sales, and after-sales service. Their comprehensive product range includes imaging systems and related instruments, ventilators, anesthesia systems, and veterinary products. Our partnership with Perlove Medical allows us to provide our clients with intelligent, humanized comprehensive medical imaging solutions that are multifunctional, highly efficient, and with low dosage. The product line covers a series of flat-panel digital radiography system, surgical C-arm series, and mobile digital X-ray systems with advanced digital imaging technology, producing sharp and high-quality images. LUZON Medical Technologies Company is one of the world's leading manufacturers for ultrasound systems certified by CMD, CE of Europe, FDA of US, CSA of Canada, KFDA of South Korea, and other international bodies. Biopharma is proud to offer LUZON Sonowai, the lightest handheld ultrasound with the fastest response speed that delivers high-quality imaging and provides a flexible connection with a smartphone or tablet. ANDI, or the Automatic Needle Destroyer by Mune, is an award-winning syringe disposal system that is compact and easy to set up and use. Partnership is always at the core of the biopharma business model. We have consistently supported various medical societies through booth exhibits, continuing medical education, and scientific sessions. For 2 consecutive years, Biopharma was given the Best Exhibitor Award by the Philippine College of Radiology. In a highly competitive industry, establishing trust and integrity is a must. Biopharma believes in its greatest asset, its people. Apart from its innovative products, the strength of Biopharma lies on the talent, dedication, innovation, and expertise of its competent workforce. Biopharma has evolved into a strong healthcare partner and a gateway of products from both international and local companies. With ultimate service in mind, Biopharma shall continue to uphold its credo, a shared commitment to quality healthcare by providing high-quality and affordable healthcare products and services everywhere in the Philippines.
The miracle of birth is a beautiful moment. Actronex is an anti-fibrinolytic solution for intravenous injection. It is indicated for obstetric and gynecologic conditions such as menorrhagia, metrorrhagia. Don't let uncontrolled bleeding ruin precious moments. Take control with Actronex.
On and on. It just keeps going. On and on. Look at the discomfort it's causing. On and on. Is there no way of controlling this? Put a stop on emesis with Onzet.
When acid levels get out of hand, it's time to call the authority in acid control. Manage gastric acid secretion with Zepson Injection. Zepson Injection is a proton pump inhibitor which reduces gastric acid secretion in the parietal cell. Keep gastric acid levels in check with Zepson Injection. For every battle we take on, a strong defense is needed. Trust the armor designed to protect against acid-related disorders. Choose Mepraz. Mepraz is available in 20 milligram and 40 milligram gelatin capsules. For a strong and reliable armor against acid-related disorders, choose Mepraz.
You're not you when you're in pain. Don't let it take you over. Coax the pain out with Coccidia. Coccidia is a non-steroidal anti-inflammatory drug used in the treatment of rheumatoid arthritis, osteoarthritis, ankylosing spondylitis. Coccidia is available in 200 mg and 400 mg capsule. When in pain, take Coccidia. It's programmed to take over pain.
When pain and muscle spasm are constricting you, don't wait for it to take over. Counteract it with Norpreksha. Never let pain and muscle spasm take away your spark. Always counteract it with Norpreksha.
In the treatment of acute pain, go to the root of it all. Lock in the target, lock in the relief. Target the root of moderate to severe pain with Daleks. Targets directly the root cause of pain. Achieve rapid relief with Daleks.
For a safe and secure sedation, choose the one with decades of clinical experience. Give your patience Xylem. Xylem 5 mg per milliliter is a sedative and short-acting sleep-inducing drug of pronounced intensity. Always stay confident in giving your patients a safe and secure sedation. Give your patients their much-needed Z's with Xylem.
Life is always self-involving. Health has become the top priority as the explorers light up the torches and looking for new ways to the future. Technologies bring us a bigger world and more creations. By focusing on medical imaging technologies and innovating, Focus and Fusion Healthcare makes high-class healthcare available to everyone, enabling every soul to write their best chapters in life. Technology lights up life.
Konica Minolta point-of-care ultrasound systems provide the power, IQ, functionality, and ease of use to optimally support bedside ultrasound exams and ultrasound-guided procedures. The laptop design of the SonImage HS2 consists of a 15-inch touchscreen monitor that swivels and pivots. The touchscreen interface and streamlined console can both be customized to specific user preferences. Konica Minolta designs and manufactures a full suite of broadband frequency transducers, which are specifically designed to meet the clinical demands of today's healthcare providers. There are 8 transducer options for the HS2 system. User-defined presets can be customized for specific diagnostic and ultrasound-guided procedures. Ultra Adjust is a one-button optimization of multiple imaging parameters and is controlled by adjusting the depth. This feature is designed to enhance workflow efficiency. Available imaging modes on the HS2 system include 2D, color flow mode, power Doppler imaging, pulse wave Doppler, continuous wave, and M mode. Panoramic imaging can be used to create a stitched anatomic presentation. Post-processing options include trimming, zooming, and measurement functions. Konica Minolta's Simple Needle Visualization, or SNV, is a unique, proprietary software algorithm that visually enhances both the tip and shaft of the needle in bright blue. This feature can be utilized with any of the linear or curvilinear transducers and works for both in-plane and out-of-plane approaches. Wireless network connectivity allows for seamless image transfer and patient information retrieval. Remote Assist is a powerful tool that can be used to remotely assist our customers with technical and clinical applications support. Konica Minolta Point-of-Care Ultrasound provides clinicians with the leading-edge technology and advanced applications designed to empower better patient outcomes. The superior image quality, ease of use, and portability of the HS2 provides the tools needed to make clinical decisions sooner. See beyond your expectations with Konica Minolta Ultrasound.
A light of hope to others. As a person of integrity, responsibility, discipline, patriotism, bayanihan, and malasakit.
Biopharma Medical Solutions is an all-Filipino-owned company specializing in the sales, marketing, and distribution of pharmaceuticals and medical devices. Biopharma is proudly composed of experienced sales and marketing professionals with expertise in building brands and fostering client partnerships. We bring value to our clients by offering them high-quality and affordable healthcare products and services. We have provided over 200 hospitals, cardiac catheterization centers, and PET scan centers with the highest quality products and state-of-the-art medical equipment. We are committed to improving the lives of patients and empowering healthcare workers and hospitals through our products and services. From imaging and diagnostics products, we have now expanded into hospital care solutions, orthopedics, oncologicals, and medical devices. We are proud to present the Biopharma product portfolio. OmniHexol is a tried and tested contrast medium for diagnostic imaging and interventional procedures with superior diagnostic efficacy. OmniHexol is manufactured in Korea by Korea United Pharm Incorporated, a multinational and multi-awarded pharmaceutical company reaching over 40 countries worldwide. Due to OmniHexol's excellent safety profile, it has been approved for both pediatric and adult use. OmniHexol is triiodinated, has excellent water solubility, and is less viscous, resulting in better efficacy and minimal adverse reactions. OmniHexol, or Iohexol, is the only contrast media approved by FDA for oral and rectal use. It is well accepted by patients due to its neutral and palatable taste. It is less likely to cause GI distress, and it can be used in cases of barium intolerance. Gasless is a complementary product of Korea United Pharm Incorporated for relief of symptoms associated with abdominal gas. Gasless is given to patients in preparation for abdominal ultrasonography, and it is used to prevent colonic bubbles during CT colonography to significantly improve sound transmission. ZonCare is a leading high-tech medical enterprise and medical equipment manufacturer and service provider located in Optical Valley of China. The main products are color Doppler ultrasound system, ECG machine, and patient monitor. Our partnership with ZonCare allows us to provide state-of-the-art ultrasound systems such as ZonCare N7, a full digital color Doppler ultrasound system. We also offer ZonCare's high-end portable 3, 12, and 18-channel ECG machines, iMac 12, a tablet ECG machine that was a 2016 Red Dot awardee, and a multi-parameter patient monitor. Perlove Medical is a large-scale and influential manufacturer with high-tech imaging equipment, R&D, production, sales, and after-sales service. Their comprehensive product range includes imaging systems and related instruments, ventilators, anesthesia systems, and veterinary products. Our partnership with Perlove Medical allows us to provide our clients with intelligent, humanized comprehensive medical imaging solutions that are multifunctional, highly efficient, and with low dosage. The product line covers a series of flat-panel digital radiography system, surgical C-arm series, and mobile digital X-ray systems with advanced digital imaging technology, producing sharp and high-quality images. LUZON Medical Technologies Company is one of the world's leading manufacturers for ultrasound systems certified by CMD, CE of Europe, FDA of US, CSA of Canada, KFDA of South Korea, and other international bodies. Biopharma is proud to offer LUZON Sonowai, the lightest handheld ultrasound with the fastest response speed that delivers high-quality imaging and provides a flexible connection with a smartphone or tablet. ANDI, or the Automatic Needle Destroyer by Mune, is an award-winning syringe disposal system that is compact and easy to set up and use. Partnership is always at the core of the biopharma business model. We have consistently supported various medical societies through booth exhibits, continuing medical education, and scientific sessions. For 2 consecutive years, Biopharma was given the Best Exhibitor Award by the Philippine College of Radiology. In a highly competitive industry, establishing trust and integrity is a must. Biopharma believes in its greatest asset, its people. Apart from its innovative products, the strength of Biopharma lies on the talent, dedication, innovation, and expertise of its competent workforce. Biopharma has evolved into a strong healthcare partner and a gateway of products from both international and local companies. With ultimate service in mind, Biopharma shall continue to uphold its credo, a shared commitment to quality healthcare by providing high-quality and affordable healthcare products and services everywhere in the Philippines.
The miracle of birth is a beautiful moment. Actronex is an anti-fibrinolytic solution for intravenous injection. It is indicated for obstetric and gynecologic conditions such as menorrhagia, metrorrhagia. Don't let uncontrolled bleeding ruin precious moments. Take control with Actronex.
On and on. It just keeps going. On and on. Look at the discomfort it's causing. On and on. Is there no way of controlling this? Put a stop on emesis with Onzet.
When acid levels get out of hand, it's time to call the authority in acid control. Manage gastric acid secretion with Zepson Injection. Zepson Injection is a proton pump inhibitor which reduces gastric acid secretion in the parietal cell. Keep gastric acid levels in check with Zepson Injection. For every battle we take on, a strong defense is needed. Trust the armor designed to protect against acid-related disorders. Choose Mepraz.
Mepraz is available in 20 milligram and 40 milligram gelatin capsules.
For a strong and reliable armor against acid-related disorders, choose Mepraz.
You're not you when you're in pain. Don't let it take you over. Coax the pain out with Coccidia. Coccidia is a non-steroidal anti-inflammatory drug used in the treatment of rheumatoid arthritis, osteoarthritis, ankylosing spondylitis. Coccidia is available in 200 milligram and 400 milligram capsule. When in pain, take Coccidia. It's programmed to take over pain.
When pain and muscle spasm are constricting you, don't wait for it to take over. Counteract it with Norpreksha. Never let pain and muscle spasm take away your spark. Always counteract it with Norpreksha.
In the treatment of acute pain, go to the root of it all. Lock in the target, lock in the relief. Target the root of moderate to severe pain with Daleks. Targets directly the root cause of pain. Achieve rapid relief with Daleks.
For a safe and secure sedation, choose the one with decades of clinical experience. Give your patience Xylem. Xylem 5 mg per milliliter is a sedative and short-acting sleep-inducing drug of pronounced intensity. Always stay confident in giving your patients a safe and secure sedation. Give your patients their much-needed Z's with Xylem.
Life is always self-involving. Health has become the top priority as the explorers light up the torches and looking for new ways to the future. Technologies bring us a bigger world and more creations. By focusing on medical imaging technologies and innovating, Focus and Fusion Healthcare makes high-class healthcare available to everyone, enabling every soul to write the best chapters in life. Technology lights up life.
Konica Minolta point-of-care ultrasound systems provide the power, IQ, functionality, and ease of use to optimally support bedside ultrasound exams and ultrasound-guided procedures. The laptop design of the SonImage HS2 consists of a 15-inch touchscreen monitor that swivels and pivots. The touchscreen interface and streamlined console can both be customized to specific user preferences. Konica Minolta designs and manufactures a full suite of broadband frequency transducers, which are specifically designed to meet the clinical demands of today's healthcare providers. There are 8 transducer options for the HS2 system. User-defined presets can be customized for specific diagnostic and ultrasound-guided procedures. Ultra Adjust is a one-button optimization of multiple imaging parameters and is controlled by adjusting the depth. This feature is designed to enhance workflow efficiency. Available imaging modes on the HS2 system include 2D, color flow mode, power Doppler imaging, pulse wave Doppler, continuous wave, and M mode. Panoramic imaging can be used to create a stitched anatomic presentation. Post-processing options include trimming, zooming, and measurement functions. Konica Minolta's Simple Needle Visualization, or SNV, is a unique, proprietary software algorithm that visually enhances both the tip and shaft of the needle in bright blue. This feature can be utilized with any of the linear or curvilinear transducers and works for both in-plane and out-of-plane approaches. Wireless network connectivity allows for seamless image transfer and patient information retrieval. Remote Assist is a powerful tool that can be used to remotely assist our customers with technical and clinical applications support. Konica Minolta point-of-care ultrasound provides clinicians with the leading-edge technology and advanced applications designed to empower better patient outcomes. The superior image quality, ease of use, and portability of the HS2 provides the tools needed to make clinical decisions sooner. See beyond your expectations with Konica Minolta Ultrasound.
a line of of hope to others. As a person of integrity, responsibility, discipline, patriotism, bayanihan, and malasakit.
Biopharma Medical Solutions is an all-Filipino-owned company specializing in the sales, marketing, and distribution of pharmaceuticals and medical devices. Biopharma is proudly composed of experienced sales and marketing professionals with expertise in building brands and fostering client partnerships. We bring value to our clients by offering them high-quality and affordable healthcare products and services. We have provided over 200 hospitals, cardiac catheterization centers, and PET scan centers with the highest quality products and state-of-the-art medical equipment. We are committed to improving the lives of patients and empowering healthcare workers and hospitals through our products and services. From imaging and diagnostics products, we have now expanded into hospital care solutions, orthopedics, oncologicals, and medical devices. We are proud to present the Biopharma product portfolio. OmniHexol is a tried and tested contrast medium for diagnostic imaging and interventional procedures with superior diagnostic efficacy. OmniHexol is manufactured in Korea by Korea United Pharm Incorporated, a multinational and multi-awarded pharmaceutical company reaching over 40 countries worldwide. Due to OmniHexol's excellent safety profile, it has been approved for both pediatric and adult use. OmniHexol is triiodinated, has excellent water solubility, and is less viscous, resulting in better efficacy and minimal adverse reactions. OmniHexol, or Iohexol, is the only contrast media approved by FDA for oral and rectal use. It is well accepted by patients due to its neutral and palatable taste. It is less likely to cause GI distress, and it can be used in cases of barium intolerance. Gasless is a complementary product of Korea United Pharm Incorporated for relief of symptoms associated with abdominal gas. Gasless is given to patients in preparation for abdominal ultrasonography, and it is used to prevent colonic bubbles during CT colonography to significantly improve sound transmission. ZonCare is a leading high-tech medical enterprise and medical equipment manufacturer and service provider located in Optical Valley of China. The main products are color Doppler ultrasound system, ECG machine, and patient monitor. Our partnership with ZonCare allows us to provide state-of-the-art ultrasound systems such as ZonCare N7, a full digital color Doppler ultrasound system. We also offer ZonCare's high-end portable 3, 12, and 18-channel ECG machines, iMac 12, a tablet ECG machine that was a 2016 Red Dot awardee, and a multi-parameter patient monitor. Perlove Medical is a large-scale and influential manufacturer with high-tech imaging equipment, R&D, production, sales, and after-sales service. Their comprehensive product range includes imaging systems and related instruments, ventilators, anesthesia systems, and veterinary products. Our partnership with Perlove Medical allows us to provide our clients with intelligent,
Welcome back,
humanized,
everyone.
comprehensive medical imaging solutions that are multifunctional.
We hope you enjoyed the lunch symposium and are ready for more enriching discussions.
We'd like to invite everyone to please move forward, occupy the seats in front so that we can have even more interaction later on. Ladies and gentlemen, for our next session, we're privileged to have with us virtually a distinguished expert in the field. To further introduce our next speaker, we are turning the stage over to Dr. Lorraine Ann Doma, our session chair for the first session of today's event. Let's give her a round of applause.
Good afternoon. Dr. Teddy Fabila is a resident physician in KK Women's and Children Hospital, Singapore, a pediatric anesthesia department and visiting consultant of the Philippine Children's Medical Center. He took his basic anesthesia training at the Hospital ng Manila Medical Center, then joined KKH for a pediatric anesthesia fellowship in 2011, and since then has worked as a staff in the department. Dr. Fabila has more than 12 years of experience geared towards specializing in pediatric anesthesia, pain treatment and prevention, hospital quality and safety, and medical informatics. Dr. Teddy serves as a secretary of the ASPA Pediatric Pain Specialist Interest Group in KK Women's and Children's Hospital. He holds various leading positions such as Pediatric Pain Management Committee, Management of Information for Hospital Quality and Patient Safety, and Medical Informatics for the Division of Surgery. Everyone, let us all welcome Dr. Teddy Fabila.
Mabuhay, thank you very much for the kind introduction. Before I begin, let me highlight that I have nothing to disclose for this talk. Perioperative anesthetic management and for children requires meticulous and targeted high-quality delivery. To capture and act on well-defined, meaningful, and relevant clinical outcome measures to drive further patient-centered improvements, a group of experts created a core outcome sets to improve consistency across clinical trials and help facilitate the conduct of the high-quality systematic review. This group of international investigators and clinicians collaborated in developing the Pediatric Perioperative Outcomes Group, or PEOPLE, whose aim is to use core outcomes measures in effectiveness trials, or COMET methodology, to develop core outcome sets for infants, children, and adolescents that are tailored to the priorities of the pediatric surgical population. Based on their review, patient comfort is the most common outcome domain from the infants to adolescents. This means parents and patients in this age group value patient comfort outcomes such as pain assessment and treatment with its clinical and psychological implications if left untreated. Hence, we, as anesthetic providers for children, should ensure that they are pain-free during their perioperative stay. One way of achieving this goal is to advocate regional anesthesia in our practice. Recently, there has been a rising trend in using regional anesthesia in children. The number of articles published has doubled in the last 5 years and tripled in the last 10. The advantages of reducing opioid use, faster recovery pathways, and higher satisfaction scores in children and their parents have laid the ground for clinicians to include regional anesthesia in the perioperative care of children. For this talk, I will be answering the following questions. What are the unique challenges in pediatric regional anesthesia? Is pediatric regional anesthesia safe? Is it safer to provide regional anesthesia when the patient is awake or asleep? And what are the roles of regional anesthesia in pediatric ERAS? The techniques of most peripheral nerve blocks in children are adopted from adults due to the grossly similar anatomical locations of peripheral nerves. However, children are not small adults and have many differences in the conduct of regional anesthesia compared to adults. Certain differences in children, like better visibility of structures in ultrasound, superficial targets, thinner fascia in sheets, faster onset of blocks, and lower concentration of local anesthetic required, can be used to advantage. Infants have an increased cardiac output and immature hepatic function in both sympathetic and clearance pathways, which can result in increased systemic absorption and accumulation of local anesthetics. The accumulation of local anesthetics potentially increases the risk of local anesthetic systemic toxicity, or LAST, especially with repeated bolus doses or continuous infusion. There is an increased potential for local anesthetic systemic toxicity with amide local anesthetics in neonates and infants due to their immature microsomal enzymes and lower plasma levels of alpha-1 acid glycoprotein. The alpha-1 acid glycoprotein that extensively binds amide local anesthetic agents in plasma is significantly decreased at birth, contributing to an increased free fraction of the drug in newborns, thereby potentiating the risk of toxicity. For these reasons, a decrease in maximum dose, may that be at your bolus dose or infusion, is recommended for amide local anesthetic agents in children aged less than 6 months. Then we ask, is pediatric regional anesthesia safe? Safety data of regional anesthesia in pediatrics was not as robust as in adults, despite literature supporting its feasibility, efficacy, and safety in the hands of experienced practitioners. Emerging literature from large datasets and clinical practice patterns support that the evolution of innovative techniques in anesthetic management of pediatric patients with regional nerve blocks can be safely provided. The Pediatric Regional Anesthesia Network, or PRAN, the European Society of Regional Anesthesia and Pain Therapy, or ESRA, and the American Society of Regional Anesthesia and Pain Management, or ASRA, Practice Advisory in Pediatrics, provided safety data updates on regional anesthesia and its unique role in impacting high-quality anesthetic care in children. The PRANS database was established in 2017 to evaluate the common practices and risks or complications associated with regional anesthesia in infants and young children. The first analysis published by PRAN database was in 2012, which included 14,917 regional blocks, concluding that complications from all regional anesthetic techniques occur at very low rate. In 2014, the group prospectively collected data on over 50,000 blocks and found that placement of regional anesthesia blocks in pediatric patients under general anesthesia was safe, as placement in sedated and awake pediatric patients. Since then, the group nearly doubled the amount of data collected from regional anesthetics performed on pediatric patients and recently published its data in 2018. It consists of over 100,000 pediatric regional blocks performed, providing a robust body of data to support the safety of regional anesthesia in children. The PRAN 2018 analysis found no cases of permanent neurological deficits. There are 25 cases of transient neurological symptoms at a rate of 2.4 per 10,000 cases. There were no cases of permanent motor deficits on this data set for both peripheral and neuraxial blocks. Severe local anesthetic systemic toxicity occurred in 7 children at the rate of 0.76 per 10,000. Significantly, the use of ultrasound guidance and test dose did not alter the risk of incidence of local anesthetic systemic toxicity. The greatest risk was found to exist in infants less than 6 months of age for the reasons that we have discussed earlier on. There were 92 cases of local cutaneous infection in patients with continuous catheters and an incidence of 53 per 10,000 cases. A higher rate of infection was associated with neuraxial catheters. Infection rate was also associated with increased duration of use, with an average increase in chance of infection by 6.7% for each additional catheter day. No infections were associated with single-shot injections. Regional anesthesia has been successfully described in awake children for short duration of surgery. Potential advantages of awake regional anesthesia include early detection of symptoms of local anesthetic systemic toxicity, reduced risk of intraneural injection, permanent nerve damage, and complications associated with general anesthesia, including opioid-related adverse effects. However, in pediatric patients, awake regional anesthesia may not always be practical and may be associated with increased risk of failure or potential harm. Causative factors include high levels of patients' anxiety, uncontrolled movements during the performance of a block or even during surgery, and difficulty in assessing the intensity of painful stimuli reported by young patients. This will also need to factor in the surgical experience and comfort during surgery wherein the patient can potentially move. In the 2018 PRAN study that I shared earlier on, the risk of neurological complications or severe local anesthetic systemic toxicity was 2.2 in 10,000 cases for nerve blocks performed under general anesthesia, and 15.2 in 10,000 cases for blocks placed in sedated or awake patients. Such risk remained higher even with adjusted age and validated findings from a previous analysis. Nerve injuries in both studies recovered without sequelae. The American Society for Regional Anesthesia and European Society of Regional Anesthesia Committee advises that given the acceptable safety record and pediatric regional anesthesia performed under general anesthesia or deep sedation should be considered the standard technique in children. Careful patient selection is the key to identify the few highly motivated children where awake regional anesthesia be a viable option. Not only the patient factor, we need to consider also the skill and the comfort level and expertise of the anesthetist who will be doing the case. Enhanced recovery after surgery, or ERAS protocols, are applied in many fields and surgical procedures. Regional anesthesia is an important element of ERAS because it allows optimal analgesia, reduces opioid requirements, and facilitates earlier return of bowel function and ambulation. The review article of Yamamoto and Schindler highlighted the significant role of regional block in early recovery following cardiac surgery. Based from their review, the combination of peripheral nerve blocks, for example, the musculofacial plane block, is very promising for reducing intraoperative opioid consumption, time to extubation, postoperative pain score, and length of hospital stay after pediatric cardiac surgery. In summary, I would like to highlight that children are not small adults and have many differences in the conduct of regional anesthesia compared to adults. Necessity is the mother of all inventions. The evolution of innovative techniques in the anesthetic management of pediatric patients with regional nerve blocks has increased safety margins and efficiency. The American Society of Regional Anesthesia and European Society of Regional Anesthesia Committee advises that pediatric regional anesthesia should be performed under general anesthesia or deep sedation. Regional blocks have a role in the early recovery of children facilitating fast-track protocols even for complex procedures such as cardiac surgery. Neonatal pain treatment and prevention is very challenging, more so if you want to provide regional blocks for this age group. Nipping the pain issues at a very early stage of onset requires precision and creativity. Learn more with our experts and join our next webinar organized by the Asian Society of Pediatric Anesthesiologists Pain Special Interest Group. And you can scan the QR code to register. See you all tomorrow at 5 p.m. Maraming salamat po.
Live link from Singapore. So any questions from the floor? Yes, Dr. Consuelo.
What's the dosages? Was the usual dosages discussed? Because I wasn't here earlier. Was it discussed? The usual dosages for nerve block using bupivacaine. Was there the usual dosages
for
pediatric patients for nerve blocks? Also, for fascial plane blocks, there should be a difference, right, for the nerve blocks and the fascial plane blocks. So, I don't know if it was discussed. I wasn't here.
Hey, hi, good afternoon, everyone. Thank you for your invitation. It was not discussed. It's not part of the objectives of the lecture. But going back to what Doctora's question regarding the dosing, with regards to dosing of local anesthetics, both for, let's say, for example, myofascial block and targeted peripheral nerve block. Yes, there's a difference, mainly because of the volume that we are giving. For peripheral nerve block will be different from the for any myofascial, muscular fascial blocks that we discussed earlier on. So what we usually do, what are guidelines for pediatric setting, especially for us. For regional anesthesia, of course, it's targeted, so it's less volume. So as much as possible, we can actually, the concentration that we target for any regional anesthesia or peripheral nerve block is 0.2%. May that be levobupivacaine or bupivacaine. It depends, of course, of the preference of the one providing the block. So having said that, it's 0.2%. So it depends on what's the type of block that we are giving. If, let's say, for example, if I'm giving a block, I give you a case, let's say, for example, it's a thoracic procedure, right? So it's a paravertebral block versus erector spinae block, correct? So I will actually give 0.2%. Right, concentration for bupivacaine for that particular case. And for volume-wise, it will play along on what level am I planning to block, or how long, or what is the actual target of the block. But what we provide in our center is that we should not exceed the toxic dose that the patient should have. So it's calculated first on the toxic dose of the patients, which is, for example, for bupivacaine, it will be 2 milligram per kg. So it will set from there. So that from there, we will set the maximum volume that we can use for this particular patient. You need to be mindful that different experts or different specialists who's providing the block will have different skill set. Some of them are very, very, very advanced that will only, for paravertebral block, that will only use minimal volume of local anesthetics that will not even exceed the maximum dose that we set. However, of course, if the one providing the block is some like a fellow or just starting to start the training and all that, then the volume can actually be more than the standard local anesthetics that we are actually giving. So long and short of it, regardless whether we are giving a paravertebral block or a myofascial block like erector spinae block, for the case that I just mentioned, we usually set the toxic dose and the maximum volume for every patient that we are actually going to. Then we set the concentration at 0.2%. Then from there, we adjust accordingly. There's no fixed specific concentration or volume, or specific volume with a set concentration that we usually use. And it greatly depends on the end users or the staff who's conducting the regional anesthesia. Yeah.
I guess Dr. Fabula was able to answer your question, Dr. clearly. Thank you, Dr. Fabula. Any more questions from the floor? So earlier we discussed about the doses. How about for the techniques? But I mean, or awake, asleep? How do they practice it there compared to us? Any more questions? Yes, Doctor.
Hello po, Doctor. Considering po the potential limitations of ultrasound guidance in pediatric patients, particularly involving those with smaller structures, what advancements or techniques are being explored po to overcome these challenges and enhance our precision during our nerve block procedures po?
Thank you for the question. Can you hear me?
Yes.
Yeah, all right. Okay. So, yes, ultrasound guidance is very essential for regional anesthesia for pediatrics because, like I mentioned earlier on, right, the limitation is that we are limited with the volume that we can actually use because of the toxic dose. And anatomy is different. And as much as possible, you try to be more accurate since you don't have much room to play with. So, technologies apart, ultrasound that we are currently, of course, preparation is the main important thing for every regional anesthesia. Simulation, we have this for let's say every 3 months, like all of our rotating residents, even our own staff in our center will have this what we call maintenance of skill, wherein we conduct our own regional anesthesia simulation, wherein we actually conduct this special session wherein everybody will have their own practice. Because why do we need to do this on a quarterly basis? Mainly because the candidate for regional anesthesia in a pediatric center may not be that much, right? Our practice sometimes is not as big in terms of numbers as compared to adults. So we need to maintain our skills by conducting this regular simulation of regional anesthesia. That's one. That's more for the preparation. And second, of course, we have this specialized group in regional anesthesia in our center, wherein that they will come to assist you for any difficulties in help. One of the factors that we noticed is that if you don't do much, especially for smaller patients, the skill set and hand-eye coordination will be more difficult as compared to adults, since your structures are smaller. And on top of that, sometimes it will be quite challenging to have a help. So you better make sure that everybody in your center will be equipped with the skill, but you have a special group that can assist you anytime as well. Yeah. So on top of that, if you're asking for technology like another on top of our ultrasound, currently in our center, we don't have much as part of the ultrasound that we are having as an assistance in conducting the regional blocks for all our pediatric patients. Yeah.
Okay. I think the answer of Dr. Fabula is very much satisfactory, and maybe perhaps that's an area that we could explore later on. Are we still allowed another question from the floor? Yes, Doctora.
How do you explain or prepare young children who cognitively that they may wake up with numbness of the limbs after peripheral nerve blocks for surgeries? Are there special instructions that you do?
Yeah, thank you for the question. Yes, we do have a part of our consent taking. We have information sheet. So we're not only educating our patients, but we're also educating our parents. During consent taking for the regional blocks, we have like a pamphlet that we actually share to our parents and patients that inform them of what the expectations after regional blocks. So it provides whole information of what the expectations are. Then at the same time, of the possible complications and risks that we, the patient, might encounter after the regional block. On top of that, part of our education, even before the patient gets scheduled for any surgery, part of it is that we have this educational video, part of our preparation for all our patients. So before they even get scheduled, either day surgery case or inpatient case, so this video will be part of their educational material. So there are various layers of educational material. The patient and the parents will receive the educational video. Then upon arrival in the hospital, then during the consult taking, we will give them another flyer informing them about the possible risk and even the complications. We're not just discussing with them the possibilities or the risks that you just mentioned just now. We even inform them of who to call in terms of emergencies, right? Let's say, for example, the numbness persists. So we have a hotline as well that they can call, that they can actually ask in worst case scenario that the nerve block persists. Because some of them actually will go home at the same day, right? They will even go home in like a day surgery. So we need to follow up on them the following day. And if nerve block, the effects of it, like side effects like numbness and all that carried on for a couple more days, then they have a hotline that they can call us. Then we will see them either in emergency room if need be, or in we can schedule the closest clinic schedule where we can evaluate them. Yeah, those are the things that we inform and the process and the workflow that we have for our patients coming in for regional blocks.
So, due to the interest of time, that would be the last question that could be entertained by Dr. Fabula. So, Dr. Fabula, thank you again. In summary, for this session, we advocate regional anesthesia in children. Regional anesthesia can be safely performed. And as mentioned earlier, the standard would be to perform regional anesthesia under sedation or general anesthesia. And of course, our thrust is to give high-quality anesthetic care in children. Thank you.
Thank you very much, Dr. Doma. And of course, it's always a pleasure to have Dr. Fabula gracing our event this afternoon. And of course, to all of our participants for making the discussion very engaging and informative. We understand that the postprandial sleepiness is setting in because of that wonderful and sumptuous lunch we just had upstairs at the penthouse. So to make it lively for everyone, we're going to slow it down a little bit, and we're going to have an exciting raffle prizes will be given out to everyone.
We're going to inject in some fun.
So we'll make it a little fun and make it a little more interactive. So we'd like to call, of course, Doctors Genuino and Samar for the special raffle prizes, courtesy of Gentri Medical Center. A round of applause, please. So hang on everyone kasi madaming prizes. They're still sorting it out. Dami. Doc June?
Okay, yun. Sa mga participant ditong Raspil, no? Gusto namin, dito sa GentriMed, ang ugali namin, gusto namin everybody happy. Walang aalis na hindi happy. Kaya magpaparapol si June, meron din kaming contribution magpaparapol. Meron kami, ano yung unang parapol mo?
Sir,
overnight, ano?
Sir, yung one day stay.
One day stay saan yun? Saan hotel?
Sa anong hotel nga ba yun? Courtesy of
Sino ba
Wentz
nagbigay?
Pharma.
Wentz. Oh. Ang Gentri Med, 1 month. 1 month stay dito sa Gentri Med. Mamili na kayo, ICU, isolation. So 1 month.
Yes,
Ngayon, to make everybody happy, meron kaming pinagawang isang token, ano, na siyempre may laman niya. Lahat kayo may cellphone, lagayan ng cellphone. So, at saka, lahat tayo sumusulat alcopen, kasama ng spray, refillable. So, ito yung, lahat magkakaroon nito. Pero yung raffle, I think, ilan ba ang attendees dito? Kasi meron kami mga 62 items na pinipin. Pero kung more than...
Sir, mukhang mananalo lahat.
Lahat pala. Hindi everybody happy. Oh, pa-distribute mo na ito lahat. Itong ganito, pa-distribute mo na. Ito pala. So ito raw yung mga ipaparapol. Ayan.
Papamigay. Pwede naman ilabas.
Bakit wala rito yung yung 1 month stay sa hospital? Yeah, okay. Hindi, distribute mo na habang nanonood sila lahat. Para pag nanalo sila, meron silang lalagyan ng panalo. Jun.
Yes, sir.
Last na yung yung overnight stay.
Yes, sir. So, since lahat naman ay kayang mabigyan.
Paano ba gagawin dito?
Yes, sir. Sir, ito yung para sa hotel.
Sa hotel?
Yes,
Unahin
sir.
mo ba yan?
Yes, sir.
Okay, okay.
Since lahat naman ay mabibigyan, hindi na natin ipaparaffle yung giveaways. So, siguraduhin nyo lang na naandito kayo sa list. Kailangan nakapag-register.
Ito ba Jun talagang
Sir, walang daya, sir. Walang
Walang daya?
daya.
Kasi
Yes, sir.
iba-iba yung item Ganyan na rin natin. Iba-iba yung item na ipaparapol. Kasi kung hindi natin mapipili, ganyan na rin natin.
Yan na rin, sir. Sir, pag
yun, kasi
pag nanalo na,
hindi natin
tanggal na. Tatanggalin na sa list pag nanalo na, sir.
Ganun?
Yes,
Ilan
sir.
ba yan?
Lahat, sir, lahat ng
Ilan yung nag-register?
nag-register ay naandyan.
Kasi 62 items to Ilan ba yan?
Oh.
62 items to
So,
75? Di hustuhin mo na lang. Sige, dali mo. Kasi hindi lahat mabibigyan
Parang wala yung pangalan ko.
Nang pare-pareho, Jun.
Si Sue. Ayan.
6, ilang kamo?
Dok, parang
Ako, wala ako eh.
Ay, yung kayo?
Wala ako eh.
Hustuhin mo na 75.
Wala kami
62. Hindi, meron kayo kasi special May special gift
Ayaw
sila.
nga pala. Yes, sir.
May special sila. Kaya, okay. Simulan mo na.
Okay, so...
Alin ang unahin mo? Ito yung...
Sir, eto muna, sir.
Sige. Pero individual ito.
Yes, sir.
Itaas natin. Okay, 1, 2. Look, Jun.
Hindi nyo man lang tulungan. Sila pa nagbubuhat. Text pa kayo ng text.
Sir, ang isang panalo, sir.
Ha?
Isang set. Isang set.
Hindi.
Isang item.
Isang item. Gusto mong... Kasi 62 lahat yun items. Pero pinadadagdagan ko para maging 75. Sabi niya 75. Patadagdagan ko na lang ng bag. Ilan to? 62. 75. 75 minus 62.
Per share.
Ha? 13. Kumuha ka
Ano
ng
ba tawag?
4 pang malilit na bag. Dahil share. Tapos... Ilan lahat yung tumbler natin?
May lupa pala ako dito.
Ilan yung tumbler natin?
Kasi malapit lang.
Okay, we may spin the wheel now. This is for the most minor prizes. Neil Ronyo. Next. Okay. Spin it again. Jamie Lasam. Spin it again. Okay lang. Alex. Doc Alex Karungkong. Next. Make it faster, please. Sige, spin again. Sir? Ito muna, sir. Yes, sir. Toreno. Doc. Toreno, Olimpio. Wala. Okay. Spin. Sige, sir. Denise.
Cabral. Yun, may background music. Background
Spin
music
some
na
more.
tama yan. Okay yan. Masaya daw na background music. Danceable.
Elika.
Aldo. So yung ano,
Sir?
yung gawin mo na lang, kung ano tao pa wala, hindi, iba-iba. Para hindi naman puro ganun ang nakuha nila.
Oh, sige.
Di ba?
Sige, sir.
Halimbawa, kumuha ka dito ng isa, kumuha ka dito.
Sige, sir.
Random na lang.
Okay, sige,
Para
sir.
hindi puro ganun. Para hindi.
Medyo mahina ang palakpak. Taasan natin ng konti. Lipat tayo sa tumbler. So, spin for a tumbler.
Music, please.
So, this is a commemorative tumbler with the Raspil logo and First World Regional Anesthesia Day. Commemorative. Another tumbler. Please spin.
Reyes.
Reyes. For Mag, please spin. Arbil, you're a winner.
Ay, wala.
Joey. Nasa Cagayan de Oro yan si Joey. Congrats, Joey. Okay. Jill Ortilla. So, this is for a mini USB fan.
John.
John Carenda.
Wala. Huertas. Ina Reina Huertas. Wala din. Search live. Okay, the next prize is multifunctional searchlight. Yes? Okay. Sige. Ano na? Sige, sige. Ano ba tawag dito? Herschel bag with alagang Gentri med. Palakpak. Okay. Okay. Roll. Wado, Jaser. Another bag. Please spin the wheel. John Christian Lago. Congratulations. Wala. Nako. Oo, another bag.
Pagbabae, pink.
Yun. Doktora Hugarman Lapat Dindi. Yes, sir.
Babae yun, babae?
Babae, babae rin to, sir. Hindi, mapili natin ka, sir. Rochelle Sevillano, President, PSA, Southern Tagalog Chapter. Doc Rochelle, panalo kayo. Okay. Ay, sir. Later na lang uli kaya, sir. Later na lang. Mamaya na lang uli. Magle-lecture na muna uli.
Oo, lecture lang. Akala ko ubusin niya.
Hindi, sir. Oh, last one, sir. Okay, last one for the... Video, okay? Wireless karaoke speaker. Okay, roll down sa ulog. Pwede na mag-video, okay? Okay. Wala? O, isa pa. Spin it again. Mafe Atilano. Wala. Spin again. Spin. Arian. Ayun. Oh, thank you very much, Dr. Jerry Muhinwino. And we'll be back to the lecture proper.
Thank you very much, Dr. Genuino and Dr. Samar. Don't worry, for those who have not won anything just yet, your names are still there and you're eligible. Nakita niyo naman po how generous Dr. Genuino and his team are. So, marami pa pong prizes to be won.
And if ever hindi man kayo palarin or gusto nyong bumili ng mga ganyang merchandise, they actually have a booth upstairs on the 6th floor. If you haven't visited, maybe later you can drop by.
But now we'll go back to business in hand. Our next session brings us two distinguished experts who will delve into critical aspects of regional anesthesia. First up, we have Dr. Philip Romel Ascalon, who will enlighten us on RA techniques in ER and trauma medicine. Following Dr. Ascalon's presentation, we'll transition to another vital topic, right?
Airway blocks for awake intubation to be presented by the esteemed Dr. Numeriano Samar Jr. And so get ready for an in-depth exploration of techniques that are crucial in emergency and trauma settings. Over to you, Dr. Samar.
Dr. Ascalon?
Dr. Ascalon first, sorry.
Hello, good afternoon, colleagues. I'm sure you are awake now because of the raffle. I am not awake because I didn't win. Ayun nga pala. Sige. Anyway, I'll be lecturing on regional anesthesia in the ER and trauma medicine. Okay, and open your hearts and your minds so you will be able to imbibe whatever new lessons you will learn today. Carl, paano to? Hindi, ayaw. Ano yung pipindutin lang ng...
Yes, sir. Tapos, this will be your pointer, sir.
This one?
Pointer.
Meron ba? Ayan, okay. Hi. Disclosure, I have no actual or potential conflict of interest in relation to this presentation. Okay, so this is the outline of my lecture. 1, introduction. 2, regional anesthesia in trauma. 3, specific injuries. And 4, my conclusion. Okay, introduction. So the incidence of trauma, it is the leading cause of death up to 45 years old, and is the 4th leading cause of death for all ages. There are 5 million deaths annually. So I'll be showing here the number of deaths for leading causes, for the leading causes of deaths. Okay, it is important to note. Sorry. Carl, sandali ah. Ayan. Ito yung pointer. Yes, sir. Sige, sorry. It is important. Bakit wala?
Parang hindi nakikita pala dito.
Ha? Ayaw. Sige, sorry. So it is important to note here that it is the 4th number cause of death, compared to the other causes of death, it being very significant. Okay. The challenges of the management of acute pain in a trauma patient is the prioritizing of the resuscitation and treatment of life-threatening injuries, and that's why the pain control is delayed until the patient is stable. Another challenge is undertreatment of pain or oligoanalgesia. And thirdly, the use of opioids. Because as we know, opioids are usually used for moderate to severe pain. So, but with patients with, you can use this in caution with patients with hemodynamic instability. You can use this with patients with respiratory depression, as it might aggravate the situation. And also opioids have sedative effects, which might cloud the inaccurate assessment of head and or spinal cord injury. Okay, we are all anesthesiologists, and we know that the side effects of opioids, which are nausea and vomiting, constipation, delirium, hypotension, respiratory depression, and pruritus. So you have to use these drugs with caution for patients in pain in the ER department. So the alternative with those side effects, these are the alternative options for pain management. NSAIDs, acetaminophen, gabapentoids, ketamine, corticosteroids, and of course, regional anesthesia. Okay, 2, regional anesthesia and trauma. So musculoskeletal injuries is common in trauma, and extremities are usually affected. Injuries with a high pain intensity have extremity involvement, 60%, of those brought in the ER have injuries with a high pain of intensity. Upper and lower extremities, 18% have upper and lower extremities affected, and 30% have two or more extremity injuries. So regional anesthesia or peripheral nerve blocks. These provide high-quality analgesia. They are site-specific. They are devoid of any systemic side effects, such as opioid-related side effects. You have a decreased length of stay in the emergency room or critical care unit because it's devoid of the side effects of opioids. It's more accurate. You can have a more accurate neurologic assessment. You have comfort and safety in the transport of patients, and it's very cost-effective. So it also prevents the transition of acute pain into chronic pain. 77% of patients with severe musculoskeletal trauma may develop post-traumatic chronic pain. So the risk factors for the development of chronic pain is the intensity of pain during the time of injury. Regional anesthesia significantly reduces acute pain in trauma. Okay, so you have a dilemma if we're gonna do a single shot or a continuous peripheral nerve block. A single shot regional anesthesia or peripheral nerve block can provide analgesia for 16 to 24 hours, whereas continuous peripheral nerve blocks prolongs the duration of analgesia. As long as you have the catheter in there and you have the drip, it can prolong for days, no, the control of pain. The advantages of continuous peripheral nerve block, it can be left from days to weeks. This can be used in repeated debridement, fracture fixation, skin grafting. Pumps can be programmed to deliver low concentration of local anesthetic, for example, by using 0.1 to 0.2% ropivacaine. And higher concentrations can be given for surgical anesthesia without reinsertion. In spite of the advantages, continuous peripheral nerve blocks has its disadvantages, which are catheter-specific complications such as kinking, dislodgement, infection. This is more prevalent in the ER trauma or ICU setting, where in the area where the blocks will be placed is not as sterile as the operating room. It can also reach toxic plasma levels, especially for multiple catheter placement. So to prevent this, use a lower concentration of local anesthetic. Intermittent boluses is better than high concentration infusions. Okay, so why do we use regional anesthesia in the emergency department? Here are the indications. Reduction of fractures, dislocated joints, repair of lacerations, and chest tube insertions. Okay, who can use regional anesthesia in the emergency department? So as of now, anesthesiologists are the most qualified or the gold standard to do that, no? Because we are the ones who are trained for this. But there is also alternative emergency room physicians. No? Later on, I will expound on this, on how they can be involved in controlling pain in the emergency department. And ER nurses, so if the emergency room is very toxic with a lot of patients, ER nurses can also help, not necessarily giving the regional anesthesia, but to help and assist the physicians. So they are called physician extenders, and they are the last resort for large volumes of patients. So PNB significantly improve clinical flow and decrease the length of stay in the emergency department compared to procedural sedation. Because as I've said, with PNBs, you can discharge the patient faster, okay, without many side effects. Regional anesthesia in pre-hospital setting. So these are giving regional anesthesia in an hospital setting. It provides pain control in the field or during transport to the hospital, but it depends on the skill and experience of doctors and the severity of injury. In Western countries, it's an added rotation, no, for anesthesiologists in large trauma centers, because sometimes they get transported, their help is needed, and they get transported to the site of accidents or injuries, and to assist in relieving the pain of patients upon transfer. And then the block techniques which can be done in the field, these are just examples, no? But it's not confined to that. Supraclavicular block for upper extremities, fascial or sciatic blocks, or femoral blocks for lower extremities. Okay, so we'll go now to specific injuries. Okay, number one, this is very common, hip fractures. It has significant morbidity and mortality. Older patients can have multiple comorbidities which need to be addressed first, no, before the pain control. 95% of hip fractures are fall-related. The pain intensity is moderate to severe, and the only effective procedure to reduce the pain intensity is peripheral nerve blocks, right? Such as femoral nerve blocks, fascia iliaco block, and pen block for hip fractures. So this has a significant reduction in opioid requirements perioperatively. Okay. The use of a catheter is beneficial while waiting for medical clearance and scheduling in the OR. It allows patients to sit up, move in bed, breathe deeply, cough with reduced pain. It reduces complications such as pressure ulcers, pneumonia, and delirium in elderly patients. Okay, next we go to rib fractures. It is the most common injury with chest trauma. Comprises 12% of all trauma admissions. Its associated mortality rates is 5% for 1 to 2 ribs, 15% for 3 to 5 ribs, and 34% for 6 or more ribs. The causes of mortality is because of maybe pulmonary injury, because of the edges of the rib fracture rubbing into the pleura, and acute respiratory distress syndrome. So the acute respiratory distress syndrome it has significant pain and may limit the patient's ability to breathe adequately. The lack of deep inspiratory size and shallow tidal breathing results in atelectasis, ventilation perfusion, mismatching, hypoxemia, pneumonia, and respiratory failure. Chest physiotherapy to clear the lungs of phlegm is not advised because of chest wall pain. So effective analgesia is the goal, as surgical fixation is not performed in these cases. The goal of therapy is to minimize respiratory depression and optimize respiratory or diaphragmatic excursion. NSAIDs can be used for mid-rib fracture pain, mild rib fracture pain, but can potentiate bleeding in patients who have vascular injuries or taking anticoagulants. Opioids can cause sedation and respiratory depression, which can aggravate the situation. So we can do thoracic epidural anesthesia to relieve the pain for rib fractures, which is effective for bilateral injuries. It decreases the daily requirement of mechanical ventilation by half, but the contraindications are as follows: hypotension, coagulopathy, head or spinal injury, and sepsis. It is performed infrequently in patients who are sedated or under GA without patient feedback for spinal cord or stick injury. Another alternative for rib fractures is paravertebral block. It is an alternative regional anesthetic procedure for unilateral and bilateral injuries. A catheter technique can be employed for longer duration of analgesia. It is equivalent to TEA or thoracic epidural anesthesia in terms of pain relief for the improvement of respiratory functions and a less incidence of pulmonary complications. The risk of paravertebral block, epidural spread of 1%, pneumothorax 5%, hypotension 5%, and vascular puncture 4%. Other alternative treatments for rib fractures are intercostal blocks, but has a limited duration and a high risk for pneumothorax, and has fast systemic absorption, so the duration of the effect of this is less and faster. Intrapleural block with local anesthetic, it has limited efficacy and also has a fast systemic absorption, and a transdermal lidocaine patch. Okay, regional anesthesia is also good for digital injuries or complete transection of the digits, or an extremity. The goal is to receive optimal blood supply and avoidance of vasospasm and thrombosis. So brachial plexus blocks can be used here. It provides sympathetic blocks, which interrupts vasospasm and provides maximal vasodilation. It also reduces hypercoagulability state to prevent thrombotic events, relaxes muscles, and prevents inadvertent movement during reimplantation. It provides excellent analgesia preoperatively. So as we know, when we introduce a local anesthetic to a certain part of the extremity, this causes vasodilation. So this can preserve the vascular supply of the reimplanted extremity for good vascularization. Okay, for shoulder dislocation, most of the time, what they do in the emergency department is procedural IV sedation. So they use propofol, ketamine, etomidate to produce muscle relaxation and to treat the shoulder dislocation. But then, when you sedate a patient, it needs fasting of at least 6 hours because of the risk of pulmonary aspiration. And the risk of hypotension with IV sedation, with propofol, and can also cause respiratory compromise. An alternative in regional anesthesia is an interscalene brachial plexus block. It gives profound shoulder girdle muscle relaxation by anesthetizing the superior trunk of the brachial plexus. It does not require sedation. It has excellent post-procedural pain control, and after doing the procedure, you can discharge the patient right away without the patient being groggy or sedated. Okay, another specific injury encountered in the emergency room is acute compartment syndrome. It is a pathologic syndrome arising with the pressure within a closed compartment, which rises above a capillary perfusion pressure, compromising the circulation and tissue function within that space. So the result of a high energy injury to soft tissue with crush or a perfusion injury, but has also been reported with arterial puncture, circumferential dressings, burns, and snake bites. 1/3 of cases are associated with proximal tibial, 6 to 10%, and fractures of the forearms, that is in areas packed by muscles. And this can be fatal. So as you can see here, I hope you can see the pathophysiology of ACS. So you get trauma, bleeding, and local tissue damage. It increases tissue pressure, which increases venous pressure, increases the arterial pressure in that extremity, which causes increased vascular spasm, vascular resistance, ischemia, and tissue death. Okay? So surgical treatment for this is emergent fasciotomy to release the tense muscles from the inelastic osteofascial compartments. And there's a golden period, no? Which should be done within 3 to 6 hours. If beyond 3 to 6 hours, you'll have these complications, which is ischemia, myonecrosis, rhabdomyolysis, myoglobinuria, acute tubular necrosis, and hyperkalemia. Anesthetic considerations. Okay. You have the dilemma to block or don't block. Okay. ACS is primarily diagnosed on the basis of pain out of proportion to the injury, or passive stretch, and paresthesia. So in some centers, in surgeons or orthopedic surgeons, they base the diagnosis of ACS through the increasing severity of pain. Okay? So if you block the extremity, you will be able to control the pain. The pain would be lessened because of your block, and then they'll have a hard time, as they say, to diagnose ACS. But it only has a predictive value of only 11 to 19%. Okay? So as I've explained earlier, regional anesthesia, you have a dense block which may mask the syndrome. So this is controversial. Do not give regional anesthesia because the regional techniques may mask the developing syndrome. Compartment syndrome is traditionally diagnosed with increasing severity of pain. On the other hand, on another school of thought, you can give regional anesthesia because it will relieve the patient of the pain and suffering. Imagine the patient is in pain and you won't give any pain medications for the assessment of ACS, okay? So better yet, you can give regional anesthesia. And serious injury normally would cause pain and increased severity is subjective. So meaning, for those patients, different patients have different pain thresholds, no? So sometimes, yung patients with a higher pain threshold, they would feel not so much pain, no? Even if the patient is already developing ACS. On second thought, on the other hand, other patients who have low pain threshold might give you a high pain score, no? But then, even if the patient is not yet experiencing ACS. So it's very subjective. So the assessment of pain is useless in a sedated patient or one with decreased sensorium. Alternate ways to assess compartment syndrome, such as pressure monitoring. So there's another method, which orthopedic surgeons also use, which is the white side method. So I'll just stress on this, that to date, there are no cases of regional anesthesia delaying the diagnosis of ACS. Okay. So we as regionalists, or regional anesthesiologists, better to give, the patient regional anesthesia or a good pain control, no, because there is another method of assessing pain. So this is the white side method, or the ACS pressure monitoring. So this is what they use. You get a 20 ml syringe and you connect it to a 3-way stopcock, and then you'll have a IV extension tubing, no, and a needle, a gauge 18 needle, at the end. On the other hand, you can use a mercurial manometer, no, yung pang BP. You can attach it on the other end of the 3-way stopcock. Okay. So when you push down the plunger of the 20 ml syringe, when there is no pressure, or when the patient doesn't have ACS in the leg, the manometer pressure will not rise, no? Or the mercury will not rise. Okay, so normal tissue pressure is reportedly approximately 0. So when you push the plunger of the syringe and there's a reading of 10 to 20, no, up to 30 millimeter mercury, so there is a possibility that the patient is already experiencing ACS. Okay. So next, let's go to head trauma. So scalp blocks, now for head trauma, has been an alternative to GA in areas which are lacking in resources for neurosurgery. This can also be used for scalp laceration secondary to trauma. Analgesic effects extend up to the postoperative periods, and in countries with limited resources operating under scalp block and continuous neurological examination has been shown to be effective. Now, as si Dr. Alili ata of Bacolod, she was telling this story before in one of her lectures, that in some remote areas, no, mga sa provinces, there are head trauma injuries, and sometimes they do like yung mga burr-holing under local anesthesia because of the lack of resources, lack of anesthesia machine, or in some regional hospitals. So you can still perform, not the surgical procedure, even yung mga suturing of lacerations of the head with just using regional anesthesia. Okay, so this technique consists of blocking 6 nerves, no? Supraorbital, supratrochlear, zygomatico-temporal nerve, auriculotemporal nerve, the greater occipital nerve, and the lesser occipital nerve at the posterior side. So blocking these nerves, you'll have a complete scalp block. Okay. Now let's go to facial trauma. The face is among the common anatomical sites for the utilization of regional anesthesia. Regional nerve blocks are more preferred than multiple infiltrations by using decreased amounts of local anesthesia and needle pricks. If the airway is compromised, there might be a need to intubate. Okay, so this picture is one of my patients who was mauled, no? Nabugbog. Okay, so we had suturing, no, on the forehead and on the upper lip. Ano yan, wasak yan, no? I don't want to show this one anymore, yung ano kasi, no? Pero it was all performed under regional anesthesia and the patient was awake. Okay, so the sensory innervation of the face is from the trigeminal nerve. The trigeminal nerve is divided into the ophthalmic, maxillary, and the mandibular parts, no? So you can use a block, no, ultrasound guided for the mandibular and maxillary areas, no, to cover right away a large area, no, by using an ultrasound. Ophthalmic, you can use a supra or infraorbital block, no, depending on the area to be operated on. Okay, now for my conclusion, so we should bring ultrasound-guided regional anesthesia to emergency medicine. Okay, but there are some limitations. There are few emergency departments that have fully embraced regional anesthesia in their daily practice. So ultrasound-guided regional anesthesia is an important skill for emergency physicians to acquire, as availability of well-trained anesthesiologists cannot cover the ED or the emergency department at all times, no? Kasi, you know, as anesthesiologists, sometimes we are so busy with OR, no? And if they ask for, you know, a regional anesthesiologist or somebody who knows regional anesthesia to block the pain of the patient in the emergency, baka matagal sila mag-aantay, no, for somebody to be available. And not all anesthesiologists at this time, no, is very adept in regional anesthesia to teach them or to do the job. So those are the limitations. A barrier is the lack of formal training of ED physicians and the lack of interdisciplinary collaboration with anesthesia. Okay, so since tayo, we're just actually regional anesthesia is a new subspecialty now, and and there are only a few consultants who teach regional anesthesia. There are even some centers here locally, who doesn't have any consultant teaching regional anesthesia. That's why we need to push this one, and be more adept, to train a lot of people, being a gold standard, maybe in our anesthesia practice to teach, regional anesthesia. And maybe it can also extend, maybe they can be invited to teach also emergency department physicians for regional anesthesia. So the solution here is to form a subspecialty training program for pain management for emergency physicians. Alternative is for the emergency physician residents, to rotate in the Department of Anesthesia. Kasi we have the patients, diba? So for us to practice regional anesthesia, so they will be more exposed and maybe improve their skills if they rotate in anesthesia, in the operating room, maybe. With such skills, the patient's pain will be attended to a timely manner in the emergency department or in pre-hospital settings. So the door-to-block time will be reduced. Okay, so as I've mentioned earlier, that the severity of pain can lead to chronic pain. But if we can attend to the patient's pain as soon as possible, there would be less chances for the patient to develop chronic pain. Okay, so in summary, patients with acute trauma is complex with competing or coexisting priorities. So meaning the resuscitation of the patient comes first before us controlling the pain of the patient. Okay? High quality of analgesia needs to be addressed. Regional anesthesia significantly reduces systemic opioid analgesia requirements, thus reducing the chances of having its side effects. The early use of regional anesthesia in selected trauma patients improve outcomes with less morbidity and mortality. Regional anesthesia reduces length of stay in the emergency room and hospital overall. It is very cost-effective. The prudent use of regional anesthesia in trauma patients should be combined with a multidisciplinary approach with good clinical judgment and vigilance. And ultrasound-guided regional anesthesia should be a core component of emergency medicine, resident education, and clinical practice. Okay, so this is one of my patients. He had a bilateral fracture, and then I gave her regional anesthesia, and she's a happy patient. Isipin mo, both legs were fractured. She was hit by a vehicle while crossing the street, and sustaining those injuries. But with regional anesthesia, she was operated on. The first one had ORIF of her ankle, and the other one had a fracture in the mid-tibial area. So afterwards, this is like a teenager, 13, 14 years old, This won't lie, yung sa pain nila. Kung masakit talaga, iiyak yan. But this one, after anesthesia and with the regional blocks, she's a happy patient. Okay, thank you. Thank you for listening.
Very much, Dr. Ascalon. We can only accommodate one question for this particular lecture. So before we let Dr. Ascalon go, are there any questions from the group? Doctora?
Good afternoon, sir. Thank
Hi,
you
good
for
afternoon.
the
Yes.
lecture. So my question is, what is the role of the continuous peripheral nerve blocks play in trauma-related surgeries, and how do they contribute to long-term pain management and functional recovery for patients with complex injuries?
Okay. So, well, actually, I tackled that in one of my slides already. No, and for continuous peripheral nerve blocks, you place a catheter there. No, so let's not think about the complications first. No, of kinking and infection. No, so yun lang. No, putting in a catheter, you can continuously control the pain because sometimes, like as I've mentioned earlier, let's say for hip fractures, no. Yung clearance ng patient, sometimes it takes a while. They have to, correct some, yung mga laboratories, no? And prepare blood, look for blood. And during those times kasi, the patient is in pain, no? Kasi the only way na para to improve the pain is to do the procedure, no? Eh habang may bali yan, okay, masakit. So you put a catheter, and during that time, maybe you just give a low dose local anesthetic, continuous, no, so to patient to relieve the pain. No, as I've mentioned before, like in hip fractures, na the patient can move about, no, and can move left to right, no, without sustaining any sacral ulcers, no, because he or she is relieved of the pain. No, and also when you have the catheter in place, okay, given it's not it didn't trail off to some other area, nandun pa rin siya, you can use that catheter actually to add local anesthetic for the surgery itself. No, and you can continue that furthermore for the post-operative pain control. Pero ako naman kasi kasi in our institutions, no, we don't usually go down and address, and we go give regional anesthesia. Well, ako, never pa naman ako natatawag sa emergency room to give regional anesthesia to relieve the patient of any specific injury. So usually tayo kasi we always wait for the patient to be brought up to the operating room, tapos doon na lang tayo nagbibigay, no? So this one kasi would be applicable if there are institutions na, they call on anesthesiologists to, to go down to relieve the patient of the pain. No, other than that, we just wait for them sa taas. So yung future kasi, well, if we can extend, no, if regional anesthesia will be a mainstream already, well, actually ngayon naging mainstream na siya starting, no. Now it can also be extended to the different departments. Like the emergency department, na sila na mismo yung maglalagay nung regional anesthesia. Okay? So, syempre yung mga ganon, it goes with the, syempre yung mga legalities naman din, di ba? Na kunwari, ano ba kayo? Emergency physician, are you qualified to do this? Di ba? So, yung mga ganon, they have to fix that. No? Kasi kung ganon, it would relieve us of the added burden or the added, rotation to go there out of our comfort zone, which is the operating room.
Thank you, Dr. Ascalon. If I may, in one of my hospitals, we do actually have emergency medicine physicians rotating with us in the division of regional anesthesia, where they learn basic blocks, initially under supervision from the consultants and the fellows in regional anesthesia. What we do have, especially for hip fractures, Dr. Escalon, is there are some hospitals that are advocating now fracture liaison services for hip fractures. And this is a multidisciplinary team composed of your orthopedic surgeons, your internists coming from different subspecialties like cardiology, endocrinology, and of course, the regionalists and the pain medicine specialists. And that's when we are called to go to the ER to give the blocks. And we do put in some catheters in place at the ER, or they're brought up temporarily to the block room wherein they receive blocks via continuous catheter. And then the target is to really operate on them within 2 days. Yeah. Thank you very much, Dr. Ascalon. I love the fact that you also lectured your head and neck blocks as well as your scalp blocks, especially since as both a regionalist and neuroanesthesiologist, it's something that I do quite often. And I really enjoyed your talk. And Thank you very much for sharing your expertise
Okay,
to us.
welcome. My last word lang. Before, I was sitting there like you guys, no, just listening to the lecturers. Ngayon, ako na yung nagle-lecture dito about regional anesthesia. So, kayo dyan nakaupo, next time, kayo naman mag-lecture dito. Spread regional anesthesia, teach, and teach, and teach. Para marami-rami na tayo. It's gonna be mainstream already. Thank you.
Thank you very much, Doctor. And now from one emergency setting to the other, we've talked about regional ultrasound-guided regional anesthesia in the setting of trauma and emergency medicine and the emergency department. We'll now go on to airway blocks for awake intubation, things that we dread to do as anesthesiologists, especially for those who are beginning their careers or those who are still in training. Joining us on stage is Dr. Numeriano Samor Jr., Doc June.
So we're very familiar with intubation, right? And we'll be talking about awake intubation with airway anesthesia. But before we can absorb the lecture, we should all be awakened first. Gising muna po kayo para sa awake intubation. So I have nothing to disclose. We do awake intubation on patients with features of difficult intubation. So in this area, I get referrals from fellow anesthesiologists to do intubation for their cases. Also, I get referrals from surgeons who know that I do awake intubation. And for those patients who will be difficult both by supraglottic or mask ventilation, then for those patients who have features of difficult intubation and yet they have full stomach, so you have to do it by awake intubation. And also, for those patients who may not be able to tolerate the effects of the usual IV induction. So you have those patients with hemodynamic instability or patients who may have cardiovascular collapse if you give your usual induction agents. So for us to be able to safely do awake intubation, we should be familiar with the following, the sensory innervation, the agents available for anesthetizing the airway, the upper airway, the techniques on how to anesthetize those areas, both landmark and ultrasound guided, and also sedation techniques. Then for the patient, we should prepare them by giving anti-sialogogue if warranted. Nasal vasoconstrictors. These are the most common available, the oxymetazoline and phenylephrine. And then we should avoid vomiting or gagging upon doing awake intubation. Of course, we should do the usual monitoring for the patient, such as the pulse oximetry, BP monitor, heart rate, cardiac monitor. And to ascertain that we are successful with the intubation, we should have end-tidal CO2 monitoring. And the good thing with doing the patient awake is that you can give supplemental oxygenation, and you have no danger of having hypoxemia on the patient. So what device can we use for our awake intubation? Any device that you have in your practice, kung anong favorite mo. So if you have your conventional blade, you can use it. But recent studies point to using video laryngoscope and flexible scopes as the standard in awake intubation. But for me personally, I am biased with video stylet because of the reasons that I'll be showing you later. So let us see some cases that I have done a few moments back. So the first case is a 9-year-old female with a foreign body on the face for removal and repair of the injury. So this patient has a car parked in front of her face. And this is a 9-year-old girl. And while playing with the younger brother, no, nagalit yung younger brother and binato siya, thereby sustaining the injury. So you have a pediatric patient with a mouth being covered by the foreign body. So the only way to intubate the patient is through the nostrils. So for the anatomy, we should know that the innervation of the airway is your trigeminal nerve, the nasal cavity, the glossopharyngeal nerve, which innervates your oral cavity, and the gag reflex, and also the vagus, which innervates the structures below your vocal cord. So for that particular patient, the most practical way of anesthetizing the airway is through nebulization with lidocaine. So the maximum total dose of lidocaine for nebulization is a bit higher. So studies show that we do not get the usual plasma level that will cause systemic toxicity with even higher doses of lidocaine in nebulization. So for the patient, this patient should be spontaneously breathing. So yun lang ho ang criteria ng awake intubation. The patient should be spontaneously breathing, and it's a spectrum between the fully conscious until the lightly sedated or the moderately sedated patient. So pagka ang pasyente mo ay fully conscious, lightly sedated, or moderately sedated, pasok pa rin yan sa awake intubation. Then, what agents can we use? We have remifentanil, dexmedetomidine, ketamine, midazolam, and fentanyl. The key here is to give your sedative agents in incremental dosing hanggang makuha mo yung level ng sedation na comfortable yung patient and comfortable ka rin na gawin yung patient. So for the patient was given midazolam in incremental doses and ketamine. And also atropine was given to help give you a clearer field So obviously, for that patient, you cannot use your video laryngoscope because of the foreign body. So this patient was done using pediatric flexible scope. So this is the patient. So the patient was given nebulization with lidocaine, and pag naka-encounter kayo ng sensitive parts, you can do spray as you go, and then until you reach your carina, and then you slide your ET tube. So as you can see, nag-cuff siya, nag-back ng kaunti, but then yun lang ho ang response niya. And the patient was successfully intubated. So this is the patient upon removal of the foreign body, and this is the culprit. So merong bakal sa likod, sumabit dito. And that patient was already in the hospital for 3 days kasi walang matawag na gagawa. Ayun. So on the 4th day, saka lang siya nagawa. Okay. So another case, this is a 43-year-old female with a tongue mask for tracheostomy. So the tongue mask extended down to below the mandible, to the neck area. And this patient already had radiotherapy done. And the patient cannot open the mouth, and also no air entry by mouth. So the patient is only breathing through her nose. And since naka-NGT siya, so isang ilong lang ang hinihingahan niya. So prior to intubation, I removed the NGT. And for awake intubation, this patient, we should do a double setup. So the ENT team should be on standby for any eventuality. This patient was explained on what to expect, and no sedation. This patient was nebulized with lidocaine. Nasal packing was done, and also spray as you go. So for the nasal cavity, we have the greater and lesser palatine nerves, which supplies the innervation, sensory innervation at the area of the turbinates and the nasal septum. And the rest is supplied by the anterior ethmoidal nerve. So those nerves are coming from your 5th cranial nerve. You have the maxillary division and the ophthalmic division. So the objective is to put your packing at that area. So remember your swab test. Lahat tayo na swab test, di ba? Yung dulo nun, yun yung sphenoid bone. And then, you put your packing upwards to reach the cribriform plate. Then you stay your packing for 3 to 5 minutes, and it will render the area insensate. Other ways of anesthetizing is using your nasopharyngeal airway, liberally coated with lidocaine, 2% or mucosal jelly. So there are 2 objectives, no? To dilate the area and also to anesthetize the area using the nasopharyngeal airway. And then there are combinations that you can use. You have a mixture of lidocaine and oxymetazoline, 1:1 or 3:1 lidocaine and phenylephrine by volume, or lidocaine with epinephrine. So this is the patient being packed with lidocaine and oxymetazoline. So the patient was not sedated. And isa-isang ilong lang, wag dalawa ha. Kasi hindi na sa hihinga. Remember, cannot breathe by mouth already anymore. And this is the actual intubation using flexible scope. So you can see, this is your inferior turbinates nasa kanan, then inferior meatus going downwards. Then yan, spray as you go. You can see the lidocaine pag naka-encounter kayo ng sensitive parts na nakalusot sa nebulization, then you can, and then that's your vocal cords and that's your trachea. Then once you see the right and left main stem bronchi, you can, that's your carina, then you can slide now your tube. There. And then you can also check for the placement of the tip of the AT tube through your, so that one there is your right main stem. This one is the left main stem. And then that's the time that you can give already your propofol and proceed with the surgery. Another case, this is a 71-year-old male with a subdural hematoma for craniectomy, evacuation of hematoma. And the patient has features of difficult intubation. The patient is edentulous with a small mouth opening, thyromental distance of, ito, 2 finger breadths yan. Kaya lang siya naging 1 kasi hindi masyadong naka-extend. But if you are going to extend, hindi pa rin siya aabot ng 3. So that's 2 finger breadths. And then the patient has cardiac problem with 2 pillows, orthopnea, heart failure, and atrial flutter. So we have a patient here with features of difficult intubation and with possible cardiovascular collapse if you are going to give the patient the usual IV induction agents. So candidate for awake intubation. So for the glossopharyngeal nerve, which supplies the area of the oral cavity, you can, so the glossopharyngeal nerve supplies your vallecula in the base of the tongue. So you can have an injection or spray. But the thing with injection is that magkakaroon ka ng bloody field. And also, your injection will give the patient pain na naglalast even after the procedure, even after na-discharge na yung patient. Nakakaramdam siya ng parang tinutusok sa area. So, for this patient was given lidocaine spray on the area of the glossopharyngeal nerve at the base of the anterior tonsillar pillar. Ayan. So that is the injection na magiging bloody yung field mo, mahirapan kang mag-intubate lalo. Another way of blocking your glossopharyngeal nerve is your parapharyngeal space approach. You can put your probe submandibularly, and here you can see your submandibular gland here, and the hyperechoic structure at around 3 to 4 centimeter from the surface of the probe is your pharyngeal wall. Ito. So you can do a block in plane or out of plane. So by doing this approach, you will avoid the possibility of the area being bloody. No? Pag dito mo tinusok, hindi magkakaroon ng bloody field. So this is okay with for awake intubation. By the way, this is case report. So case report pa lang, kokonti pa lang nagagawa. Ganyan. Ayan. So we go now to the vagus nerve. The vagus nerve supplies the sensory of the airway above the vocal cords and sensory below the cords. So for the sensory above the cords, you have the superior laryngeal nerve. So this is the superior laryngeal nerve. You have the internal branch and you have the external branch. The external branch supplies the muscles. extrinsic muscles, while your sensory branch supplies the superior surface of the vocal cords and also some part of the epiglottis. And there are numerous techniques on how you are going to block, because as you can see, coming from laterally, it goes under the hyoid bone, and then it pierces your thyrohyoid membrane to be deep to the thyrohyoid membrane. And also we have the recurrent laryngeal nerve, which supplies the sensory below the vocal cord and the trachea. This is a study which shows that ultrasound-guided superior laryngeal nerve block is better as compared to ultrasonic nebulization. So that's why mas okay pa rin na i-block, because it takes a more significant time to intubate a patient using nebulization. So this is the sonoanatomy of the area with that probe placed sagittally. So you have here the thyroid cartilage, the hyoid bone. You have the thyrohyoid muscle, and this is your thyrohyoid membrane. And since you have already here the nerve, the superior laryngeal nerve, then this is already more medially pumasok na sa loob ng thyrohyoid membrane. So how about comparison between anatomical landmarks and ultrasound-guided? It was shown that it's better. It's better to do it under ultrasound guidance because tracheal intubation was shorter. Patient was more comfortable with the ultrasound-guided blocks. And also, the blood pressure of the patients intubated under ultrasound guidance has lower values. Then, where do we inject the local anesthetic? In this paper, it's shown here that you can inject your local anesthetic in this area. Okay, anterior to the thyrohyoid membrane. So 6 cc of local anesthetic will block the right and the left superior laryngeal nerve. And the traditional approach, which is given in this area, around 1 to 1.5 cc of local anesthetic, is also okay. So pareho lang sila. No? You can either do your modified anterior approach or your traditional approach. Then this is a case report again wherein the probe was placed transversely. This is a patient with a severe burn at the neck area. So the probe cannot be placed in a sagittal plane. So the probe was placed transversely. And we can also do it through the transverse approach. And this is the longitudinal approach. Again, you have the thyrohyoid muscle, the thyroid cartilage, the hyoid bone, and the cricothyroid membrane. So for going back to the patient, this patient, so this is the sagittal scan of the patient's thyrohyoid membrane. And this is the actual block. So this is the area. And this is the scan of the cricothyroid membrane. So for the recurrent laryngeal nerve, we do a transtracheal injection. That is percutaneously injecting local anesthetic to the trachea. And the local anesthetic, once you spray it inside, will give a coughing reflex. And that coughing reflex will drive the local anesthetic under your glottic opening. So this is how we do it. So you have the air, so you're already within the trachea, and that's the coughing. So between the devices, you have video laryngoscope, video stylet, and flexible scopes. It was concluded that comparison between video stylet and flexible video scope, using your video stylet has a relatively shorter duration time, and also as against your video laryngoscope, video stylet has a higher first pass intubation success rate and clearer glottic exposure. So this is the video stylet, and this is the actual intubation of the patient. So the patient is not gagging at this time. So that's your epiglottis, supplied by the superior laryngeal nerve. So successful yung ating superior laryngeal nerve block. Then we have no cough reflex, which means that successful din yung ating recurrent laryngeal nerve block. And that's awake intubation for this patient. Uy, thank you agad. So, contraindications, those patients who need immediate intubation, you have no time to prepare for the blocks, for the nebulization. It is relatively contraindicated. Patients who are uncooperative, combative, this is a relative contraindication because you can give your sedation. And patients with, of course, local anesthetic toxicity or allergy. And patients with excessive airway bleeding. Probably you can do your surgical airway pagka hindi kaya ng your devices. And then, of course, if you have no clinician experience to do awake intubation. So sana po, after this lecture, practice na tayo, mag-nebulize, and so that magkakaroon na ng more available experienced clinicians to do awake intubation. That's all.
Thank you very much, Dr. Samar, for that wonderful lecture on awake intubation. Do we have any questions from our audience members?
Hello. Good afternoon, Dr. Samar.
Yes.
In what clinical scenarios is topicalization of the airway using our local anesthetics preferred over our nerve blocks for awake intubation? And what factors influences the choice between these two approaches po, sir?
If you are in a hurry, you want to intubate right away, then you should do your injections. But if you have 30 minutes, 15 minutes, then you can do your lidocaine nebulization. And of course, mas maganda ang block na napoproduce ng injection techniques.
Thank you very much for that question, and that was expertly answered by Dr. Samar. In the interest of time, we're running a bit late. We'll just ask you for your questions. For those who have other questions, you can forward them directly to our last two speakers. Thank you very much again, Dr. Samar.
Thank you.
I'd like to come back my partner. And I'd like to thank myself for that excellent moderating. Hey, do we still have energy? We still have a couple more sessions to go. I hope you're still with us as we will still have interesting sessions, right?
Yes. And we'll also have a quiz later on. So stay wide awake, wide and bright. Ladies and gentlemen, our program continues with a pre-recorded presentation that explores the vital topic of obstetric anesthesia care and collaboration towards global progress. We have invited another esteemed speaker for this portion. So let's not delay this any longer. Let's call back on stage Dr. Lorraine Ann Doma as she will introduce our next speaker and then provide a short panel discussion right after the presentation.
Hi, it's me again, but don't worry, I'll keep this session short and sweet. Dr. Dominic Nulaluca is a consultant anesthetist at London Northwest University Healthcare Trust. Her major interest is in obstetric anesthesia. Dr. Lucas is the president of the Obstetric Anesthetists Association and a co-lead for the UK Confidential Maternal Death Inquiries. She is a senior editor for the International Journal of Obstetric Anesthesia. Dr. Lucas was the sole anesthetic member of the guideline development groups for the NICE, or the National Institute of Health and Care Excellence. In 2020, she was awarded an MBE and the Queen's Birthday Honors for services to anesthesia during the COVID-19 pandemic. In 2021, she also received the Featherstone Professorship by the Association of Anesthetists. Dr. Lucas also served as a co-investigator on the UK Obstetric Surveillance System, or UCOS study, of a high regional block in obstetrics, and the direct reporting of awareness in maternity patients, or the DREAMY project, which is a prospective evaluation of accidental awareness in obstetric general anesthesia. Let us all welcome Dr. Nwala Lucas.
Hello, my name's Nuala Lucas and I'm an anaesthetist working in the UK. I'm currently president of the Obstetric Anaesthetists Association, and it's my great pleasure to welcome you to the obstetric section of the first World Day of Regional Anesthesia and Pain Medicine. I'm biased, but I think obstetric anaesthesia is an important part of the regional anaesthesia family, and I'm so grateful to Ezra and its sister regional anaesthesia societies for including it within the programme today. Obstetric anaesthesia isn't just another medical subspecialty. It's a field that deals with critical moments in the lives of mothers and their infants. During childbirth, anaesthesia can make the difference between a smooth delivery and a potentially life-threatening situation. And of course, key to all of this is education. Education in obstetric anaesthesia is paramount to ensure the safety of both the mother and the baby. The physiology of pregnancy is intricate and dynamic. Comprehensive education equips us with the understanding needed to navigate the challenges presented by changes in the cardiovascular, respiratory, and hematological systems. This knowledge is the cornerstone of effective obstetric anaesthesia. And of course, our care can impact beyond immediate delivery care. Education in obstetric anaesthesia contributes to maternal well-being postpartum. Managing post-delivery pain and sometimes complications ensures an optimal postpartum recovery. And of course, I'm not just referring to physical recovery, but also psychological well-being. We know that we have a second patient as obstetric anaesthetist, and the impact of obstetric anaesthesia extends beyond the delivery room, influencing neonatal outcomes, affecting the health and development of the newborn. Education in obstetric anaesthesia empowers anaesthesiologists to offer patient-centred care. It allows us to make informed decisions, to communicate effectively, and provide compassionate support during labour and delivery, ultimately contributing to a positive childbirth experience for mothers. In conclusion, education in obstetric anaesthesia is not merely about acquiring technical skills. It's about safeguarding the well-being of both mothers and their newborns during one of the most pivotal times in their lives. By investing in comprehensive education and taking part in initiatives such as today, we contribute to a safer, more comfortable childbirth experience and lay the foundation for a healthy start for every newborn. We're here today not just as clinicians, but as a global community committed to the transformative power of regional anaesthesia and pain medicine. Our shared dedication to these disciplines resonates beyond borders, transcending geographical and cultural difference. It's this shared commitment that forms the foundation of the first World Day of Regional Anaesthesia and Pain Medicine. Thank you for your attention, and let's continue to prioritise education for the benefit of all our patients.
Okay. Thank you, Dr. Lucas. So unfortunately, Dr. Lucas will not be able to join us for a live discussion or question and answer portion. So for this afternoon session, I was tasked to give a short reaction. So yesterday, I was able to meet up with one of ESRA members from UK, and I tried to ask her, who is Dr. Nula Lucas? And she said that Dr. Nula Lucas is a big gun in the obstetric anesthesia in UK, but also in the entire Europe. So Dr. Nula Lucas is a scientific faculty leader with major interests in obstetric anesthesia. She supports evidence-based perioperative management and shares the same sentiments that anesthesiologists handling obstetric patients are required to make decisions quickly and mostly in the emergency setting. Let's take a look and deep dive with some of her works. Okay, so she's a prolific researcher, which has, she has more than 206 journals under her name and almost 4,000 citations related to obstetric anesthesia care. Her research interest includes airway management in the obstetrics and complications of obstetric anesthesia. And her latest publication was very recent. It was just this January 2024. And it is on the cardiac arrest in obstetric patients receiving anesthesia during the 7th National Audit Project in UK. Her studies were able to guide care teams and achieve key national recommendations and benchmarks, including the NICE guidelines, which could give us idea on how to manage patients having twin pregnancy, those undergoing cesarean sections, and also to offer intrapartum care. She served as a co-lead in improving mother and babies, reducing risk through audits and confidential inquiries to prevent maternal deaths. Her works also include provision of care among different ethnic groups. And this provision of care also affected the neonatal outcome. Her works are varied. I was surprised to find out that she has several journals of with the use of videolaryngoscopy in obstetric patients and obstetric wards, breastfeeding, environmental safety, and even the COVID pandemic, for which she contributed obstetric guidelines in managing parturients who are COVID positive. What was surprising for me was to find out that since 2016, Dr. Nula Lucas has been an advocate for the use of ultrasound in obstetric anesthesia. And she pointed those three things again during the ESRA Congress last year. She suggested utilizing the ultrasound for neuraxial blockade, airway management or assessment, and even POCUS to check on the gastric emptying time. So for the neuraxial blockade, she said that it increases the success rate and the ease of performance in the neuraxial technique. And she also mentioned a meta-analysis that the ultrasound-guided neuraxial blockade correctly identifies the level of the lumbar space, it reduces the number of the attempts required, and there's a reduced number of failed initial procedure, improving catheter function, reducing reinsertion site, and even post-dural puncture headache. The use of ultrasound for the airway enables us to predict the difficulty of the intubation as well as accurately locating the cricothyroid membrane. And of course, for the POCUS of your gastric ultrasound, the antral cross-sectional area measurement serves as a guideline regarding examining the stomach content and determining the pulmonary aspiration risk of a parturient patient. So it's not really that surprising that Dr. Lucas has garnered several laurels and feathers on her cap. So anesthesiologist knows no color, creed, or political standing, and it is only our innate nature to give the best standard of care, supported by research and studies. Thank you, and that concludes my session.
Thank you for again being such a great audience and for participating in the panel discussion.
Moving on, we have exciting news to share with everyone. For this next portion, we have prepared a quick competition brought to us by ESRA. Get ready for an engaging quiz game that could earn you a very fantastic reward. We'll be awarding the top 3 players who will get the most points, and they will win a free registration for the Prague Congress. Are you ready for the challenge?
Are you ready? Yes. Okay.
Oh, yeah.
So the quiz is actually open to actual participants of the World Day of Regional Anesthesia and Pain Medicine globally. So some rules, only one participation per entrant per device. Each participant will have 5 minutes to complete the full quiz. And as mentioned just now, the best 3 responders worldwide will win a pre-registration for the Prague Congress. Lakas na talaga yung boses ko. Oo nga, ayan. Okay, again. The quiz is open to actual participants of the World Day of Regional Anesthesia and Pain Medicine. Only one participation per entrant per device is allowed. Each participant will have 5 minutes to complete the full quiz. And as mentioned just now, the best 3 responders worldwide will win a free registration to the Prague Congress. Here are the mechanics. To participate, simply scan the QR code being flashed on your screen right now, and this will give you access to the quiz. And it's your time to showcase your knowledge in regional anesthesia and pain medicine.
Does everyone have a good connection? None? Do we have a QR code for the Wi-Fi? If you want connection, if you don't have connection, here's the QR code for the Wi-Fi, and it's open for you to join the Wi-Fi connection so that you can also participate in the quiz.
So this is for the Wi-Fi connection.
Is everyone good?
Everyone has it? Now we'll display the QR code for the quiz competition. Again, it's the best 3 responders worldwide. So you have 2 targets. Have the most correct answers for the quiz and be the fastest worldwide. Uy, Prague din yan.
Yeah, of course. Ezra.
Ezra Congress in Prague.
Or there's yummy food I heard from you.
Yeah, Trujilnik. Or, yeah, yummy food and fun places. See the Prague Castle, go through the Old City, and of course, attend the Congress and learn more about regional anesthesia and pain medicine. For those who are done, you can also go out and step out of the theater for a while if you want to take a bathroom break.
Or there are snacks along the corridor. They're serving snacks right now in the corridor. So after completing the quiz in the fastest time possible, you're very welcome to partake in the snacks and the refreshments outside. But reminder, please do not bring any food or beverages inside the theater. Please also feel free to share your experiences and insights using the hashtag WDRAPM. I've actually clicked this link and saw a few already. Internationally, worldwide, they have already shared. So share your experiences also and connect with the rest of the world on this very momentous occasion, the very first World Day of Regional Anesthesia and Pain Medicine.
So share your experience in your locality, share your experience with the quiz, or simply enjoy the online camaraderie with everyone across the globe. So many things happening right now. You can take the quiz. You can post using our hashtag WDRAPM. And of course, if you want to partake of some of our palabok and toasted siopaw, they're very yummy. They're very yummy, of course, while they last. But we will be beginning in a few minutes with our next session so that we will still have an early off tonight.
Also, please stay for the workshops at the end of the day. We will be focusing on upper extremity, truncal, and lower extremity blocks.
And of course, don't forget about our raffle prizes. So Doc Rochelle is here na. Your name was called earlier. You won a prize. You got a Herschel bag courtesy of Gentri Med. Thank you, Dr. Genuino and his team.
For those who haven't won yet, don't worry, later marami pang prizes.
I feel dapat may nagtatranscribe na lang na quiz na isang tao. Tapos sagutin na lang natin later on. Tapos pabilisan na tayo mag-click. Kasi hanggang 12 noon pa naman ang Paris time to join. So you don't have to force yourself to answer correctly. Yeah. You have to be smart. That's Prague we're talking about. Sorry, I love Prague. Go visit Prague. Doc Rochelle, I have your prize. Yeah, Lenny. Char. Lenny. Ang liwanag naman ng ilaw, parang nanunundo. Doc. Ay, meron ka na? Okay. Akin na to. Char. You can only answer once. That's why you need to have a sacrificial lamb to find out the questions and then for everyone else to answer. Correct? Correct. All right. It's now time for us to dive into the next segment where we'll explore the recent advancements in regional anesthesia and pain medicine. We have two distinguished speakers lined up for you, so we'd like to invite everyone who are still outside to please join us back in the theater. And we'd like to invite on stage our session chair for the next segment, Dr. Ana Maria Consuelo, to introduce our next two speakers. Dr. Consuelo, Ana, the floor is now yours.
Good afternoon, everyone. I'm Dr. Ana Consuelo, and I can only see very few people remaining for the last two topics. May we ask the, okay. We'll wait for the others. Okay. Wala ng boses. We have a yummy merienda outside. We're given palabok and siopaw. Sarap. May we ask everyone to please come in so we can proceed. Sarap ng kain eh. Na-introduce ka na kanina? Oh, re-introduce me. Ayaw nila pumasok. Mga tao. Nasagutan. Oo, tama. Ang bilis-bilis. Ang hirap naman nun. Panay gusto. Hello, everyone. We're running late with our session, so May I request our participants to join us in the auditorium for a continuation of our lecture series. Okay, again, good afternoon, everyone. We are nearing the end of our celebration of the first World Regional Anesthesia Day. I hope everyone has acquired a lot of knowledge from today's activities. But we have a few more relevant topics to discuss. And I think we cannot end this day without touching on the advancement in regional anesthesia. Regional anesthesia. For analgesia of the lower limbs. He was already introduced earlier as a dynamic, dedicated local regional practitioner, mentor, and teacher. For those who have missed his earlier lecture, I'm glad to reintroduce him. Dr. Madarang is an active consultant at UST Department of Anesthesiology, the same institution where he finished his medical degree and residency. His experience in regional anesthesia is rooted in his almost 2 decades of practice. He underwent apprenticeship from the best teachers in the field under Dr. Noel Aipa and Dr. Braganza, undergoing international courses in regional anesthesia from distinguished institutions of University of Montpellier and New York School of Regional Anesthesia. As a member of the PSA, he played important roles in both international and local conferences under the PSA. In 2019, he was part of the international studies in ultrasound. Mid-year and annual conventions. In his academic home base in USC Department of Anesthesia, he holds various roles as department secretary, member of the credentialing committee, member of the sections of anesthesia in orthopedics, general surgery, obstetrics, and otorhinolaryngology. Without further delay, I would like to call in Dr. Madarang.
Thank you very much for the kind introduction, Dr. My classmate. Thank you very much everyone here for controlling your hunger at hindi kayo sumama dun sa mga nasa labas ngayon na kumakain ng pansit at toasted siopaw. In fairness, masarap naman. And speaking of thank yous, before I forget, I'd like to thank first Gentri Med. Thank you very much for accommodating us for this day's activity. May I say na sobrang na-impress ako sa lugar ninyo. Pagpasok pa lang, may payong na kaagad ako, parang feeling ko artista. And we were really, I really felt at home. Thank you very much for the way you treated everyone here. Thank you very much. Thank you very much also to Dr. June Samar, the overhead chair of this activity. Galing, so finally, Doc, makapagpahinga na kayo after this. The whole organizing team. Thank you very much, Rasfil. Thank you very much, Ezra, for organizing this event. And I hope that all attendees here would go home later with much knowledge learned from this afternoon's activity. So now, for this afternoon, I have been tasked to discuss about novel blocks on lower extremities. Next slide, please. So this is the statement of Dr. Alan Winnie in 1994. This is his prediction, referring to the need for more precision in regional anesthesia. The next slide, please. So for this afternoon, I'll be discussing not necessarily new blocks, although one block is relatively new. The other blocks are old blocks, but have been underutilized. But these blocks still have great potential, especially now since ultrasound-guided versions of these blocks have been developed. And I think it is about time that we should revisit these blocks. And I will be discussing about what I'm talking about is the suprainguinal fascia iliaca block, the dual subsartorial block or the high-pack block, and the ankle block. Next slide, please. Okay. Traditionally, lower extremity surgeries have been done under some form of regional anesthesia. And more often than not, neuraxial blocks were done, either spinal, using isobaric, or epidural. However, because of technological advancements, the need for ERAS, enhanced recovery after surgery, these neuraxial blocks have fallen into disuse kasi the surgeons would want the patients to be up and about as soon as possible. Kung naka-spinal, naka-epidural, matagal pa, hintayin pa natin mag-resolve yung block before mapapauwi yung pasyente, which would take about 6-8 hours. So with recent developments, there came a need for better options than spinal or epidural. Fortunately, when these need arose, this is also the time that ultrasound guidance peaked. Okay? And because ultrasound guidance, there was enhanced precision of nerve identification, and the efficacy of the block somehow improved as well. Although some pundits would say that yung mga consultants natin na matatanda, nasanay na sa landmark-based regional anesthesia, they would still say na pantay pa rin yung ultrasound-guided versus landmark-based. That was before, but now, since bihira na yata yung gumagamit ng landmark-based approach, everyone is leaning towards ultrasound guidance. I think the curve has now skewed more to the right. Next slide, please. Mainstream blocks usually done are the femoral nerve, sciatic, the fairly recent IPAC block, and lumbar plexus block. RAUK is promoting the Plan A blocks, which they define these blocks as the blocks that every anesthesiologist, even non-regional specialists, must know. So they should include this in the armamentarium. So kung marunong ka mag-intubate, marunong ka mag-spinal, marunong ka mag-epidural, dapat marunong ka rin gumawa nitong Plan A blocks. And these include the femoral, the adductor canal, and the popliteal sciatic blocks. But we will not be discussing this today. For this afternoon, I'll be discussing, next slide please. First, I'll be discussing the suprainguinal fascia iliaca block. As far as the upper extremity is concerned, hip surgery, the hip, is a particular problem to the anesthesiologists because anatomically mataas yung pwesto niya. Okay, so blocks, you cannot do a simple femoral nerve block or sciatic block. You have to block it higher unless you want to do, pag tinamad ka, mag-spinal ka. But if you don't want to do spinal or epidural, then you want to do peripheral nerve blocks, you have to come up with a block that is higher than a femoral block or sciatic block. And traditionally, this has been the lumbar plexus block or the psoas compartment block. But these two blocks are first technically difficult to do, and second is wrought with risks. Kasi it's a deep block and you might hit things that you don't want to hit. You might hit, for psoas compartment, you might hit the abdominal contents. There are great vessels involved na baka rin matamaan. Okay. Fortunately, next slide please. Anterior approaches to these blocks have been developed. So, and these provide simpler and safer alternatives. In 1973, grade 1 pa lang si Dr. Nogoy nun, Al Winnie developed the 3-in-1 block. And in 1989, Allen developed the fascia iliaca compartment block, and with these two blocks, they were able to block the lateral femoral cutaneous, and the obturator nerves. So these are the main branches which provide surgical, if not surgical, at least post-operative analgesic effects for hip surgery patients. It wasn't until about 30 years after these blocks were developed that ultrasound guidance caught up already with the suprainguinal fascia iliaca block. So 2011, the suprainguinal fascia iliaca block was developed, but until now, I think it's not that popular yet, which is why I'm going to introduce it this afternoon. Next slide, please. So how do we do this block? First, you place the patient supine with the hip extended. You place the probe slightly medial and caudal from the ascis. And then once the probe is placed, you look for the iliacus muscle. And above the iliacus muscle is the fascia iliaca. Okay, it's as simple as that. Place the probe just beside the ascis, medially from the ascis and a little bit inferior, and look for the iliacus muscle. And from the iliacus muscle, look for the fascia iliaca. Ganun lang. Less than 5 seconds, mahanap mo na kaagad. Next slide, please. Okay, this is what the ultrasound image looks like. So ito yung iliacus muscle. Above the iliacus muscle is the fascia iliaca. And sometimes, it is nice to find also the convergence of the abdominal muscle and the lower extremity muscle. This is the internal oblique, the abdominal muscle, and the sartorius muscle. So they form an hourglass shape or a bow tie. Okay. And in between these two muscles and the iliacus muscle is the fascia iliaca. So as I said, napakasimple. Place the probe medial from the ascis. Look for this. Yun lang. Insert the block needle here and place it just under the fascia iliaca, in between the iliacus muscle and the fascia. It's easy kasi once you pop, nandun ka na. Okay, there's less need to search for the proper place, yung i-withdraw mo pa ng konti, although some withdrawal is needed. But once it's popped, more often than not, yun na yun, nandun ka na sa place na yun. But one caveat though, it has to be, the local anesthetic should spread. This is another anatomical consideration. This is the circumflex artery. If you see this pulsation, it is both a landmark to find as well as a structure to avoid. The local anesthetic, once it's spread, it has to spread under the circumflex artery. If you see the spread of the local anesthetic above, wala ka sa fascia iliaca. Okay. So again, place the probe, medial to the ascis, look for this, and inject. You need higher volumes. Next slide, please. Okay, from in plane, from caudal to cephalad, pop to the fascia iliaca, hydrodissect, confirm placement. Next slide, please. Okay, this is a high volume block because with this potential space, under the fascia iliaca, the local anesthetic has to spread within the pelvic cavity to where the branches, the femoral, lateral femoral cutaneous, and the obturator nerves emerge. Okay, so pag emerge pa lang nila, makukuha na kaagad nung block na to. But you need a high volume, about 30 to 40 ml of 0.2, 0.25% ropivacaine or bupivacaine. Because you need a high volume, it follows that you will use a lesser concentration, like 0.2%. In order to extend the block, it is nice to add dexamethasone as an adjunct to prolong the block. Okay? So properly done, this will provide analgesia to the hip for more than 24 hours. Next slide, please. Elderly patients are usually the ones who need hip surgery. Sila yung mga madaling ma-fracture, and the complications for untreated fractures might lead to more severe symptoms. So as elderly patients, because of their age, they are more sensitive to opioid effects, and the suprainguinal fascia iliaca block provides more effective analgesia than patient-controlled anesthesia. Patient-controlled opioid anesthesia. It reduces the opioid consumption, It provides postoperative analgesia without, sometimes, hindi nagagamitan ng opioid, hindi nagagamitan ng tramadol, hindi nagagamitan ng oxycodone. And because of this, there is also decrease in incidence of opioid-related side effects, which translates into better patient satisfaction. Okay, that's the suprainguinal fascia iliaca block, and I really, really hope you get to try it once someday. Okay, next slide, please. Next is dual substertorial block, or the HIPAC. Now, again, as I mentioned earlier, this block is for surgeries to the knee, okay, specifically for total knee replacements. And patients who undergo total knee replacements, more often than not, are also belong to geriatric age. And the same problem that we see in geriatric patients for hip surgery, we also see for the patients undergoing TKR. And because of this, the same advantages of doing proper regional techniques also apply. Okay, it provides effective analgesia, early mobility, reduces opioid consumption, and earlier discharge. Yep. Next slide, please. Just a brief review. The region is innervated by the main branches of the lumbar plexus, the femoral nerve, the obturator nerve, and the sciatic nerve. Now, if we can block these three nerves, then we will be able to block the knee joint already. But the problem with blocking these three nerves is we will also be blocking the motor components. So ganun din, it defeats the purpose. The patient will not be able to go home immediately. We'll have to wait for the block to recede before we allow the patient to leave. Okay, so aside from that, because of the motor weakness, there's also that risk na mahulog sila, and it will cause further damage. Okay. Next slide, please. Fortunately, motor sparing options have been developed. So this includes the femoral triangle block, adductor canal block, the IPAC, and the infiltration analgesia. Each of them has their own advantages and disadvantages. But for this afternoon, I will present to you, next slide please, the dual subsartorial block, which is a hybrid form of subsartorial block. You will do two subsartorial blocks. First is the femoral triangle block, and second is the adductor canal block. Both these two punctures will block both the anterior aspect of the knee and the posterior aspect of the knee. Okay, next slide, please. And this is done in 3 easy steps. Yung kanina, yung sa suprainguinal fascia iliaca, di ba? Salpak, medial, that's it. Ito, 3 easy steps. First, identify the apex of the femoral triangle. Second, do the first injection, which is the femoral triangle block. And third, do the second injection, which is the adductor canal block. Panis, di ba? Dali lang. Okay, next slide, please. Okay, first, identifying the apex of the femoral triangle. You place placing the patient supine with the hip slightly everted. You place the probe in the middle of the thigh and look for the apex of femoral triangle. You have to look for the vastus medialis anterolaterally, the adductor longus posteromedially, and the sartorius muscle. The apex of the triangle is found when you, excuse me, when the medial border of the sartorius muscle and the medial border of the adductor longus muscle convenes. Here. Okay. So this is the sartorius muscle. This is the adductor longus muscle. Okay, when their medial borders merge, they form a sign of 3. Kita mo? Or the kissing sign, para siyang labi na lang. Para nakaganon. Okay? So then we'll know that is the apex of the femoral triangle. That's the first step. Look for this. Okay, second step. Next slide, please. Second step is to, after looking for this, you move the probe 1 to 2 centimeters cephalad upward. Okay? So, from here, iaangat mo yung probe, tataas mo, then you will find the femoral vessels, the femoral artery. Beside the femoral artery, there is the saphenous nerve and the nerve to the vastus medialis. Okay, here, this is the saphenous nerve and the nerve to the vastus medialis. At this level, at the level of the femoral triangle, the saphenous nerve and the nerve to the vastus medialis are contained within the same space. There is no membrane separating them. Okay, so it is easy to block them. Once you've located this, you do your puncture, look for the needle, and give 5 cc. You give 5 cc to the saphenous nerve and 5 cc to the nerve to the vastus medialis. So that's a total of 10 cc. Okay, that's the second step. Okay, third step, next. The third step is to do the second injection. So kanina, di ba, nasa ano tayo, apex of the femoral triangle, you slide the probe upward. This time, you slide the probe 1 to 2 centimeters downwards. Okay? So kanina upward, ngayon downward. And this is where the femoral triangle can be found. Okay, if you notice, in the femoral triangle, the nerve to the vastus medialis is separated from the saphenous nerve by the vasoadductor membrane. Okay, the vasoadductor membrane is an important structure because it is where the needle must be placed. Ito yung dapat ma-puncture ng needle. Okay, so you place the needle must be placed through the vasoadductor membrane, just close to the femoral artery, such that when the local anesthetic is injected, you will notice the compression of the femoral artery. Parang pagka-inject mo, liliit yung femoral artery. And then pag binitawan mo, mag-expand na naman siya. Okay, that is a good sign that you're in the proper location. When you inject and the femoral artery compress, then when you stop injecting, the femoral artery once again goes back to its original place. Okay, you inject about 20 ml of local anesthetic. And that's it. That's the third step. So 3 simple steps. That is this dual subsartorial block. Now, why? Bakit? Ano yung rationale for doing these 2 injections? Next slide, please. Sorry. Just if, di ba sabi ko kanina, you give about 15 to 20 ml sa adductor canal. If you give a higher dose, higher bolus of local anesthetic, like 20 to 30, even some even go as high as 40 ml, you will do the high pack or the high volume proximal adductor canal block. And this local anesthetic volume will spread distally, and it will include, eventually, it will include the sciatic nerves posteriorly. So it follows the course of the femoral vessels, and as the femoral vessels crosses towards the posterior, susunod yung local anesthetic sa femoral vessels to eventually include the sciatic nerve. Okay, ito. So from the femoral triangle to the adductor canal, gagapang yung local anesthetic kasama ng femoral vessels towards the popliteal fossa to include the sciatic nerve. Okay, next slide, please. Okay, so the first injection. But why do we need to do the first injection? It targets the saphenous nerve and the nerve to the vastus medialis directly. So you don't have to worry about the anterior aspect of the knee. Kasi na-block na yung na-block na yung dalawa, yung saphenous nerve and the nerve to the vastus medialis. Plus, a little more distally, local anesthetic will spread a little more distally under this sartorius muscle to block the sartorial plexus. Okay, so it blocks the nerve to the vastus and the saphenous nerve, and it blocks the sartorial plexus. And blocking these 2 structures, these 3 structures, will block the anterior aspect of the knee. Okay, so that's the first reason. Next slide, please. Now, why the second injection? The second injection targets the popliteal plexus indirectly. So as I mentioned earlier, because of the volume, here, local anesthetic spreads, it follows the course of the femoral vessels, and it proceeds to the posterior aspect of the knee to block the popliteal plexus. So if you've read about the IPAC block, that is the same principle of the IPAC block. You inject local anesthetic in between the capsule of the knee and the popliteal artery, because that is where the popliteal plexus lies. This is the same principle. With the volume given in the adductor canal, it is enough to spread with the femoral vessels going to the posterior aspect of the knee to hit the popliteal plexus. Okay, so with that, we're able to block the posterior aspect of the knee. So yung unang injection is for the anterior aspect. The second injection is for the posterior aspect. Okay, next slide, please. Okay, and again, if you inject even higher volumes, so as you inject local anesthetic, diba, sa posterior aspect of the knee, if you give even more, there is a potential for it to spread, to involve the sciatic nerve. So if we have, for example, a surgery involving the shin, then this can be an alternative. You do a high pack block. So for nakakast na. Hindi ka na makapag-popliteal sciatic nerve block kasi nakakast na yung pasyente. Diyahe naman sa surgeon kung patatanggalin pa natin yung cast. So an option is to do a high pack. So look for the adductor canal, bolus 40 ml, and that's it. Covered na yung block na yon. Covered na yung area na yon. So you don't need to do a popliteal sciatic nerve block. Okay. Next slide, please. Next is the ankle block. Okay. Dati, nung residente kami, this is one of the options na ginagawa. For foot surgeries, we do ankle blocks, pero landmark-based technique. And it is more often than not hit and miss. Sometimes it takes, sometimes it doesn't take. So parang 50-50. And because 5 nerves are involved, makuha mo, maswertehan mo, makuha mo yung 3 nerves, pero yung sa dalawa hindi naman nag-take, so hindi rin. It's not a perfect block. Okay, so this is why it fell into disuse eventually. Parang tinamad na eh. May LMA naman, pwede namang i-tube na lang yung pasyente. So hindi na ginagamit yung ankle block. Okay. Plus, next slide please. Ayan. Because traditional anesthetic techniques relied more on wound infiltration, and their success rate is about 30%. Plus the advent of the ultrasound-guided popliteal sciatic block. So ba't nga naman papahirapan sarili mo na iba-block isa-isa yung mga nerves na terminal nerves ng sciatic nerve when you can block the sciatic nerve itself? No? With the advent of these, loss of interest in the ankle block happened. So tinamad na yung mga tao. I might as well just do the popliteal sciatic block and saphenous nerve block, and there, you're able to do surgery on the ankle already. However, next slide please. Because of the enhanced program, as mentioned earlier, because of the ERAS and the orthopedic surgeons' recovery protocol, their new protocol, they want patients to be sent home as early as possible. Hindi na kailangan i-admit. Kasi nga naman, paalang na operahan, bakit paalang kailangan i-admit? So this can be done as day surgeries. The main challenge now for anesthesiologists is to provide safe, simple, reliable, prolonged analgesia, which affords a swift ambulatory procedure to be done. And pwede nang pauwiin yung mga pasyente kaagad. And because of this, there has been a renewed interest in the ankle block. This time, using the ultrasound. Okay, so hindi na landmark-based approach, ultrasound-guided na. Okay, next slide, please. Okay, ultrasound-guided ankle block is safer, provides quicker analgesia and anesthesia theoretically kasi madali na lang mahanap eh. And affords faster mobilization and rehabilitation because you don't need to use higher volumes. Remember, these are terminal nerves na maliliit lang. And if you find it, if you locate it, you only need to give smaller volumes, 2 ml. Unlike yung mga traditional na per segment, per nerve, you give 5 to 10 ml. Okay, this time you can get away with giving small volumes only. Ultrasound guidance also increases the success rates and reduces the conversion to general anesthesia. So, one friend of mine said that major advancements in regional anesthesia was made possible by the LMA. It was his private joke, loko-loko. But because of ultrasound guidance, this reduced the conversion rate to general anesthesia. And it also decreases post-operative analgesic requirements. Okay, next slide, please. Okay, so as I mentioned earlier, the ankle block is done by blocking 5 nerves. Okay, first is the first 4 are branches of the sciatic nerve. So this is the tibial, the deep peroneal, superficial peroneal, and the sural. And one branch of the femoral nerve is the saphenous nerve. So there are 5 branches na kailangan ma-block. Okay? Next slide, please. The tibial nerve, it innervates the plantar area of so yung talampakan. Okay, the majority of the talampakan is observed by the tibial nerve. And also, it also includes some of the first hanggang sa kalahati ng third toe. This is observed by the tibial nerve. Okay, so if, for example, ang pasyente mo mayroong plantar warts, or if there is foreign body, may natapakang foreign body na kailangang alisin, the tibial nerve block is your best friend. Ito yung kailangan mong malaman, ito yung kailangan mong matutunan. Fortunately, madali lang siya. Next slide, please. Okay, you place the probe at the medial aspect of the foot, transversely across the medial aspect of the lower leg, just above the medial malleolus, and you will be looking for the tibial artery. Okay? Here. So look for the tibial artery, and just posterior-inferiorly, nandun yung tibial nerve. So madali lang. So place it here, just behind the medial malleolus, in between the medial malleolus and the Achilles tendon. Look for the pulsation of the tibial artery, and that's it. Mag-inject ka na. Okay, since this is a huge nerve, you have to give about 5 ml pa rin. But still, the area coverage is, more often than not, is required. Plus, it is one of the 2 nerves of the ankle that supplies bony innervation. So if there were any procedures involving any bone of the foot, kailangan yung tibial nerve na block. Okay, next slide, please. Next is the deep peroneal nerve, which innervates the bones of the dorsal side of the foot. So yung kanina, bones of the plantar, of the talampakan, this time, the deep peroneal nerve innervates the bones of the dorsum. Okay? So this is sabi ko, the 2 nerves involved for any bone, for any bony surgeries of the foot. And this is the second nerve, the deep peroneal nerve. Okay. Aside from the bones of the dorsum of the foot, it also involves the cutaneous, this small patch of cutaneous skin in between the toe, the big toe, and the second toe. Okay, so kung magsusot ka ng tsinelas, di ba, sinisiksik mo dito yung part ng tsinelas, yung mga flip-flops, yung part na yun yung sinusupply ng deep peroneal nerve. Okay, so how is the deep peroneal nerve blocked? Next slide, please. Okay, you place the probe anterior to the ankle and look for the dorsalis pedis artery. Okay, it's that simple. Lagay salpak dito and look for the dorsalis pedis artery. Here. Okay, depending on where you place the probe exactly, because the dorsalis pedis starts laterally, and as you go distally, it transfers medially. That's where the nerve is located. Sometimes mahirap hanapin. So the best thing to do, since we know that it is in close approximation to the dorsalis pedis artery, then you do a perivascular injection lang. So you inject local anesthetic around the dorsalis pedis artery, then you're 100% sure na matatamaan mo yung deep peroneal nerve. Okay, next slide, please. Okay, next, kung merong deep peroneal nerve, merong superficial peroneal nerve. The superficial peroneal nerve covers the skin and soft tissue over the dorsum of the foot. Okay, dito. Okay. You place the probe laterally, at the lateral aspect of the foot, dito banda. Okay, look for the tibia. And it is located between the extensor digitorum longus aponeurosus and the peroneus brevis muscle. Nakikita nyo ba? Sorry, medyo malabo. It's here. Now, sometimes it's difficult to see the muscles itself. One technique is to look for the fibula. Okay. The fibula, where the fibula points, usually nandun na yung nerve. So this is the fibula. Look for it here. Nandito yung nerve. Okay, that is the superficial peroneal nerve, and for any surgeries that involve the dorsum of the foot, then you need to block the superficial peroneal nerve. Okay, next slide, please. Next is the sural nerve, It innervates the lateral malleolus and the dorsal side of the last two toes. Okay. So you place the probe at the posterolateral. Kung yung ano kanina, yung yung tibial nerve, di ba dito sa medial. Okay, between the medial malleolus and the Achilles tendon. This time you place it at the lateral malleolus and the Achilles tendon. And you look for the short saphenous vein. Sometimes you see the nerve, sometimes you don't kasi maliit lang eh. But if you don't see the nerve, all you have to do is, once again, do a perivascular injection around the short saphenous nerve. Okay, next slide please. And last is the saphenous nerve, which is a branch of the femoral nerve. You place this, it provides skin innervation of the medial part of the ankle, here, and foot. You place the probe proximal and anterior to the medial malleolus. Look for the great saphenous vein. Okay, so kanina sural, short saphenous vein dito sa likod. This time for the saphenous nerve, you place it here anterior from the medial malleolus and look for the great saphenous nerve, great saphenous vein. Ito yung vein na minsan pag nahirapan tayo maghanap ng ugat sa mga pasyente natin, sabi natin sa paa na lang mag-insert. The most common vein na makikita mo is the great saphenous vein. Look for that nerve and do a perivascular injection. And then you'll be able to block the saphenous nerve already. Okay, next slide please. So that's the ankle block. Those are the 3 blocks that I would like to introduce. So once again, fascia iliaca block, dual subsartorial block or the high pack block, and lastly, ankle block. I hope that you find time when you get home, you consider doing these blocks because they are simple, they are effective, and they work well. If you have any more questions, I was only given 20 minutes to discuss 3 blocks, so medyo minadali ko, and I hope I'm sure I didn't do them much justice. If you have more questions, you can email me at these email addresses. Thank you very much.
Thank you, Dr. Madarang. Due to the limitation in time, we may have one question from the audience. If you have any questions. We have a question from Dr. Ascalon.
I think yung ankle block isn't wasn't in your lecture isn't classified as novel, no? It's ano ba yung isang ano?
It's old block, but still useful.
Oo, kasi I think kasi sabi mo bakit naman kailangan i-ankle block if you can do ultrasound guided, femoral sciatic na combination. But I think yung kasi, I think others would still go, no? For ano naman to comment, it's not really a question. Personal ko lang to I don't know if, a lot of people would agree na kasi because of its proximity. Ang napansin ko lang, this is anecdotal, hindi naman siya kasi, based on my experience lang, it's, let's say, mga debridement of the plantar surface of the foot or yung dorsal surface because of the proximity of the block ng ankle block compared to the sciatic femoral. Medyo mas mabilis ata yung take niya. I don't know lang kung kung if this is true or
medyo mabilis yung
mas mabilis yung take no ankle block. So it's still, useful even if you know how to do the sciatic and the femoral. Tingin ko yung mas mabilis nagtitake because it's nearer to the site, lalo na yung mga debridement na diabetic foot.
Like for example, meron akong patient na for bunion surgery. So dito lang. So you don't need to block all of the 5 nerves. Ang kailangan mo lang is the tibial nerve and the deep peroneal nerve and the superficial peroneal nerve. You don't need to block the sural and the saphenous nerve. So one of the advantages of this is you get to choose which nerves yung talagang kailangan. Parang nagbablock ka ng For example, for hand surgeries, di mo naman kailangan i-block yung tatlong nerves, yung radial, ulnar, and medial. You can choose which one. The same principle here, you can choose which nerve ang kailangan lang talaga. One other, as I mentioned earlier, yung plantar mass, plantar wart. So I just block the deep peroneal nerve, and that's it. Yung mga iba, hindi ko na ginalaw.
Thank you.
Thank you, Ren.
Thank you, Dr. Madarang. So we were giving new blocks to use for analgesia of the lower extremities. And it's nice that Dr. Madarang also explained to us that there are basic blocks that we should know, but it's also nice that there are developments that can give better analgesia to our patient without compromising the motor strength of our patient. So while we know what is the basic blocks, it is also good that we find out or we discover new blocks that could help us. Okay? Thank you, Dr. Madarang. With that, we're going to not the last, but the second to the last topic of the afternoon. I know you are all full with knowledge and hopya. Ay, siopaw pala. So, sana kaya pa nating pakinggan ang susunod na topic for this afternoon. We will be discussing chronic pain, and we as regional anesthesiologists and anesthesiologists in general are all in the business of pain. Most of the time, however, we are called upon to manage acute pain, either preoperatively or postoperatively. Now, when we're called to manage the chronic pain of our patients, parang lost na tayo, no? And we are not that confident to manage the chronic pain problems of our patients. The easy way out is just to call the pain service, no? But it's not always possible, lalo na sa mga mahirap, when pain service is not accessible to some of the smaller hospitals. But we are all aware that acute and chronic pain are related. We just lack that confidence. And so here with us today to close the gaps in our knowledge is none other than the president of the Philippine Society of Pain, Dr. Dolma Santos. Her experience in pain management spans almost 30 years, starting with a residency in Philippine General Hospital, followed by fellowship in the same institution. As a pain specialist, advocate, and teacher, she conducted several seminars and trainings in pain management throughout the Philippines, from Mindanao to as far as the north in Baguio. Even during the pandemic did not stop her from sharing the knowledge in pain management. She headed several annual conventions of the Pain Society in the Philippines. She continuously developed her craft, attending international convention, meetings in Asia, Europe, and United States. She holds various positions in local and international society. She's president of the Pain Society, mentioned already, treasurer of the RASFIL, treasurer of Southeast Asian Society of Pain, member of the Technical Working Group of Palliative and Hospice Care Program, and as an academe, she holds a position in UP College of Medicine as Associate Clinical Professor. Ganda ng boses, sorry. So now, please welcome our very own Dr. Dolma Santos.
In pain ako sa... Okay, let's see. There's a clicker. You have a clicker? Okay. Good afternoon. So this is not yet the closing remarks, but you're close to getting there. So I am Dolma Santos. Thank you, Dr. Ann, for the kind introduction. You make us feel pain every time you speak. Okay, so this is actually closing the gaps. Okay, from the lecture is actually quite a tall order, but we'll try to give some points on that concept. And for this lecture, for this presentation, I don't have any disclosures. Is there a clicker? How does it work? Oops. Okay, so for the next 20 minutes or so, I'll try to keep, I have a timer, Dr. Amy. So I've been tasked to present an update on the magnitude of the chronic pain problem. We will also illustrate the gaps in pain care that contribute to the chronic pain problem and possible role of regional anesthesia, analgesia interventions in bridging these gaps. The presentation will also try to describe current regional anesthesia practices in chronic pain management and related evidence. Okay, so we always start off with definitions. Since 1979, we have maintained the same definition of pain until 2020 when we made a little, when IASP rather made some changes. So this time, pain is defined as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. The word that actually made the difference is the word resembling, okay? Not as contrasted to the previous word described. So this gives significance to those patients who are unable to do self-report. Okay, so even an experience or presentation, clinical presentation resembling that associated with actual potential tissue damage can be considered a pain experience. Now, since we're dealing with chronic pain, I'd like to also define chronic pain as that pain which persists or recurs lasting for more than 3 months. The ISP, or the International Association for the Study of Pain, to which the Pain Society of the Philippines belongs to as a local chapter, actually has included in the ICD-11 chronic pain as a disease. Okay, so there's chronic secondary pain, which has clear organic factors, versus the chronic primary pain, which is more difficult to explain from the organic aspect. Okay, so right now we can safely say that chronic pain is a disease. Okay. So to be able to properly or more adequately, appropriately rather, manage chronic pain, you should also be familiar with the pathomechanisms involved in pain treatment. So I think you are already familiar with the terms nociceptive pain, okay? So, and this has to do with the activation of nociceptors, your specialized nerve endings that respond to, that subserve noxious stimuli. And of course, there's neuropathic pain, okay? Neuropathic pain, I'm not sure if it's, okay. There's neuropathic pain that has to do with underlying disease or lesion of the somatosensory nervous system. So the main contrast with nociceptive and neuropathic pain is that the nociceptive pain has an intact somatosensory system. Now there is this third group, okay? We refer to as nociplastic, okay? It is not nociceptive pain, it is not neuropathic pain, but there is altered nociception. Okay, so these disease entities or pain syndromes are referred to, are described to have nociplastic mechanisms. Okay, so again, these are descriptors of pain, not diagnosis. Okay. Now for the burden, in the box, once the acute danger period has passed, the pain no longer becomes a necessity, but a burden, a disease unto itself, which is actually the rationale behind the ISP's initiative to establish chronic pain as a disease. So in contrast to acute pain, chronic pain contains little evolutionary benefit. So in viewing chronic pain as a disease, the patients and providers will shift their expectations from eliminating the problem, okay? So there is a more realistic perspective, okay? If they understand chronic pain as a disease, we are better able, the clinician and the patients are better able to establish common goals as far as controlling the pain and not fully eradicating the pain problem, which is more often than not a difficult goal to reach, okay? So chronic pain, again, is associated with unique, sometimes disease-specific alterations in the peripheral nervous system, okay? So there is, okay, a study, okay, done by the National Institutes of Health that shows new cases of chronic pain occurring more often among American adults than the new cases of several other common conditions, including diabetes, depression, even high blood pressure. So chronic pain prevalence is higher. So among people who have chronic pain, almost 2/3 still suffer from high impact chronic pain, and the prevalence rate is approximately 21% for just from your regular, quote-unquote, chronic pain, and 8% for high-impact chronic pain. Okay, so chronic pain is, the regular chronic pain is just that pain that persists, okay? Recurring, not every day, maybe every so often, for the past 3 months, while high-impact chronic pain is pain that is limiting, okay, as far as activities of daily living are concerned. Okay, so the links between the widespread burden of the chronic pain and the opioid epidemic stateside actually underscores the urgency to understand and address the issue of pain. In a more global perspective, what we use is disease burden. Okay, so this is indexed by the Global Burden of Disease Study under the auspices of the Institute for Health Metrics and Evaluation of the University of Washington. So this does not specifically include chronic pain, okay, as a condition. However, it includes conditions where pain is the primary symptom. That means migraine, headaches, neck pain, low back pain. So taken all together, these conditions account for 22.9% of the total years lived in disability worldwide. So this gives us an idea, okay, of the burden of chronic pain. So for the main reason why people seek medical care, we have 3 of the top 10 reasons being pain. So that is osteoarthritis, back pain, and headaches. And among the 4 leading causes of years lost to disability, we have back pain, musculoskeletal disorders, and neck pain, all chronic pain conditions. Prevalence rates of chronic pain vary between 11% and 40%, with a study by the U.S. Centers for Disease Control, CDC, and Prevention, estimating the point prevalence as 20.4%. It's like 1 in every 5, okay, individuals. Okay. So this is a diagram from, if I can read, Apkarian's paper, okay, in the Journal of Pain. So this has to do with a patient's course through the experience of pain. So this, we try to identify now. We have discussed the burden of pain, of chronic pain rather. Now we will try to identify the gaps in chronic pain care. So Dr. Apkarian's theory of chronic pain dynamics is described in this diagram. So healthy individuals from the far left, okay, your left, okay. Healthy individuals have varying levels of underlying risks. So they have predictors for developing chronic pain. These are contributed to by genetic and environmental predisposition. So if they suffer injury, they go into acute pain. If this acute pain continues for 2 to 3 months, so that's the subacute phase, a certain percentage will then transition to chronic pain. Okay, so this transition stage is marked by much emotional learning of the nervous system, sensitizing a person's nervous system, which we are all familiar with, the term sensitization, okay, to the sensory signals that give rise to pain and chronicity of pain. So essentially, the brain becomes hypersensitive, okay, to external noxious stimulus, even non-noxious stimulus, if the central nervous system is already hypersensitized. Okay. Now, an example of this evolution, okay, from acute pain to chronic pain is that pain that occurs after surgery. Chronic post-surgical pain, some people call it PPP, persistent post-surgical pain. So this is tissue injury lasting at least, 3 months after surgery, okay? So what are procedures known to transition to chronic post-surgical pain? Thank you. We have, I think you've seen this table before, thoracotomy, sternotomy, mastectomy, cholecystectomy, and inguinal hernia surgery, okay? So peripheral and central sensitization are considered pathophysiological mechanisms for the development of CPSP. Okay, let's see if it still works. Okay, so the gaps, where are the gaps? This is during the transitional phase between immediate, let's say the 2 weeks to 3 months after surgery. That is where you can develop chronic post-surgical pain. And of course, when it already has developed into chronic pain. So the gaps in care will be prevention, preventing transition to chronic pain, and the other one is controlling what is already existing, okay, chronic pain condition. Okay. So hopefully, if we're able to close these gaps, okay, we can have the spectrum go back to reasonably healthy, okay, patients. So healthy, pain experience, and then go back to recovery, okay, recover reasonably healthy lifestyle, okay, with recovery of function, okay. So having identified the gaps, what can we do? Okay, we try to go over best practices. Okay, so not just regional anesthesia alone. So identifying the mechanisms behind the pain can be challenging. So we, the earlier slides actually gave you pathomechanisms that you should be able to consider in and formulating your pain regimen, including your interventional pain management, okay? In 2019, the U.S. Department of Health actually published a document on pain management, best practices, and this is summarized in this panel. Okay, oops, this is not that one. Okay, so the best practices for pain management actually has to do with establishing a good treatment plan, appropriate treatment plan that has the diagnosis and measurable outcomes. It emphasizes individualized patient-centered approach, and of course, among the multidisciplinary modalities, it has among the interventions procedural pain management. Okay. So, but please note that it also tells us to use safer and less invasive treatments, including self-care. Okay, so it does not directly recommend interventional pain management. Okay, again, treatment should be tailored to the diagnosis and the patient. And of course, the biopsychosocial model down here has to be considered, okay, in formulating our pain management approach. Okay. So the indications, what are the indications for regional anesthesia techniques or interventional pain management for chronic pain? We have the following. It can be used for neuropathic pain, nociceptive pain. So these are the examples of the interventions. Even mixed pain disorders, nociplastic pain conditions. Okay, it can also be used as a diagnostic block on top of hopefully therapeutic block. Okay, just like what we do with epidural steroids, we advise the patient that it's diagnostic in as far as it helps us see if it works for the patient, if it can be repeated. Okay, that's why we always say diagnostic and hopefully therapeutic. And of course, to facilitate other treatments, patient has to go to rehab. It is too painful to move the extremity, then you can do your blocks. So who is the ideal candidate? So not all patients are for regional anesthesia pain intervention. So these are the recommendations. This is from the review of Stephen Cohen, okay, in 2021, published in Lancet. So those with a pathology consistent with the neuroanatomical pain distribution patterns, so your diagnosis should be clear, okay? Because you have to identify the target. This is regional anesthesia's targeted approach to pain management. So you should be clear as far as neuroanatomical pain distribution patterns are concerned. Check that there is no psychopathology, okay? And that the patient is without secondary gain and without lower degrees of disease burden. Okay, so check the baseline disability scores. Okay. So next. Also from the same review, I'm going to put on this slide some salient points. So this is one take-home concept that you should remember. Randomized studies have found that RA injections done as part of a multimodal approach are more effective than those done as standalone therapy. So it is recommended that your regional anesthesia technique as part of our pain management should be part of a multimodal regimen. Okay. Next. So another point from the review, guidelines recommend, everybody has seen intra-articular steroids done by orthopedic surgeons, also by rheumatologists. Intra-articular steroid injections for osteoarthritis that affect large and medium joints are recommended, although repeated injections have been shown to reduce cartilage volume. So, more from this. Now, some points on epidural steroid injections, which anesthesiologists commonly do. Okay, so note again, lumbar radicular pain from disc pathology. With regards to lumbar radicular pain from disc pathology, only small benefits in the short term as far as pain control and function have been noted compared with the placebo. Okay. However, for multiple injections, repeat injections, there have been noted that there can be long-term improvement. Now, the underlying diagnosis, rather, for which you do your epidural steroid injections can also be spinal stenosis, and aside from a herniated disc. So comparing the two, there is less evidence for spinal stenosis than for herniated disc. There is also low-quality evidence supporting ESI for non-radicular pain. So when we're doing assessments in the pain clinic, we also check for the quality of the pain. Okay, we check for radicular quality. Okay, so as far as neck pain is concerned, that related neck pain related to disc herniation, stenosis, discogenic pain, history of surgery, was found to have moderate evidence supports for performance of ESI. That is as far as long-term improvements in pain and function are concerned. Again, now for the approach to doing the ESI, randomized studies have found transforaminal epidural injections, okay, in contrast to what we usually do, translaminar. Okay, the transforaminal epidural injections to be more efficacious than interlaminar injections. However, this comes with greater risks. Oops, sorry. Now, another note from the same review has to do with radiofrequency ablation. Okay, so RFA, this is frequently made use of for non-neuropathic pain. So it includes facet, SI joint pain injections, even for knee osteoarthritis. Okay, we also use it for cervical and lumbar facet joints, as SI joint has been mentioned. And it's associated with modest pain relief in the long term. However, clinical outcomes are highly dependent on, again, careful patient selection and meticulous technique. The following two slides actually give you the block techniques for chronic pain. This is from COSE, Chronic Pain, an update of clinical practices and advances in chronic pain management. You will notice that most of the regional anesthesia blocks are also the same as those done for anesthesia management, anesthetic management. However, some of these, the ones that we use for neuralgia, gasturial ganglion block, occipital nerve block, the maxillary and mandibular nerve block for facial neuralgias, are more often than not more particular to the pain practitioner. Okay? So what else? The facet joint and medial branch block are also more often than not more specific to the pain practitioner. Okay, the others are all familiar as anesthesia techniques. So paravertebral, ESP, rhomboid intercostal, serratus plane. And the next list also has some familiar blocks. Okay, so TAP, ilioinguinal, iliohypogastric, genitofemoral, of course, the lower extremity blocks, and of course, the autonomic nerve blocks are also more commonly performed and used by the pain interventionist. So that's the stellate ganglion, the lumbar sympathetic block, celiac plexus block, particularly for pancreatic cancer. And for pelvic pain syndromes, we have the superior inferior hypogastric plexus block, impar ganglion block for perineal pain. Not in the list, we also have pudendal, the piriformis, some musculoskeletal blocks for chronic pain. So we mentioned earlier that there are two gaps. The one gap is controlling pain when chronic pain is already present, and the other gap is preventing transition to CPSP with RA. So these are just some notes from Geradrin, use of regional anesthesia to prevent the conversion from acute to chronic pain. So some salient points: after thoracotomy, perioperative regional analgesia does not seem to prevent CPSP. Okay, so this time after breast cancer surgery, paravertebral block might prevent CPSP intensity and impact on daily life up to 12 months, particularly in high catastrophizing patients. I think every now and then from morning up till now, we have had some mention of blocks that actually work, okay, for particular for particular procedures. So again, in knee arthroplasty, perioperative regional analgesia, or preoperative genicular nerve neuroablation do not prevent CPSP, although current studies present several bias. Okay, so we are unable to confirm, okay, if it actually offers benefit. The protective role of effective regional anesthesia and early pain relief in trauma patients, I think we will all agree, deserve further studies. So this is also the same as what was presented by Dr. Mel, okay, earlier for RA in the ER. Okay. So next, just a few more. So this is from current anesthesiology reports, role of regional anesthesia in the development of chronic pain. Again, a review. We'd like to bear in mind what was said by the RAPM editor first thing in the morning. We have to be, it depends on the systematic review. So I have put in the references also for your review later. And because, as he said, clinical decision-making are very much affected by whatever systematic reviews are put out there. Okay? So this has to do with the reduction of the risk of developing persistent post-surgical pain, okay, in breast cancer. So overall, the paravertebral block, as was also mentioned earlier in one presentation, was found to be the superior and favored regional anesthesia technique over conventional methods for the prevention of pain in this population of patients. I think you do a lot of that, paravertebral for breast, okay? So now this is from our RAPM, the ASTRA journal, okay? So acute pain management to prevent chronic post-surgical pain. This is also from 2021. So highlighted in the article is that regional anesthesia can reduce the risk of acute postoperative pain transitioning into a chronic and disabling affliction. So there is still that belief that RA is the answer to preventing transition of acute postoperative pain to CPSP. However, there is this note. Pharmacologic modalities and interventions of limited duration have not proved helpful in preventing CPSP. So think about single shot blocks, okay? But those of extended duration are more promising. So they're talking about long-acting local anesthetics and even maybe perineural catheters, prolonged delivery of your regional analgesia. Okay, I think that's the last, more or less. Yes, to summarize, again, regional anesthesia techniques present a valuable modality in closing the gaps in prevention and management of chronic pain. However, there is still much need for research so that we will be able to identify the optimal dosing, the frequency, the right patient, as well as the chronic pain syndrome for which a particular block will work and is associated with favorable outcomes as far as regional anesthesia and analgesia are concerned. So again, we stress that regional anesthesia works best as part of a multimodal analgesia regimen. And it is also recommended by the reviews that we should evaluate the long-term effects of regional anesthesia. Okay, thank you for your attention. Yeah, that's it. Yeah. Finish.
Thank you, Dr. Adoma. We still have, I don't think we have any more time for questions. But you may have one question for this speaker. She's very valuable, so you may want to ask one question. All right. Dr. Santos, it seems that we want to thank you for closing the gaps, but it seems that there are so many still open for studies, for experiences, and as the pain process itself evolves, there will be more questions and there will be more experiences to share. Thank you for your sharing. And sana mawala na to. Palakpakan natin ang ating sarili at matatapos na tayo sa ating program for today. But I guess we still have one last topic, video.
Before we let you go, Anna, as we approach the last few segments of our event, we have an insightful pre-recorded video presentation on human factors in communication in regional anesthesia by none other than Dr. Steve Coppins.
I have a Audico here somewhere. So, kindly bear with us. Last 10 minutes.
So I will start with a quote I usually use when I train new residents. The job is not always that difficult. It's the communication with surgeons, nursing personnel, and patients which actually poses the most challenge. Unfortunately, when working day in, day out in an environment like the OR, anesthetists get used to the high-stress environment and not always understand how anxious a patient is. When this knowledge of the anxiousness is lacking, it's almost impossible to anticipate. So failure to communicate is a cause for a lot of litigation and complaints and closed claims. And I would recommend you to read this very interesting article on a failure of communication, a patient story, and you'll get the link here. It's an absolute must read, and it's a story about a patient whose communication failed in an obstetric case. So, can you teach us to become better communicators? Yes and no. Some people do have a natural knack to be good at communicating. They are extrovert but also introspective, having a deep knowledge of their own strong points and weak points. Of course, not everybody has these abilities. However, there are a couple of things you can train. The best training is experience. Gaining experience will get you more confidence. The more confidence you get, the more it will radiate to patients. And this explains why I think that it's very important to have a regional team which is experienced and not casual blockers who only block once in a while. And secondly, there are also communicating courses you can follow. However, I'm quite unsure how effective these truly are, and I've followed a couple of them, and it helped me, but how much it can help you if you don't have a natural talent, I'm pretty unsure about. And when communicating with patients, you can certainly use 10 short tips and tricks, which I will give you here. If you use them, it will make a difference. And this is the next question. Those 10 tips and tricks are probably the main reason you are watching this podcast. So bullet point number 1, every patient is a family member. All patients should be treated as a good friend or a family member. It's an easy tip and trick, but it really helps you concentrate on what's important. How would you or your family would like to be treated, and how can you achieve that goal? Number 2, quickly assess patients' characteristics. When you enter a block room, you should be looking at a patient and immediately assess their status. Are they very anxious or not? Are they informal patients where you can have a really nice, easy, even a joke? Is the patient extremely defensive in his or her attitude? So every characteristic makes a set off of a preset communication templates go off and helps you. Okay, number 3, become a leader. That's an easy one. You need to be a leader. Why? Because patients want somebody who they can trust. When you enter a block room or an OR, you have to have this aura of control and helpfulness and a strong sense of I'm here for you, trust me. Okay, number 4, be wary when teaching blocks. Be very careful, not for everybody, not everybody works in a teaching hospital, but always be very careful when communicating when a resident is doing a block, not like saying, be careful for that, watch out, that's dangerous. Never do that. Take over when you feel it's unsafe and always only give positive feedback. So number 5, I think, continuous communication. So it just doesn't stop at a little bit of talk at the beginning and then just doing a block without talking anymore. Continuously, while you are performing your block, talk with the patient, and even after the block has set in the OR, talk with what a tourniquet does, that it can give some pressure, that they can feel touch and sensation, but will not feel pain. Very, very extremely important. So it's a continuous effort, so not just a 5-minute easy talk and then you're off. The next number, see and hear everything. Concentrated on a very difficult block? Well, yeah. But while you are concentrated, you should be hearing everything. Like, for instance, when you're doing thoracic epidural and you hear a decreased heart rate while you're performing a very difficult block, immediately ask the patient, are you feeling okay? Talk with your team, get atropine ready, maybe go to a lateral decubitus. So be there and see everything. So the next one, team communication, very important. We've been talking about patients, but it's not only about the patients, right? Be a champion, be the T in team, be a hero. Your nurse personnel will be so happy when you can lead a team and inspire them. So next one, safe and quiet environment, extremely important. No patient who is anxious wants to be blocked while in the next room people are cracking jokes and laughing right next door. So make sure that the patient is in a safe and quiet environment. And the next one is very closely related. So remove distractions. I always get my phone out of the way when I do a block because patients will say, are you 100% giving your attention here when you take like 3 calls while you're doing the block? No, so make sure you remove all distractions. And the last one is very, very dear to me, closed loop communications. I never want to see any drug errors. And, you know, talking with your personnel when getting a drug, when a test dose or getting ropivacaine, always use closed loop communication so no drug errors are possible. Thank you very much for these 10 tips and tricks. If you use them, you will be a much better communicator. Most of them we've already discussed in our tips and tricks. However, there are 3 specific cases: failure, complications, and mistakes, which should still be emphasized. Failure, when a block fails, and it does sometimes, it's very important to stop, communicate and explain that we can do something else. We can give other payment modality and offer a multimodal approach and explain why the block has failed. So it's extremely important to communicate and stop. Stop doing a block when it's not working. Your ego can recover, however, bodily harm caused by persistence may not. Secondly, when facing complications, be very active in communication. Do not avoid contact at any moment and offer multiple contacts if a patient is in need. And lastly, when mistakes have been made, like drug errors or wrong-sided blocks, it is important to always completely have open disclosure. Never try to conceal it. Apologize, be humble, explain steps that the department will take in order to avoid things like this again. So over to the last question, is sedation a better option? So it's definitely not a pro-con debate on whether communicating or sedation is better. They both have their role to play. Sedation should never be used as an alternative for good communication skills. However, it should be used as an additive when communication skills alone is not enough. And I would use that in extremely anxious patients where just talking is just not cutting it. Thank you.
In regional anesthesias, communication, isedate na lang, no? But this should not be the case. So the next slide, we see some reactions, anesthesiologists and the art of communication. Is there really such a thing as an anesthesiologist who can really communicate? And these are the memes that we found regarding communication among anesthesiologists. Next slide. I like people under general anesthesia. But we're not doing general anesthesia anymore. We're doing regional anesthesia. Hence, next slide, when they are sedated. So like what Dr. Coppen said, we should use sedation as a last resort. Nothing can substitute to better communication and, of course, a good technique. And lastly, I'm going to give you a mild sedation to counteract your really annoying questions. No? Patients are not annoying. They need to know. They have a right to know. No? Next. I have a very particular set of skills, and communication is not one of them. This should change, and communication should be a part of regional anesthesia. So in a study, next, patients' anxiety in the OR is at 25% upon entering the OR. No? It's the environment causes the anxiety, and 35% at induction. Pag sinabi mong tutusok na po ako, tumaas ng 10%. No? So anxiety in the operating theater, this is from a study, and the good news is that communication reduces anxiety by 49% with information and education, and 55% when you give them the opportunity to ask questions. So there is really hope, and this is where our role should be. Thank you, and that's ending our discussions for the day. Let's give ourselves a round of applause. Thank you.
Thank you so much, Dr. Consuelo, and of course, Dr. Steve Coppen, for preparing and sharing that very informative presentation with us here tonight.
And a very humorous one as well,
Yeah.
right? I also love people, especially when they're sedated. So as we draw towards the conclusion of our event, we have an exciting opportunity for those eager to dive into hands-on learning. So don't miss this hands-on ultrasound workshop on the 6th floor, featuring upper extremity, lower extremity, and truncal blocks. Our experienced facilitators, Dr. Samar, Dr. Baryon, and Dr. Nogay, are ready to guide you through these invaluable sessions.
To officially close our event, please join me in welcoming back Dr. Maria Dolma Gude Santos, RASFIL President, who will deliver her closing remarks. Soft close.
Okay. So no longer closing the gaps. we soft close, okay? Because we still have the workshop after this. So as we draw to close to the end of our first World RA Day celebration, and RASPHIL's first, that's the Regional Anesthesia Society of the Philippines' first, but hopefully not the last, Tri-City Conference, I would like to acknowledge the hard work and commitment of our 3 city coordinators. So along with their organizing teams. So there's Dr. Numeriano Samar Jr. for Luzon, Dr. Lily Hinco for Visayas, Dr. Dalia Arancel for Mindanao, and she's also the overall lead for this activity. This activity has truly been a coming together, not just globally but locally, of colleagues who share the same interest in regional anesthesia. The not so young and the really young ones. We have the learned and the learners, but these roles easily switch as new knowledge and skills in RA are established. So again, as practitioners of regional anesthesia, with or without the use of ultrasound guidance, okay, I hope you have taken this opportunity to join the society. You are most welcome to share your expertise and, of course, enjoy the camaraderie. I will take this off. Sabi ko, ba't ako hinihingal? May mask pala ako. Okay, so 2024, again, for RASPHIL will be geared towards CME as we try to bridge the gaps in RA educations and skills training. So not just for our residents and fellows, but also for those who are already consultants. RASPHIL also supports the PBA initiative to standardize training programs as well as RA practice. Even if it may be true that not all can be RA specialists, quote unquote, we can still work towards making every Filipino anesthesiologist a reliable and safe RA practitioner, making RA and its benefits accessible to our Filipino patients. In each of the 3 cities, we have received generous support from our industry partners, whose commitment, even at short notice, is very much appreciated. Everything started just in November, okay, and we were able to get all this support. Please receive our gratitude as well as our anticipation of having all of you once again during the 2024 countrywide Regional Anesthesia CME Caravan. Last but definitely not the least, a big thank you to Gentri Med Center and its staff for the warm welcome and kind accommodation. Have a restful weekend. Thank you.
Thank you, Doctora. What an inspiring message. In conclusion to this event, we want to express our gratitude to all the speakers, moderators, and of course, you, the participants, who have contributed to the richness of the discussions today. We look forward to carrying these insights forward in our practices, and maybe also invite everyone for a group photo here in front before you conclude today's event. And please don't leave, there's still a raffle. Remember that raffle for that overnight hotel stay and the workshops later. Everyone, please
So
come
may
on
we
stage.
invite everyone to please join us up on stage for a group photo. It's our reward for staying the entire day here and learning a lot about regional anesthesia and pain medicine as we celebrate the first World Day of Regional Anesthesia and Pain Medicine. Again, please include it in your social media posts with the hashtag WDRAPM so they know that we're celebrating it in 4 areas in the Philippines. We have Makati, and of course, Gentri City, Bacolod City, and Davao City. For the accommodations that will be raffled out after our photo. Ayan. Not yet.
Para magstay lahat. Only those present
So,
will be able
may
to
we
win.
invite everyone to please join us up on stage? Or some can stay downstairs.
Combination na lang daw.
And then maybe some of the speakers, the officers of RASFIL, and of course PSA Southern Tagalog chapter, who are our co-organizers for today's event, to please join us on stage. Our guests, our panelists, of course, we love PSA STC for all your support. Diba, PSA STC is a Hall of Famer, na chapter. And we know why, diba? Baka mahirap mag-share. Dr. Samar, Dr. Genuino, thank you very much po. Okay. And since COVID-19 is no longer a public health emergency, we can remove our masks. Joke lang. Thank you very much.
We still have a raffle to draw.
Yes, but of course, before we go to the raffle, we'd like to ask everyone to please return to their seats. And at this point, as Secretary of the Regional Anesthesia Society of the Philippines, we would like to really invite everyone who's not yet a member of RASFIL to please join us. If you want to join us and be a member of this community of regional anesthesia enthusiasts, do give us an email. Do leave us an email. It's rasfils@gmail.com. Or talk to any of your officers and member of the board of directors. And you can send your inquiries also to Dr. Rochelle if you want to be a member of PSA STC as well as RASFIL. Dr. Rochelle, do you have any message for our delegates? An announcement.
Hello, good afternoon. I'm Dr. Rochelle Flor F. Civiliano, incoming president of the Philippine Society of Anesthesiologists, Southern Tagalog Chapter. We'll be having our induction on the February 18th sa Lipa City, Palazzo Antonio. If you're not yet a member and your area of practice or you're living within the area of the Southern Tagalog, which is Cavite, Laguna, Batangas, Quezon, and Mimaropa, you can approach us for your, if you want to be a member of a Hall of Famer. Presently, the champion during the fellowship. Yung Aladdin kami yon. So, thank you. We have a series and array of activities from civic, charity, and learning activities. So if you want to be a member, approach any of our coordinators within the area po. Cavite is Dr. Castillo. And yon. So thank you. Thank you po.
Thank you, Dr. Rochelle. Again, be a member of PSA STC chapter. Join that very wonderful and excellent group of individuals. Hindi lang world-class anesthesiologists, world-class performers then. And of course, if you're a regional anesthesia enthusiast or a wannabe a regionalist in the future, a specialist, come join us in RASFIL. We're a happy group, we're a happy bunch, and just leave us a message. You can talk to any of the officers and members of the board of directors. No, they are also. With us, again, are the officers who are with us today. Our president, of course, Dr. Dolma Santos. I'm the secretary. Dr. June Samars, the treasurer. Members of the board of directors who are with us also now are Dr. Ampoy Barion and Dr. Michael Madara, who might have left already. Okay, so now that we are all we're mostly settled down, I guess we'll now like to thank our generous sponsor. So, like what Dr. Santos told us, we only planned this because we got the call from Estra just last November, and yet our industry partners took on the challenge with us, along with PSA STC in holding this event. So we'd like to thank Wen's Pharma, Fresenius Kabi, Taisho Pharmaceuticals Philippines Incorporated, Janmore Medical Supplies, Gison, MG Prime Pharmaceutical Incorporated, Prime Medics, Excel Life Med Trading, Toyo AdTech Health Corporation, the Menarini Group, Aspen, Excel Farm, East Asia Medical Company Corporation, the Magayami Industrial Gas Products Corporation, Endure, the Cathay Drug Company, Quick Cross, VG Polaris Diagnostic and Laboratory Supplies Incorporated, and of course, I would like to thank the PSA Southern Tagalog chapter, the Gentri Medical Center and Hospital Incorporated, as well as the Hospital ng Maynila Medical Center Department of Anesthesiology. Thank you very much. A round of applause, please, for all our industry partners, as well as our society partners and hospital partner for today's event. Okay.
Finally, the raffle.
To announce me winning, then I'm kidding.
This is courtesy of Wentz Pharma. They're sponsoring an overnight stay for 2 in Acacia Hotel Alabang with free breakfast for 2 and use of hotel amenities. Okay, let's spin the wheel.
We have the, kailangan ba present? What do you think? Yes.
Present, okay.
Agree.
Very good.
Kaya lang wala ako dyan eh. Wala kami dyan.
Sayang, nakita ko pa naman yung pangalan ni.
Maria Raisa Carla Opulencia.
Congratulations!
1, 2! Ayaw. Congratulations. See? Staying here really pays off. Congratulations.
Yes. Kindly claim your a picture. Yes, please come up front and have a photo with us as proof of winning.
You may claim your prize from Palawan. Sure.
Congratulations.
Congratulations. Ang swerte naman. Acceptance speech. Sino yung kasama mo raw for the overnight stay? Ay, love it, manifesting. May we invite you to join us also po on the stage for the photo. Congratulations.
Na-picturean na po ba siya?
Okay, picture.
Picture daw, Dr. Samar. Yan. We just heard that we are going to give away 10 more prizes. Last 10 na madadraw. If you're here, you can claim it. If not, forfeited na raw. Okay? Please spin the wheel 10 more times.
Okay, can we have the Wheel of Fortune? The Wheel of Names, rather.
Okay.
Okay, let's spin the wheel.
Spin the wheel.
Can we have the wheel again? All
Here
right.
we are.
Ay,
Ay, wala ulit.
it disappeared.
Nagpapakipot pa.
What are we giving away po for now? Oh,
One bag of everything.
Oh, wow.
Ano na siya? Hindi na isa-isang item. Loot bag na siya.
Loot bag na
Okay,
siya.
very nice. Mine na to. Ay, joke lang.
okay. Wait, may we have the wheel of names? It's coming, don't worry.
Yes.
Pakidagdag naman yung names
Pinapataka.
namin.
Oo nga, lagyan nyo naman yung names namin.
Oo, kanina pa kaming umaga dito. Grabe naman kayo. Siso, Carl, Matthew. Pwedeng hiwa-hiwalay. Carl, Matthew, Ko, si, Su. Pwede.
More chances of winning. Okay, Doctor. Okay, excited na po kami mamigay.
Opo, yung wheel na lang po.
Oh, here we are now. Are we ready? Kindly click to spin.
Okay, so let's spin the wheel. Find out who our first winner of 10 loot bags, courtesy of Gentri Medical Center. Ayan na.
Oh, I see my name. Sayang, nalampasan.
Oh my God.
Panalondong Jonah. Please claim. Are you here?
Jonaima Panalondong. Doktora Jonaima.
She's not
1.
here? Ha? Nandito siya?
Nandito siya. Parang wala. Char!
Nasaan siya?
Nandito siya, working behind
Working behind the scenes.
So
Okay.
congratulations, Janaima.
Congratulations. Next one. 9 more.
We have our second winner,
Reyes Patrick.
Patrick Leonard Reyes. Grabe, no, nakakatakot.
Wala po siya.
Pag-
Spin again.
Sana sumisigaw.
Atienza Jose.
Jose Lorenzo Atienza.
Jose Lorenzo
Nasa
is
taas.
here.
Nasa
Upstairs.
taas daw.
Yes, working also.
So he's working for us for the workshop. So we already have 2 winners. Sana may nagsusulat ng pangalan nila. Hindi ganun kagaling ang memory ko.
Marie Grace Canta.
Marie Grace
Wala.
Canta. Wala?
Sige, spin again.
Wala. Given the chance, you missed your chance.
Hayaan mo, Carl. Malapit lang tayo. Ito
Wala
na.
pa rin yung pangalan natin, friend. Ayan
Andyan
na.
tayo.
Oh my God.
Muntik ng ikaw. Midel.
Oh my
Athena.
God. Ini-edging nyo ko. Edging? Edging?
Wholesome tayo dito.
Ay, bakit alam mo yan? Ayan na. Ayan na. Our 4th winner,
Castillo Abad.
Deborah Castillo Aban. Ilista yung mga pangalan yan. Kailangan members yan ng Rasfil.
Congratulations.
Hindi, member si Doktora. Natatandaan ko ang name
Ang
niya.
ating loot bag. Sabi nila, buti na lang hindi kami nanalo kanina. Oh, free registration na raw.
Ayan.
Ayun. Oh, if you register today to become a Rasfil member, it is free today.
Dr. Regine Aguilar. Wala.
Mali.
Oh no. Sayang, sayang.
Wala.
Oh my God, eto na. Wala yan. Si Juan Martin Arcilia.
Juan Martin,
Wala.
wala daw.
Okay, kaibigan ko yan. Wala yan. Wala.
Okay.
Wala. Ay!
Fritz Dalida.
Fritz Gerald
Wala
Dalida.
daw.
Wala
Wala
rin.
daw.
Oh my God.
Palitan natin. Baka
Oh
biglang
my God,
manalo.
ito na. Ito na.
Baka nandito na siya.
Nararamdaman ko na Carl Siso to. Manifesting.
Ay! Ayun na nga! Luto! Luto!
Well, wala tayong magagawa. I'd like to thank the Academy.
One more. Mukhang ito talaga yung gusto ipamigay.
Mark Edward Olan. Nasa
Nasa
taas.
taas. Congratulations.
Dahil ayoko ng pula,
Oh.
sa kanya yon.
Ibalik natin sa dati. Mukhang umaano tayo. Agne.
Mario Cocoba Jr. Congratulations, Doc. Diba, it really pays off to stay the entire day. Oh, ano naman yung ano?
Congratulations po.
Ano?
Ayan.
Edgar Allan Ambida. Wala.
Mukhang ayaw ipamigay yung mga
Wala
ganito,
si
no?
Dr. Ambida.
Okay.
Agape de Ocampo, Doktor.
Congratulations.
O, di ba? Ang ganda ng pangalan ni Doktora. Agape Faith.
Magliliwanag ang
Congratulations.
buhay mo, Doktora. Oh, yes. Filipinos love karaoke.
Sofia Clareta Tolentino.
Sofia Tolentino, wala.
Wala. Absentee.
Karaoke in the car. Akin na lang.
Alisa Talosig.
Wala pa rin. Wala pa rin. Next one.
Hannah
Del
Del
Carmen, our karaoke queen of the day.
Ayan na.
Kakantahan na kayo sa OR.
Pwede nang mag-duet. Loot bag again. Obelia Zapanta.
Wala daw. Next one. Sandra Yao.
Sandra Teresita Yao. Doktora, congratulations po. You have a loot bag from
Wow.
Gentri Medical Center.
Ang daming laman.
It has everything.
Next one.
Ang saya naman dito sa Gentri.
Oo nga.
Walang ganito sa Makati.
Sana araw-araw Pasko. Agnes Karumpong.
Makati.
Nasa Makati. Sorry.
Agnes Karungkong. Kasi nahati na ang
Jennifer
Makati.
Abago.
Yay! Jennifer Abago. Nasa taas.
Ayan, nandyan siya.
Nandito
Cleaning
siya?
now?
Nandito ba siya o nasa taas? Nasa taas. Okay, tatabi natin para kay Doktora.
Para kay Doc Jennifer.
Glennis, no? Glennis Kane, no kumfong. Wala.
Wala rin.
Wala.
Next.
Baka nasa Bacolod. Char.
Rona Sibal.
Dr. Rona Sibal.
Wala po.
Wala
Okay,
rin.
next one.
Shake it, move it, yeah, yeah. Oh my!
Dora Anita So.
Dr. Anita So.
No more, no more. Who wants from Dr. Anita?
Sino ba ang favorite resident
Oo,
graduate ni Doktora
Sino
So?
favorite mo?
I spin the wheel na lang, Doktora. Sure po.
Daw
Okay
mo
po.
ulit.
Thank you, Doktora, for your generosity. Buti pa si Doktora generous. Ako hindi. Angelo Benedictan.
Wala ba si Angelo?
Wala si Angelo.
Negative. May chance ka pa.
Lumalaki na yung spaces, oh.
Verhel Habito. Upstairs or here?
Here.
Here.
He's here. Congratulations, Dr. Habito.
Verhel. Spin again. Congratulations, Dr. Maria Opulencia.
Dr. Opulencia, oh, pwede na. Kasi major prize. Ibabalik mo daw sa amin yun. Ay, hindi, loko na.
Ipapalit mo ba?
Dr. John Marie Dita. Wow, sarapan. Congratulations.
Okay, yung next daw naman nanalo. Herschel ulit tayo.
Oh.
Yes, yes.
Oo.
So exciting.
Or dapat ba pink at saka red?
Reynaldo Dizon.
Rinaldo Dizon. Oh, ito na.
Reynaldo Dizon.
Magkakalaman na. Pink o yung blue?
Pink o blue? Blue, pink, pink. Pink nga.
Pink or blue? Pwede ka mamili.
Pink daw, pink.
Pink? Talaga? Lenny?
Okay, okay. Next one. Okay, last two.
Dr.
Congratulations, Leonor Kagiat.
Kagiat.
Negative.
Wala
Next
daw.
one.
Negative. Cannot be borrow 1 from 3. Ay! Oh no. Ernesto Negrillo
Wala
Jr.
rin. Wala rin daw.
Wala din.
Negative.
Okay. Negative.
Remove.
Malapit ka na, partner.
Oo nga.
Manifesting.
Sunod na
Sa'yo yung
Herschel.
bag. Sabi sa... Ay, oh my
Ayaw
God.
talaga sa...
Dr. Kirk Benson Nopre.
Nopre.
Wala rin.
One more.
Ayoko
Oh my
na.
God!
Jan Obispo. Wala rin?
Wala rin.
Wala rin. Jessa Aquino. Wala rin.
Wala rin.
Sino na lang wala pang premyo dyan?
Sino pang hindi na nanalo? Taas ang
Sino
kamay!
Sino pa? Unahan! Kung sino mauna.
Nasa iyo na, friend. Sa'yo na yan. Or yung Herschel bag ba rin tayo?
Oo, yung Herschel bag. Akin na yun, joke.
Dr.
Pakisabi
Joanne
kay
Arcilia.
Joanne, sayang.
Wala rin. Mga Arcilia talaga, nawawala.
Next.
Dr. Grace de la Cruz.
Grace de la
Wala
Cruz,
rin.
wala rin.
Okay.
Nako, nakakainip na to.
Malapit na, malapit na.
Malapit
Konti
na
na
may
lang.
manalo. Ayan na! Congratulations! Finally! At ito na po yung last one for me. Just kidding. Last one, your Herschel bag. Ang ganda, denim yung color.
Yes. Ay, wala yan.
Jennifer Pasco.
Wala. Wala,
Wala
no?
daw.
Wala. Wala si Jen. Nag-duty pa yan, I'm sure.
Ayun na, ayun na, ayun na. Angelica Lorin.
Wala rin.
Malapit na, guys.
Riza, parang wala ka rin dito.
Akin na to.
Ayan na!
Akin nga siya.
Thank you for joining us, Paul. Of course, again, thank you to the generosity of Gentri Medical Center. And as a reminder, our event is not yet done. We would like to request everyone to make their way to the sixth
Sixth
floor.
floor po tayo. Meron po tayong scanning para ma-practice ang inaral today.
Yes.
Okay?
So this has been the first World Day of Regional Anesthesia and Pain Medicine. I'm one of your hosts. I'm Dr. Carl Sisu.
I'm Dr. Marika Biag, and we wish you all good night.
Good evening and happy World Day of Regional Anesthesia and Pain Medicine. Join Raspil!
Thank you, Dr. Genuino, Jerimo. Thank you, Sherry Buwan. Siya ho ang overall coordinator. Thank you very much. And Hospital ng Maynila residents, thank you very much.